Hello guys, so now we start with our biomechanics course. Actually, we start with the basics. I know that for most of you this is something very simple and you must know everything or almost everything regarding this, the first part of our class at least. But I think it's important for us to create now just biomechanic language, something that we can communicate during our course. So this is important. If you want to accelerate this, you can do that, or if you want to skip to another part of our course, it's okay. But keep in mind that this is important because from now on, we're going to communicate using this kind of language. Vectors, for example, are very important for us to communicate, for us to establish points that are important for our biomechanics. So we start with the basics and then we go on and on and on, increasing our knowledge in biomechanics from now to the end, from now to the vectors and the moments and everything, and from now to the clinical use of this kind of concepts, okay? So, biomechanics in orthodontics, let's talk about force. A force is something that makes or tends to cause a change in the motion or shape of an object or body. In other words, force causes an object to accelerate or decelerate. It is measured in newtons, but in orthodontics, as you know, we just communicate in grams. We always use grams for that, even though we know that Newton is the right way to address the forces in the physics, okay? But now we are going to say grams from now on because this is how biomechanically we speak of forces. So let's move on. We are talking about the magnitude of the force, the direction, the point of application, line of action of the force, and sense of the force. So those things are present in our vectors, and we are going to use this kind of scale for understanding and for representing the vectors in one system of force in orthodontics. Meaning, I'm going to go to do a length. I'm going to go to arbitrary a length because from there I'm going to represent other forces in our system. If I'm using 50 grams for 5 millimeters or 5 centimeters of length, if I want to increase that for 100 grams, I need to double the length of the vector because I'm using the same scale for that. And this is what is important for us. The length of the vectors is proportional to the magnitude of the force. The actual length is arbitrary, as I told you before, and depending on the scale that we are using. But all forces in a diagram, they must be on the same scale, meaning I have to keep the scale to represent other forces present in my diagram. So in common sense world, let's say if we are applying a force, we know that when we apply a higher force, a higher magnitude of force, I'm having a different outcome for that. For example, I'm pushing something. If I apply more force, I can go with that thing, that body in a longer distance, for example. Here we are seeing a beautiful score, a beautiful goal by Leo Messi. And if we apply a higher force in our kick, we are going to have a more accelerated ball going to the goal, okay? But it's not the same thing with biomechanics, with orthodontics, because we are not applying a force in a free body. We are applying a force in a restrained body, in a teeth, in a group of teeth, in a tooth. So they are surrounded by periodontal ligament, by the bone, by the gingival attachment and everything. So we know that when we apply more force in orthodontics, the objective here is probably not being achieved because more force doesn't represent in biomechanics, in the force we apply to the teeth, more movement, because those teeth are restrained, and the ligament, the periodontal ligament, it's something that has to be respected biologically. Meaning, I apply more force, I'm not having that cascade of events triggered when we apply a low force to that structure. We may block our movement. We're not talking about this today because this is not the objective of our course, to explain everything about biology of the movement, the movement in orthodontics. But we are from now on just speaking that, understanding that you know that we don't need to apply much force in orthodontics. It's not like a free body, it's not like a ball. It's something that we need to respect the biology present in the periodontal ligament, okay? So from now on, I'm not explaining more about much force and about the biological events that are triggered when we apply much that higher force or lower force, because we imply that you understand that, okay? So let's move on. So if we have a force applied for a certain period of time, we will have that events occurring inside the periodontal ligament, meaning we are going to have bone resorption, not root resorption, bone resorption in one side and bone formation in the other side. So this is what happens in orthodontics. A very, very quick summary of what happens, but I think you know that, I'm sure you know that. The direction of the force, it's important for us. Of course it is, because we apply a force in certain angulation to a determined structure. For example, if I use a fixed axis to represent my point of application of force and direction of the force, I may go from there to the resultants of the force. Meaning, I'm using, for example, an elastic for doing the retraction of anterior teeth. I need to understand all the forces present there. I'm not having just the force that I want, which is mesial distal displacement of those teeth, but I have other forces, other resultants that I may consider, because they have some effect on the body and have some effect on everything that I'm applying. Meaning, I'm doing that force, I want to have the distalization of the upper arch, but there are other forces present in the system that may jeopardize the outcome or may help me. I don't know what I want. So this is something that I have to keep in mind. The direction of the force, the angulation of that line of action of the force in relation to some kind of reference. In this case, for example, the occlusal plane. We use the occlusal plane as a reference because it's a good horizontal reference and it's close to the point of application that I'm using. So the center of the line of action of the force and this angulation that we have may have some kind of bad or good side effects in our mechanics, okay? Point of application, line of action, and sense, we can see that in our vectors. I'm applying the force to distalize this tooth, for example, and this point of application, it's obviously almost always in the center of the crown. And in this kind of situation, I need to understand the side effects or the other forces or the resultant of the system, the quality of the movement. I've told you before, that's not the amount of the movement that we are going to apply more or less force. It's more about the quality of the movement. Is this a translatory movement? Is this an inclination, a tipping, uncontrolled or controlled tipping? Everything is about this vector, the point of application, the line of action of the force, and everything. I'm so sorry to go like very speed here with this very fast here, but I know this is something for the majority is very, very well known. So because of that, I'm going a little bit more faster, okay? So point of application, I can change the point of application, and we are going to see that sometimes we have more than one point of application of the force. I may have just one point of application with two forces also. So everything needs to be measured, needs to be understood for us to have the best outcome for that. Hello guys, so let's move on in our course here. Now we are going to address the center of gravity, which is very important for us. As we know, when I apply a kind of force, given the center of resistance, the distance from the center of resistance to the line of action, we know, and we will address this in a few slides ahead, but we know that we are going to have some differences in movements depending on this relationship between the line of action of the force and the center of resistance, okay? So the center of gravity, before talking about the center of resistance itself, it's in physics an imaginary point in a body of matter where, for convenience, in certain calculations, the total weight of the body may be thought to be concentrated, meaning so all forces are annihilated, are cancelled in that body. This is the point in which if I apply a force going through it, that body goes like a translatory movement. I know I'm jumping a little bit ahead in this concept, but I know you know that. And we will explain in a few slides. But this is important. This point is very important for us as orthodontists because we are applying force against some bodies, against a tooth, a group of teeth. We are applying force with the different line of action. So this is important for us to understand, okay? Let's move on. For example, I'm using here this baseball bat for this kind of a representation of the line of action and the center of gravity. If I'm applying the force in the exact or through the exact center of gravity of this body, in this case, this bat, this movement of the bat is going to be a translatory movement. A translation will occur in which all points of this body are going to go in the same direction, the same sense, and with the same magnitude. All those points are going up. The center of the center of gravity is going up, and all those points, the neighboring points, are also going up. But what happens when I change the point of application and I change in relation to this, the line of action of the force that I'm applying here? What's going to happen in this situation? The center of gravity still goes up, but now the way the body is going to move is not all the body, all the points in the same direction. As you can see here, we're going up with the center of gravity, but we are applying another thing here, which is a tendency to rotate that body, in this case this bat, and we are going to learn about this in another session of our course, but we know that this is what happens in orthodontics. When we apply a force outside the center, in this case, the center of resistance, I'm going further here in our knowledge, but in the center of resistance, this movement that is related to this line of action is not going to be a movement of a translation of that body. We know this, and this is the same thing here. And as we know, we are not applying a force in a tooth outside in the space free of everything. This tooth or a group of teeth, they are restrained by the periodontal ligament, by the bone, by the gingival attachment and everything. So this is different for us because we are not applying this force in that exact point that is supposed to be the center of gravity, because this body is not free, it is restrained. So in this situation, if we apply the force in that same center of gravity that we saw before, is it going to have the same outcome? Of course not. The center of gravity now is closer to the hand. We know that by nature, we know that if we apply a force like closer to that point that we are restraining that body, we tend to move like in a more translatory movement. We know that. So we are moving the hand and the finger closer to that point of restriction, okay? And now we can have a different situation, a different relationship between the center of gravity. In this case, we are not calling it anymore the center of gravity, but something different. The center of resistance, because as I told you before, this is not free. This is not a free body. It's restrained, and we call it the center of resistance, and we know by calculation of some articles before that is located in a different position from its center of gravity, okay, or center of mass. And in a single tooth with good periodontal condition, so this is something that we have to keep in mind. We can't think that we are applying like a formula, like a cake recipe for all the teeth that are moving, because we have differences in the size of the root and the periodontal ligament, in the bone height, in everything, so, and bone density. So we can start from something. We start from something that we know that is the average, but we have to understand that we need to calculate, we need to see that movement that we want to apply, because we're going to learn how to calculate this movement. We need to understand that we are not doing that for every teeth that we apply in the force the same way. We need to do the movement, we need to anticipate the movement, we need to plan for the movement we want, but it's important that we need to have that in mind, that all times that a patient come back to our office, we have to reassess that, to understand, is it the movement that I really want that's going on here, or I have to do some kind of adjustment to move the way I want, the way I'm planning that to happen. You understand that? So I have to keep in mind some points to start with. I know that for a single tooth with good periodontal condition, the center of resistance is located between the coronal third and the middle third of the root. This is something that for average it will work. So I have to start at some point. This is the point in which I'm going to start. But we need to do all the adjustments needed during the treatment, during the movement that it's occurring, okay? So this is important, because we know that we have some situations in which our patient present a periodontal loss, bone loss. So is it the same center of resistance? No, it's not. It goes up. It goes up inside the bone. So if I want to apply the force, a single force at this center of resistance of teeth with periodontal losses, I need to go up with this force. If I'm applying, for example, a high hook for that, I have to go higher with this hook, with the tip of this hook. So in this case, if I want to apply, and yes, especially in periodontal problems, in patients with periodontal problems, I want to apply less force and the force closer to the center of resistance. We will see that in this course, okay? So here we have this different condition, and I need to calculate the whole time, all the time, the center of resistance related to the center of the center of resistance related to the line of action of the force I'm applying in all the movements in a three-dimensional view. Now, for example, I'm applying here upwards this force. I have to calculate, I have to understand the relationship between this kind of force I'm applying here with the center of resistance, which in some situations, as it's depicted here, is far from the position that comparing to a healthy periodontal status, okay? This is important, and we are going to focus on this point and many aspects of our biomechanics course, okay? So we're moving on. The center of resistance, for example, for a multi-rooted tooth, is likely to be between the roots 1 or 2 millimeters apical to the furcation, okay? So this is another thing that is related to a healthy periodontal status, to a healthy periodontal tooth, okay? And in this case, if we apply a force close to the center of resistance, we used that a lot before in the past, using, for example, a extraoral headgear for that, an extraoral force for that. We used to calibrate the line of action of the force, the elastic, to try to pass through the center of resistance of this tooth or those teeth, both molars. So we needed that. Visually speaking, it was very difficult, but we tried to do that before, using the line of action as a reference to pass through, or if I wanted to correct the angulation of those teeth, I would go up or down, meaning trying to put the line of action of the force in the right position to have the right movement that I wanted. So for that, I used this kind of reference, meaning, again, I'm using a point that is an average point. We need to understand that we have differences related to many aspects of the teeth or tooth, like, as I told you before, the root area, the periodontal status, and the bone density, and many things related to that, because we are not applying a force in a free body, as I told you since the beginning. Okay, moving on. Think the center of resistance as a point that needs to be evaluated three-dimensionally, meaning I'm not just using this force in a lateral view. I have to understand that. Let's make another example of that. I'm applying the force buccally, and I'm using the center of rotation, the center of resistance in this lateral view. But as I'm applying the force buccal to the center of resistance in an occlusal view or in a frontal view, I'm going to generate some kind of resultant forces, not just looking at this view, but looking of the occlusal aspect and the coronal cut that we made this way. We have to understand that that force I'm applying, that force will have another kind of resultant related to these other views. So not just one view, because we are not applying a force against a bidimensional object, is a three-dimensional object. So we need to anticipate the movements that we are applying, that we are having when I use other views for assessing that, for evaluating that. Okay, we need to understand these other views in all situations. Okay, so when I'm using a group of teeth, I need to understand again what is the center of resistance that I may use for that body. If I'm using a rigid ligation for that, because it's different from, for example, here, if I'm considering to be the six teeth, or the six anterior teeth, one body to be moved, and I'm using a force, a single force for that, because now we're just understanding one vector, I'm applying a single force for that kind of movement. I need to ligate those teeth in a rigid situation, a rigid aspect, a rigid condition. Meaning, if I'm using a round wire or an undersized arch wire for doing this, it's not the same thing. I'm not getting those teeth ligated. So I have to understand in this situation, if I'm applying a force with not rigid arch wire, undersized arch wire, or a round arch wire, I can't consider those teeth to be rigid ligated. This is not a body. In this condition, we have 6 different bodies that we have to understand, and we have to anticipate the movement of those 6 bodies separately, not ligated, because I'm not using here a rigid ligation for that. Why is this important? Because I see many people using this kind of concept, thinking that they're using the same center of resistance of the 6 body together, the 6 teeth together, but they are not, because they're using, for example, a 1625 arch wire in a 2230 slot. So this is not a rigid ligation. It will allow those teeth to move separately. And this is not the same thing for us, okay? Just something that I remember now, because I see that very often. I see people saying, we're using here this 6 teeth to be ligated together, and we are applying the force close to the center of resistance. I'm gonna show you that is wrong. That is the wrong concept. let's move on. So for that, we need to have a rigid body, a rigid arch wire, very tight ligated to those teeth, to have those teeth together to be considered just one body, okay? We have also the center of resistance when we are applying a force to a different structure, for example, the maxilla, which is ligated to the skull by sutures. So if you consider to have a force applied against the maxilla to do the retraction of the whole body, of the whole maxilla. I mean, I'm doing now orthopedics, not orthodontics. So I also have a center of resistance to consider, to have the force passing through the center of resistance, up or below the center of resistance, in order to achieve the right kind of movement that I want, that I planned for. So we have all those center of resistance calculated for us. We have many articles that have this kind of information, and you can go anytime in our references to see those articles. You go to our ebook and see where you can find those information. So for now, understanding the center of resistance, that we have a center of resistance that is different from the center of gravity or center of mass, is what's important for us, okay? Hi guys, we are back with another information which is very important, and now I think it's very clinical. This information comes when we need, for example, to use elastics for doing retraction or protruding anterior lower teeth. Everything we want to, in this kind of situation, using elastics, we have to take into consideration this point that we are going to address now. So this is important. The point of application of the force we have the origin of the force, or the 2 points of application if you want to use this. And for understanding what is going to happen in our movement, and this kind of movement we are imposing to those teeth, we need to understand the resultant and components of the force that we are using in this system. But because teeth move in response to the net force acting on them. So the resultant force with a single point of application is easy to understand, but sometimes you have more than one point of application. What can we do to understand what is going to be the net movement of that teeth or tooth that we are applying the force to? So in this case, we can find the resultant force of those two forces applying in the same point, at the same point. So in this case, when we have the two line of actions, the two vectors, we can just continue two other lines parallel to the first vectors, to the first ones, parallel to one vector and to the other vector, and the intersection between them will be the head of the resultant vector, and the tail of those two vectors will be the origin of the resultant vector. So now we have a force that is trigonometrically speaking, if I can say this, I don't know if we have this word, but in trigonometry, we need to understand this concept and need to understand this relationship between the line of action and the center of resistance, which is important for us now. So now we have the resultant force. Sometimes you have 2 point of application, but we don't see the connection between them. We don't see because they are different, they are not the same point. But we can, also in this situation, we can understand and we can trace the line, the resultant line, if we unite the heads of, we know that the line of force of the action, it goes infinity forward and backward, so we can just move that vector in that line of force, and we can find the intersection between those two vectors. In this situation, we unite the heads of the vector, and now we can use the same concept of doing this two parallel lines to draw and to find the intersection between them and find the origin and the tail is the origin, and the head is the sense of the line of action. So now we have another line of action, and we can go with the line of action again, infinity, backwards and forward. So we now understand which is the resultant force, and we can now see what is going to be the relationship between the line of action and the center of resistance, and understand for that what is going to be the kind of movement we are going to have in this situation. So it's important for us in orthodontics to see. Sometimes it's very subjective, it's not that objective, but we can like anticipate the kind of movement, understanding the line of force of action, understanding the components, and drawing from there the kind of movement we want, and try to control this movement. So sometimes we have just one force, and this force in this case is very visual. I'm using for this example a class 2 elastics applied from upper anterior to lower posterior teeth, and I want some kind of correction because I have a class 2. In this situation, I would prefer to have a horizontal movement of upper teeth backwards, and the lower teeth going forward in a horizontal pattern, okay? But is this what is going to happen in such a situation? Do we have other forces acting in this kind of system? Yes, we have. And sometimes, and most of the time, we don't want this side effect. We don't want this other forces, this other vector to be very strong, to have the force imposed by these vectors in my teeth. Why is that? I'm giving you an example of class 2 patient with a hyperdivergent pattern. Are you seeing this patient in your mind? Yes, very vertical. And I'm applying the force to correct the class 2 because I want to correct this sagittal position of upper and lower teeth. But I have other forces present in the system that may jeopardize my outcome. I have other forces acting vertically that may have this side effect, this bad side effect over lower teeth and over all the situation, because having the extrusion of lower teeth, I will have a clockwise rotation of the mandible. In a class 2, I don't want that to happen at all. So can you understand this? I want to avoid this. And is there a way to avoid this? Let's see how it goes here. And just for having this biomechanic conversation with you, I just draw here the numbers and the sine and cosine that sometimes you don't want to understand, but I need to show it to you because I'm showing to you now how can we manage this to decrease the magnitude of the vertical component. Let's see how it goes here. I'm applying 200 grams in this class 2 elastic. My patient is wearing the class 2 elastic from the lower first molar to this region distal to the canine. I'm using a hook that welded or pressed in the arch wire, and I'm using this force trying to correct the class 2. It's a sagittal correction. As you know, the upper is going forward and the lower is going the upper is going backwards and the lower is going forward, all teeth, because we have the contact points here. So this is going to happen. But it's not just this kind of force that are present in my system, because I have one force and I now need to depict the resultant force that we have in this kind of situation. As you know, I'm not applying this force horizontally, I'm applying this force oblique. So we note by this angle, the angle between the occlusal plane and the elastic itself, that we are not having just a horizontal component. We have vertical components. And we can know how these vertical components will work. We can understand their magnitude, because in trigonometry we can do this kind of calculation, because we know that using this concept of the right triangle, if I know one of the sides and one angle, I can calculate the other sides. Now we know the hypotenuse. It's 200 degrees, 200 grams. 200 grams, and I can have a very approximate idea of what the angle I'm using here. And if I want to see the angle, the exact angle here, I can just draw it. I can use like here this. We can have it in the internet. You can just take the PNG image here and do the calculations easy. So in this case, I'm knowing the angle that's generated between the line of action of the force and a horizontal reference. I have 30 degrees of angulation of this angle formed here. Now I know these two numbers, the 30 degrees and the hypotenuse, which is the elastic component. I have 200 grams and 30 degrees. I know by the trigonometric ratio that I can know the sine and cosine using the two sides, opposite and hypotenuse, and I can do the opposite here. I can calculate, for example, the adjacent component, which is the horizontal force, knowing the cosine of 30 degrees and the number that I have the hypotenuse, which is 200 grams. So we have here the cosine of 30 degrees is 0.866. So we can now measure it because we know the cosine of that angle and we also know the magnitude of the force. So we have those two numbers and we know now that the force in the x-axis and the horizontal component is 200 plus 0.86, which is exactly 172 grams. So now we have the horizontal component, and now I'm looking for the vertical component. Look at this calculation above. We have now the opposite force is 200 grams plus times the sine of 30 degrees. So 200 plus, or 200 times the sine of 30. I know the sine of 30 is 0.5, and knowing this, I can do this calculation. 200 times 0.5, which is 100 grams in a vertical component, extrusive component on anterior segment, and extrusive component also on posterior segment. So if we want to decrease this force, what can we do? What if we increase the span between maxillary and mandibular attachment points? Let's see how it goes here. Now we have a more horizontal line of action of the force in the elastic, and from this point we can also calculate the components. Let's say we use the same 200 grams for that. Of course, we're having to use another kind of elastic, because if I use the same elastic with more far points of application, I will have more force. Now I'm using another elastic to keep the 200 grams that I used in the first example. Now I have just 200 grams, but I change the angle between the line of action of the force and the horizontal reference. We have now 15 degrees. Also, doing that calculation, I'm gonna see that using this variation of the points of application, I can have a different outcome. Force in the x-axis is 200 grams that we know, the hypotenuse, against times the cosine of 15 degrees now, which is the cosine of 15 degrees is 0.965, which I'm going to do the calculation. So 192 grams is the resultant force in the horizontal plane. And in the vertical component, what is the number? For the vertical component, I have 200 grams from the hypotenuse times the sine of 15 degrees, which is 0.258. So let's do the calculation. 200 grams plus 2.26.25 or 26, I'm sorry, is 52 grams, just 52 grams. Of course it is capable of having extrusion, but very less capable than the other force. Okay, so in this situation, I'm lowering the force. I'm decreasing the magnitude of the force that I'm using in the vertical aspect of the class 2 elastics, which is very good in most of the cases, especially in hyperdivergent patients with a big exposure of upper anterior teeth or even gingival margin. So we need to do this kind of adjustment when we don't want to generate that much of vertical forces. We have also the extrusion of posterior teeth with the same number, because we're having here a rectangle, so are the same sides and the same numbers. We're having, so the predominant component here is horizontal, and the vertical component is much less than the anterior example I gave to you. So knowing orthodontics, biomechanics, we can calculate that. I know that you know that, because you can feel that when you see, it's very visual. You see that when you put more horizontal force, you have more horizontal component. It's easy for us to understand, but we have the possibility of doing the calculation. So for showing this and for having this, for sure, we need to do the calculation. So this is for now very important, and we move on from now knowing the force, knowing the components, knowing the resultants. So it's easier for us now to calculate and to anticipate the forces that we need to have in our system. Hi guys, we're back with another information on biomechanics. Now we are going to address one concept that's very interesting for us in orthodontics and very dear for us as orthodontists, which is trying to apply the right force related to the center of resistance of one tooth or a group of teeth. So when we do this kind of calculation or anticipation of this movement, when we try to do the right way, we have more tendency to have a very good kind of movement in our treatment. So if we want to apply a force to a tooth or a group of teeth, trying to achieve some type of movement, I need to understand this. The relationship between the line of action of the force and the center of resistance. So this is important, more than important. This is everything in orthodontics when we think about biomechanics. Especially now, at this point of our learning, at this point of our course, we are addressing everything about the continuous archwire mechanics. We will have the opportunity of discussing many things about the segmented mechanics approach. Not now, not in this part of our course, but further we will discuss this. But now, this is important. Understanding this relationship will allow us to control the movement that we want. Of course, this is not mathematical. This is not something that is that's sharp. We try to do this and we will have this result. Not like this, unfortunately, but at least we are trying based on science, based on what we know that will work in average. So if I want to apply the right force, the right amount of force, I'm not telling you which is the right amount of force for such kind of movement, for each kind of movement, I'm sorry, but I'm just trying to show to you that the right way to apply the force and controlling all the forces present in the system, the energy I put in the system to translate, the energy I put in the system will be translated in movement, and this movement is going to happen the way I'm planning, or close to that. So for that, we need to understand the relationship between the line of action of the force and the center of resistance. Again, I'm not going to address in this course here the biological aspect of the tooth movement. meaning I'm not doing I'm not showing you the best force, the relationship between the tension and the pressure and the biologic aspect of the resorption, frontal resorption, and other things that are related to that, because you have the opportunity to see that in many articles, and we are focusing here on biomechanics. But we will focus in this situation the relationship between the line of force, the line of action of the force, and the center of resistance, and all the components that we can have in this kind of relationship. Okay? So to understand these effects in orthodontics, it's necessary to understand those principles, those mechanical principles. So first of all, let's see what happens when I just apply one single force in one point, in specific point, creating a specific line of action of the force. We have three possibilities of moving teeth, of moving one body. We have a translation, in which we have all movement, the body is going to move all points of the body in the same direction, same sense, and same magnitude. We have a rotation, pure rotation. I'm going to show you here, not now, but a little bit further. And the combination of translation and rotation, which is very common. The most common type of movement we have in orthodontics is this one, because it is the simplest one. Okay? Translation on the other side is very difficult to achieve, because for that we need just applying one force to pass the force through the center of resistance, at the height of the center of resistance, if we are looking from a lateral view here. And you remember from our previous sessions that I showed you that we have to understand those effects not just in a bidimensional view, but in a three-dimensional view. And for that you have to understand the relationship between the line of action, the way you are applying the line of action, in an occlusal view, lateral view, coronal view, everything is related to that. So if we have just this view, to make things simpler now, we will have a translation, because the line of force of the action, the line of action of the force, as you know, it goes infinity, backwards and forward. So this is what we have in this situation. How can we achieve, let's make it simple, in this situation, using just one tooth example for understanding this. How can we apply one single force in this line of action of the force? At this level, we have to have a higher hook. If we weld a higher hook to this incisor, and I'm just doing the force, and this incisor at this point, we don't even need to use a wire for that, because I'm having a translation in this view, of course, in this view, lateral view, because if you're seeing from an occlusal view, it's different. We're not applying the force this way because we have the gingival attachment here, we have the bone, we need to do the force in a different way. So if we could apply, let's say we don't have the gingival margin, we don't have the bone, we don't have the periodontal apparatus, we don't have anything, we just have this tooth here, and we have the force. If we applied the force this way, we would have this kind of outcome. Putting, for example, fixed here a mini implant, and I'm stretching a coil spring to have the force, and the line of action of the force is at the level of the center of resistance. What is going to happen? A translation. All points of a given object, in this case this tooth, move in the same direction and sense with the same magnitude. All points are moving at the same magnitude. So this is a translation. It's good for us in orthodontics. I'm going to show it to you when we speak of a retraction of anterior teeth and the relationship between this kind of movement and the periodontal ligament, and the stress and the strain we are provoking, we are imposing on the ligament and periodontal ligament, and this structure. It is important also, of course it is, but now for the sake of the simplicity of the understanding, we are just thinking of this one line of force, one line of action of the force and one center of resistance. So in this situation, just one force, just one line of action of the force applied at this height will have, we shall have this kind of outcome, a translation, okay? And this is going to happen not just in this view, not just in horizontal view, but in any view we can do the same things, the same thing. Let's see a clinical example of that. I'm doing the retraction of anterior teeth, and I don't want to think about torque and anything that we're going to see a lot in this course, but I want to make everything simple. Kleber, I'm a simple person. I don't want to make things complex. What can I do to apply just one line of action of the force, meaning just one force at the right point to move all teeth, all anterior teeth backwards in a translation movement, in a kind of a translation movement? Well, we can do that. For that, we have to understand some things. For that, we have to ligate all teeth that I want to move in a rigid fashion. Very, very rigid fashion, very, very rigid way. So if I'm applying this kind of concept, I don't even need to have a ligation between anterior and posterior segment, because I'm using the concept of line of action of the force against one body, which is a very rigid body here. But what can I do to make this body really, really rigid? What can I do to cut the wire and the posterior region, because I don't want to have friction here? What can I do to make this anterior segment very rigid, or rigid enough to make it just one body, and apply the concept of line of action of the force and center of resistance using the translation for that? So I need a very, very rigid segment. And if I want to use it, I'm not using a 1725 or a 1625 arch wire against inside a 022 or 030 slot. I need a very, very rigid slot, a very, very rigid arch wire, I'm sorry, and this arch wire must fill almost completely the slot. This way, only this way, I can consider I have a rigid body being moved backwards. Okay? So I don't use other combinations when I use this concept. I use a very, very rigid arch wire in the anterior segment, and then I can put the line of action of force that high using the center of resistance of those teeth I'm moving as reference to obtain the right movement that I'm planning for, which is translation. In this example I'm giving you here, translation. So now it's possible to use it, and if I do the right combination of the right height and the center of resistance passing through the center of resistance, I may obtain the right movement I'm planning for. So as you can see here, we did the extraction of the second premolar for patient's convenience, because she didn't want to have the teeth that showed in her smile extracted. So we chose a posterior teeth for that. We could have chosen the first, of course we could, but in this case, because of patient's option choice, we chose the second premolar, and we have in here the distalization of anterior teeth using a high hook for that, trying to achieve a higher position of the line of action of the force, trying to keep it close or passing through the center of resistance. Sometimes we are not in the right height. We can adjust that during retraction. If we are losing inclination, we know for sure that the height is not correct, so we can go upwards if we want, or we can change this using other moments involved in the system, of which we are going to speak later, okay? So now we have the retraction and the correction, and now I'm using for losing anchorage this beautiful loop that I use here. We'll learn about it, and that's the final part of our course when we address loops in orthodontics, but now we can see it in action, doing the losing of anchorage in this situation, okay? And now we have the result. before and after, and we have now the correction of the class 2 using this concept of uniting the anterior segment, the segment I'm doing the retraction, and uniting it in a rigid fashion, okay? In a rigid way. And we have the translation. The translation is very good in orthodontics, not very simple to achieve. Of course, I'm talking here the most simple way to achieve this, with one force, line of action of force, high line of action of the force, but sometimes you have to do some adjustments because the movement is not that simple, not that beautiful as the drawing make us think. Nothing of that. It goes sometimes like this, twisting, and at the end you have before and after. Comparing before and after, you may have this translation, comparing before and after, but during the movement can be a little bit more like this more root, then more crown, this tooth being more twisting, and then we have in the end the right movement that we want. So we sometimes do other kind of line of action, not just horizontal. Sometimes we want to do more vertical component, more oblique component for having intrusion and retrusion or retraction of anterior teeth at the same time. So we can do it. We just put the line of action of the force the way we want and with the angulation we want to achieve the movement we are intending. Okay, so in this kind of movement, I'm doing the intrusion and retraction of anterior and also having a translation. It doesn't have to be just horizontal. Okay, so translation is a movement that we sometimes need to have in orthodontics. Let me try to put it in a clinical aspect. For example, we have this overjet of anterior teeth. We have this class 2 and we want to do the retraction. We need that retraction to be in a controllable inclination way. Okay, so we're doing the retraction, and this retraction, it needs not to lose inclination of anterior teeth. What can we do for that? We want a translation. For having the translation and this kind of retraction, if we are applying just one force, we need to apply it high, and we need to have this very, very well ligated anterior segment. Very rigid and very well tightened anterior segment. So if we are not doing this, and we are applying the force at the level of the crown, this won't apply. We need to have another force of which we are going to talk about later, okay? But for now, I want you to understand this. We are always aiming for the right movement in orthodontics, and one way to do that is just using one line of action of the force and the right concept of one body united, okay? We can do that in our horizontal movement, in a more intrusive movement, more oblique movement, but this is the most important thing. Line of action and center of resistance. Hi, we are going now to another kind of movement that we have in orthodontics. This type of movement is very common because sometimes we just apply the force for a kind of retraction or protraction that we want to happen, distalization of just one tooth, and we apply the force and we don't think much about what's going to happen. But the outcome of this kind of movement is going to be almost always the same, an uncontrolled movement, because we are applying the force far from the center of resistance and we are not having a control of what we are having here. In this situation, when we apply the force away from the center of resistance, not at the height of the center of resistance, we will have, as a result of the movement, a tipping of this movement, a tipping of this body, in this case, my tooth. So this is what's going to happen. As you can see, we have an uncontrolled tipping here. We didn't control anything, we just put the force and expect that the tooth goes forward with the crown. But as you can see, we have a crown going palatally, but the root is going buccally. What can I do to control that? We're going to see that in another session of our course. But for now, we have to understand that just one force passing outside, not at the level, not close to the center of resistance, we will have the same outcome, non-controlled type of movement. This is uncontrolled tipping, as we call it in orthodontics. So if I want to understand what happened, I need to understand those other concepts that we are going to address from now on. The center of rotation we're going to see later, but this one, the moment. What is a moment in orthodontics? We call a lot of a moment. It was generated during the movement. I don't need to control the moment. I have a different moment that allowed me to have a specific center of rotation. So all those things, I think you've heard about it before. And sometimes you say, what is going on? Why you have to say moments in orthodontics, center of rotation? Wow, this is important for us. Regardless the type of orthodontic appliance you're using, you need to understand that. You need to control, or even try, or at least try to control that. At least try to understand and manipulate forces in order to have the best outcome, the best kind of orthodontic movement that you are trying to have. So we need to understand that. A moment is nothing but just one kind of tendency in our body. We are applying force outside, we are applying force far from the center of resistance, will tend to move that body, not a translation of that body, but some kind of tendency of rotating it, some kind of tendency of inclining it. So in this case, this tendency of inclining, let's say this root, this body here, is called a moment in orthodontics. So moment is tendency to tilting or rotating when a force is applied away from the center of resistance. And the magnitude of the moment is calculated when we know the force and the distance, the perpendicular distance between the line of action of the force and the center of resistance. Why perpendicular? Because it's the closest distance between the line of action of the force and this point that we are measuring, which is the center of resistance. So in this situation here, we can just understand what is the tendency of the moment, knowing the force, the magnitude of the force in grams we have here, and the distance between the line of action of the force and the center of resistance. If we are applying, for example, 150 grams of a retraction force in this situation, 10 millimeters away from the center of resistance, our tendency magnitude, our moment, our rotation or tilting magnitude here, the moment is 1,500 grams of moment. And the representation of the moment is this curved arrow that you see here. The way to see the direction of the moment is bending this vector around the center of resistance. So we have the sense of the force that way. If we just bend this arrow around the center of resistance, we see which is the moment direction. We call it this clockwise direction of the force, meaning we are going this way. We are going this way. And so this is a clockwise moment of 1,500 grams when we apply the force 10 millimeters away from the center of resistance and 150 grams of force. So this is the way we calculate this. Why is this 10 millimeters? Because I showed you before that is the distance between the line of action of the force when applied at the center of the crown and the center of resistance. Of course, considering a periodontal healthy teeth, periodontally healthy tooth. So in this case, 10 millimeters is the average of the distance between the center of the crown and the center of resistance. Okay? We are applying the force away from the center of resistance. So we need to understand what is the type of movement we are imposing to that teeth, anterior teeth, or just one tooth. In this case, we have this huge tendency of tilting these teeth. Okay? So this is the outcome that we are seeing. And then we need to understand that in all other views, we can apply the same concept. If we are having this force away from the center of resistance, the moment will be generated, and in an intrusion fashion, in an intrusion type of movement, the same thing will happen. We'll have the intrusive force that will tend to go with the center of rotation up. This is the same thing if we apply this force, as we are going to see, at the center of resistance. The center of resistance will move up, but now we are applying away from it. The center of resistance is still moving up, but we now have another tendency. We're not applying more energy to the process, to the system. We're just having an outcome of the force I'm applying outside the center of resistance. So the moment is nothing external of the movement. It's a tendency of, in this movement, change the way this body is going to move. Not more translation, but with an inclination. So if I'm applying the force away from the center of resistance in an intrusive movement, we will have also the tendency of inclining that crown and having this uncontrolled tipping in this view. Not just retraction, but intrusion also, and all movements we impose to a tooth are going to respect the same kind of concept, okay? So we have it here. Let me ask you something. Am I in this intrusive moment saying, intrusive force saying that all the time, every time you're applying an intrusive force to anterior teeth, we will have a moment. Think about it. Just 1 second. I'll let you think about it. Pause here, and think. Is there a way to apply the force, an intrusive force, in this anterior teeth and don't have a moment? Yes, there is. For example, this way. If I have a very retroclined teeth, anterior teeth, and I'm applying the force this way, what matters, always take it into consideration, is the relationship between the line of action of the force and the center of resistance. It's not because you're applying the force in a buccal way, in a bracket, in a bracket bonded buccally, that you will have a moment generator intrusion. Of course, most of the time we are going to have this intrusive and this tilting of anterior teeth because we have this distance. When teeth are well positioned, meaning are well inclined or close to it, the center of rotation is far from the position you are applying the force. But there are some situations in which the center of resistance is not is at the same level of the line of action of the force, and then in this situation we won't have tilting. We'll have a real intrusion without tilting. Okay, that's not common. Just something for us to think about. Okay, and of course, thinking of it, we see that the more far the force is from the center of resistance, the line of action is, the more we'll have the moment, the more we'll have the magnitude of the moment. The higher will be the magnitude of the moment, okay? So this is something to consider always. So, hi. Now we are back with another information which is very common to use in our language, orthodontic language. We say a lot this. What is the center of rotation in orthodontics? The center of rotation is a fixed point around which a two-dimensional figure is rotating, as determined in its initial and final position. So if you compare before and after of one tooth or a group of teeth moving from one point to another, that point in which that figure seems to rotate, this is the center of rotation. Of course, the center of rotation is a bidimensional view for us, but this is something that has to be seen in 3 dimensions also. But for understanding what kind of movement we are planning for, just this, the bidimensional view is enough for us. We are speaking of it now. So when we see this before and after, we can say what was the center of rotation. It's very difficult for us to understand the center of rotation through the whole movement because it's not something simple to understand and something simple to view or to draw. But when we compare before and after and knowing where we want to go, knowing what our goal is in terms of movement, I want to do this inclination, or no, I want to do the translatory movement. I want just to go with my teeth like this, control a little bit for losing inclination at the end of the movement. So I can do that. I can at least plan for that because, as we talked before, not very simple, not mathematical, but it's important for us to know the goals and to understand that we can manipulate force, height of the force, manipulate the relationship between the center of resistance, and then in a few slides, in a few sessions, I will talk about the possibility of adding to the system a counter moment. So all of those things are important for us to understand the kind of movement we are having. And center of rotation is part of it. It's part of it because we have to know what is the center of rotation that we want for that kind of movement we are imposing to the teeth, okay? In this situation, I showed you before, we have the possibility of having a translatory movement, the translation of the teeth. I have the inclination of the teeth with uncontrolled tipping, or I may control it during the retraction if I want to retract anterior teeth. And we'll have different center of rotations in relation to that type of tooth or teeth movement that I'm having here. So we are talking about one point, just one point, when we see before and after, around which that figure seems to have rotated. So if I have just a simple movement, it's very easy because I just draw two lines before and after of the long axis of that tooth before doing the force, after a while, 1 month, 2 months, 6 months, and I just understand what kind of movement I have imposed to that teeth during that period of time. In this case here, we see that the dot point that we are seeing right above the center of resistance of this tooth is the center of rotation, because it is the point that did not move during this movement, did not move at all. It seems to be stationary. It kept its position while all other parts of the teeth, this tooth in this case, moved. So this is the point around which this movement occurred. Of course, as I told you before, it's not something that happened like instant center of rotation. Just if you compare before moving and after the result that you achieved after the movement finished. In this case, this is the center of rotation, but there are some situations in which we don't have this intersection in the body, inside the body of the teeth or tooth we are moving. How can we calculate? How can we see where the center of rotation of this movement is located? This is easy also. What do we do for that? We take 2 points before movement at one specific point of the root of this tooth or any part of this tooth, but 2 exact points of those before and after figures, and we take a far position. Now I'm using the tip of the crown, and before and after same point, I ligate those 2 points at the root and at the tip of the crown, and I bisect it. I take the middle of the position and I bisect it, and now I have the 9 degrees between this line and the perpendicular line, and where those 2 points cross, where there's the intersection between those 2 lines, it will be the center of rotation. Let's see how it goes here. It will be the center of rotation of this whole large movement. So in this situation, this is how we see what happened, what was the center of rotation of this before and after in this bidimensional figure. And if I just grab here the center of the resistance of this tooth, and I go like twisting this pendulum, I'll see that this is really the point around which the rotation occurred. Okay? There are people that say that it's easy to do that. We just have to draw the line of the long axis of the force, and when it bisects and when it crosses, it will be the center of rotation. But it's not accurate. Let's see and compare one to the other method of doing this analysis. For example, here I have it here, the intersection between these 2 points of the long axis. But when I grab the same way the center of resistance and I do the pendulum, the swing of the pendulum, I can see that it's not a point, because it has to go downwards in this movement, the center of rotation, and the whole body in this kind of pendulum. So this is different. I just don't do this kind of 2 lines unless there is a connection inside the body to see what was the center of rotation inside the body. Okay? It seems to be a little bit theoretical, but it's important for us when we do the calculation of the movement we are trying to do. Okay? What happens? You're saying, Kleber, that we have to have this intersection to find the center of rotation, but I'm seeing here that movement, that translation that you said before, which is very, very parallel before and after position, because all the points of that teeth, that group of teeth, or just this tooth, moved, all those points moved the same direction, sense, and magnitude. How can we draw a line and have the intersection between them? We don't. That's what we call the center of resistance is located in the infinite. Okay, because we don't have the crossing of those 2 lines. So in this case, we just consider that we have the center of rotation positioned at the infinite. Okay, this is how we call in orthodontics this translatory movement. So guys, this is for now important for us, and we are going to understand more and more about it when we address the retraction of anterior teeth. I promise you. Hello guys, so we've seen in the previous session that we can use this calculation of the center of rotation to understand the type of movement we had in this before and after bidimensional view of our movement. But now we are going to apply this concept in a more clinical way. So we know that when we do this, applying the force far from the center of resistance, and we don't have other force, we just have this uncontrolled tipping when we have 10 millimeters away from the center of resistance. But for calculations of finite elements and everything, we know that when we move this line of force of the action closer to the center of resistance, the type of movement would be different. The type of movement, for example, when I move this from 10 millimeters high, which was at the previous example giving us this uncontrolled tipping, when we move it from 10 to 5 millimeters closer to the center of resistance, meaning now I'm from 10 to 5. I'm 5 millimeters away from the center of resistance. In this situation, we have a different type of movement. Still tipping, because I'm not passing the force through the center of resistance or at the height of the center of resistance, but now I'm closer to the center of resistance. So the type of movement that will be generated, that will be originated of this kind of line of action is different. This we'll call a controlled tipping. I'm gonna show you how it works. In this example here, as you can see, we have this very proclined anterior teeth, very proclined anterior incisors that had to be retracted because we have a class 2, a full step class 2, as we can see in this image above, those 2 images above here, and we want to retract but we don't want to retract it in this type of movement, putting the roots, throwing the roots against the cortical plate and moving the crown backwards or palatally in this movement. So I want to control, if I want to control it and I want just to lose inclination, one good possibility here is putting the line of action of the force closer to the center of resistance of anterior teeth. So as we know, the anterior teeth center of resistance is located of these 6 teeth together. It's located approximately 8 to 10 millimeters higher in relation to the center of the crown of those teeth. So as you can see here, this high hook, but not that much high, put the line of action of the force closer to the center of resistance, but not at 10 millimeters height from the center of the crown. So it's a little bit below the center of resistance, not 10 millimeters, and something between 5 and 10 millimeters. And so we are not passing the force, the line of action of force, through the center of resistance. So it tends to go with the movement in a more controlled way, meaning I'm going to do the inclination, or I may use losing that much of inclination, controlling the center of rotation, putting it closer to the apex of those 6 anterior teeth. This is what I'm trying to do here. Of course, again, this is based on an average case. I may have here different amount of root, different amount of bone and shape and everything, but we are going to control this using the theory about this center of resistance, line of action, and controlling in between the appointments. Seeing it's all right, it's not the right, so I need to stop. Sometimes I need to add some torque here, and we're going to talk about torque extensively about torque, but not now. In this situation, I'm trying to control the movement via just one line of force, one line of action of the force, and putting this line of action at the right height related to the center of resistance of those 6 anterior teeth. This is what I'm trying to do, and as you can see here, during the retraction, I think we're managing to do this. We are managing to control this kind of movement. That is not that simple, and the center of rotation is not just that at that point, but for now, for sake of simplicity of understanding this first concept, I'm gonna keep it like this: center of rotation and the apex of anterior segment. Okay, and now the retropositioning of those crown, losing inclination, is occurring as I planned for, and now we have the correction of the class 2, and it was very good inclination control during this movement, and for that I used this concept of just one line of action of the force and the proximity of this line of action of the force from the center of resistance of anterior teeth. Of course, we have other ways. Yes, we can do this by using torques, using loops for that, but in this way to do the control here, this manner that I'm using to control it, the inclination, it's a very good possibility also, and so we had a good control during retraction of anterior teeth. Okay, so as you can see, when you move this line of action of the force closer to the center of resistance, the tendency is for having the center of rotation of the movement located close to the apex of those teeth, in this case, the central incisor. But in this image, just let me call your attention for something here, to something very interesting. As you can see, for having this kind of center of rotation, it's necessary to have this tooth inclining buccally, but it goes like the pendulum movement. It goes extruding the crown. not a real extrusion, but a relative extrusion of the crown. But it didn't extrude really, but in relation to the previous position, it's more downwards. So this is important. And you see that this is important because this is not the real center of rotation of the movement, because we have a rigid arch wire acting here. We are using for this in this example, and we are using in our mechanics, as the previous mechanics I showed you before, during the retraction, a continuous arch wire mechanics, meaning I have a rigid arch wire at that point of the crowns, and this vertical displacement of the crown is really difficult to have because I'm using, in this case, this rigid arch wire. But if I haven't used this, I should have a different outcome. Of course, just for you to understand, that's not that simple, but for understanding now, we are using this center of rotation, but we are changing this a little bit ahead, okay? And in this case, our moment occurred, of course it is, because our force is not at the level of the center of resistance, but a lower moment compared to the moment that is generated when you apply the force 10 millimeters high from the center of resistance. So what happened here? Happened also a moment, but during this movement from before to after movement, if we draw the line before and after, if we follow this movement, we'll see that the center of rotation is different and is closer to a more controlled movement when comparing to the force applied 10 millimeters away from the center of resistance, okay? This is important because when we talk about moment to force ratio, we'll come back to this concept. When we talk about it there, when we do the retraction of anterior teeth, and we talk about the moment to force ratio, this is a very important concept, okay? We'll talk about this in another part of our course. So, moving on, as you can see, now we have what we call in orthodontics a controlled tipping. Pay attention to this. I'm here trying to be very simple in our mechanics, using just one line of action of the force and comparing the height of line of action of the force with the center of resistance. I'm not using a different concept like a counter moment and force to moment ratio, moment to force ratio. So this is the simplest way to do this kind of controlling the movement, okay? This is a controlled tipping. Controlled tipping in opposition to uncontrolled tipping moves the center of rotation higher and puts it closer to the center of resistance. To the apex of anterior teeth, okay? What if I do this now? I put the I put the line of action of force 5 millimeters higher in relation to the center of resistance. The same way, I will have a controlled tipping, but now the center of rotation changes in a more lower direction. And in this case, I'm positioning the center of rotation closer to the tip of the tip of the crown. So in this case, still a controlled movement, but we don't call it in orthodontics. We call it root movement, which is, believe me, very difficult to achieve. And sometimes it's not worth it, okay? And I'm gonna show it to you when we go to retraction of anterior teeth. But it's possible. When I move it higher from the center of resistance, 5 millimeters higher in relation to the center of resistance, now I have a different movement. It's also a controlled movement, but the center of rotation is different. It goes downwards concerning to the upper arch and goes to the tip of the crown. It is a root movement, okay? Sometimes we want it to happen, and for that we need to use a different strategy. But if I wanted to use for that the same concept of using a line of action of the force higher than the center of resistance of anterior teeth, I could do that without one force. Yes, I can. How can I do that? Now you're thinking, what's going on now? I'm putting the force higher. Is it possible? Yes, it is, but is it something that is comfort for our patient? No, it is not. Just look at this picture here. Very bad sometimes because of the position we are putting the force, and sometimes we are hurting the gingiva of our patient, okay? The mucosa of our patient. In this case, the torque should be an option, but we're not talking about torque now, are we? No, we are not. We're talking about torque later. So this is the root movement. Is it easy to achieve? No, it is not. And this other possibility of uncontrolled movement, but now we're going the opposite from the force we applied at the level of the crown. We're applying now 10 millimeters high, not 5 anymore, 10 millimeters high. This is a type of movement that resembles the first one that I showed you before, which is the movement called uncontrolled tipping. This is an uncontrolled tipping, but now the center of rotation of the movement is still close to the center of resistance, but it is displaced more in the direction of the crown. Okay, so we can change the height of the line of action of the force, and doing that we obtain different types of movement. So I'm trying to show to you now just a simple way to do this, the simplest way to do this. We are going to address another type of controlling this movement. Not now, but when we do that, I'm showing it to you that it's very, very, very simple. Very, very simple. I promise you. You understand that. Hello, then now we are back, but before we go further with the type of movements in orthodontics, I was entering the rotation. The rotational movement is a little bit tricky, so before that I'm going to try to explain to you another concept. I'm going to try to explain because I know sometimes a little bit confusing, but the equivalent force systems is important for us to draw the kind of movement, the type of movement, and what's going on when I apply some kinds of different counter moments and other forces. And so to understand and to work with the vectors in a system, in understanding the equivalent force systems is important for us. So going with this concept, an equivalent force system is a system of forces and or inclinations that can be replaced with a different set of forces and or inclinations and still achieve the same translational and rotational behavior. Meaning, if I change the position of the vectors that I'm using, I can put those vectors acting in another part of the body. For example, we know here that I can put two vectors, thinking of the cancellation of the force. We have two vectors acting at the center of resistance, for example, because this is the point in which I want to understand the movements, because when we do retraction, we know the behavior of the center of resistance during retraction is important for us. Let's put this force in the center of resistance. So if I use for this example here, the same amount of force, the same magnitude of force that I'm applying here at this position and at the crown level, we can put the same amount of force, the same magnitude here, two forces acting one against the other at the center of resistance. So if we do this, we know having these three vectors here, that I can cancel those vectors that are the same in magnitude because they are opposite in direction. So I can cancel this vector and this one here, because when I apply the force in opposite directions, I still have the moment, as you can see, because the force is applied far from the center of resistance. But those two forces tend to move the center of resistance in opposite ways in the same magnitude, so I can cancel them. Because I want to know what happens if I put this force now in the center of resistance. So now I'm canceling those two forces and I'm going with the force in the center of resistance, because out there this force will be acting also. but we still have a moment here. So I can represent this set of forces here. I can represent this system of forces as two forces acting at the center of resistance. And if I could separate those two types of movement, I should have one translation, because I have the force acting at the center of resistance, and still have some rotation. At the end of the movement, I'll have the combination between the rotation and translation and the center of rotation located, because as you remember from the previous session, we put the force here at the level of the crown, and this will tend to move the tooth in an uncontrolled tipping way, or this type of movement is an uncontrolled tipping. So what we are representing here, in order to visualize the type of movement, I'm putting the equivalent force acting at the crown in the center of resistance, okay? So now we have it as a reference of forces. So as you can see, I moved both the center of resistance, and I also have a moment that imposed an uncontrolled tip into this tooth that I'm moving, okay? So let's see, for example, if I have two forces acting in opposite directions, but not with the same magnitude. So this is different from the previous example. Now we have a 100 gram force acting distally in this crown, and I have 50 gram force acting mesial in this crown. So those two forces are generating two moments, different moments with different magnitudes, because the distance between the line of force of the action, force 1 and force 2, they are different. So they are imposing two different moments at this tooth here. So if I'm trying to say, I'm trying to find here the resultant force here of the moment and the force, I know that the higher force and the higher moment will have prevalence against the lower force and the lower moment. So the direction of the moment will be the direction of the higher force, and direction of the force will also be in the direction of the higher force here. Okay, so the higher moment is preponderant and the higher force also. So let's try to find it how. We have now as a resultant 1,000 milligrams per millimeter of moment in the clockwise direction, and 250 moment of magnitude of the moment, this blue arrow here, and a counterclockwise direction. So when we add 1,000 to minus 250 grams, we have as a resultant of the magnitude of the moment 750 grams of force. And when we do the resultant of the force, also the same thing happened, and we have as a resultant the 50 gram force in a distal direction. So we can represent as a resultant of these forces acting in the system going through the center of resistance, meaning I'm doing the equivalent force in the center of resistance of all those forces that they were acting in this system, just as two resultants, one force and one moment. So it simplifies the process, okay? Of course, you can do this representation of all the forces and all the moments that are acting in the system, but you have to be very accurate for that. And when you do that, sometimes you may confuse everything. So this is a way to simplify forces and to understand visually what is going to happen in this type of movement you are imposing to this tooth. Okay, so this is the equivalent. Hello, now we reached that point that I love to talk about, the rotation. Rotation in orthodontics, when you talk about this kind of movement, this specific type of movement in orthodontics, it is important because for that we have to have a different concept. which is a couple. The only way to have a pure rotation is imposing a couple to the structure, the body we are trying to move. So pure rotation can only be achieved with a couple, which is two non-collinear forces with the same magnitude, same direction, but opposite senses, okay? And they are non-collinear, not the same line, because if they are at the same line, they will cancel each other. So in this situation, I'm having two forces, same magnitude, same direction, meaning horizontal, oblique, but different senses. Remember the tip or the head of the arrow? So this is what shows us the sense of the force. So we have two forces and different senses, okay? So I consider that very important in orthodontics because we have it in our bracket when we put a rectangular arch wire inside the rectangular slot. In this situation, we can generate a couple. So this couple is very, very important when we can control, when we understand and manage the controlling of this type of rotation, when we manage to do the control of the wire to impose the type of force we want in the direction and sense we want, so we can do many things in orthodontics. Trust me, I'm going to show it to you, okay? So rotation, before understanding rotation, I said that the only way to achieve pure rotation is with a couple. What is a couple? I showed you two forces in opposite direction, opposite sense. Actually, the direction is the same, horizontal, but opposite sense. We call it opposite direction all the time because it's easier. Opposite direction. We understand naturally, very visually what it means, but actually it's sense. So we have it 10 millimeters far from the center of resistance, equal distance in this example here. So let's see what happens. We have 100 grams in one direction. We see here above the center of resistance, and here below the same 100 grams, and opposite sense, meaning we have two forces, same magnitude, non-collinear, not at the same line, and we have it in different senses, opposite senses, okay? So let's see how it goes. In this case here, we have force 1 and force 2. I'm going to say F1 and F2. F1 generates a moment 1. The moment 1 is 100 grams, same force, and we have this 10 millimeters. So we have as a resultant at the same thing as the moment 2, 100 grams plus times 10 millimeters height. So we have the same amount of moment. Since they are at the same direction, acting at the same direction, we had to add those moments. 1,000 grams per millimeter plus 1,000 grams per millimeter because they are the same direction. So we have, as a resultant of those two moments generated by this couple, 2,000 grams per millimeter. Okay? But is it, what happens with the movement in the sagittal or in the horizontal sense, in the horizontal reference? What happens here? As we saw before in the previous session, we can go with those arrows with those vectors and place those vectors at the center of resistance. The center of resistance here, we put 100 grams against 100 grams here, because for being a couple, we have to have the same magnitude of the force. For being a couple, it's one of the rules, same magnitude of the force. So when we apply those forces against the center of resistance, one force against the other, what we have as a displacement of the center of resistance. No displacement at all, because those errors, those vectors will cancel, will annihilate each other. So we don't have movement in horizontal aspect, in horizontal reference. We don't have it. So the only thing that we have in this kind of movement, this type of system, is the rotation. meaning since the center of resistance, it doesn't move. Remember the center of rotation calculation. Since the center of resistance is the point that doesn't move in this configuration here, the center of resistance is the center of rotation itself. So for having a couple, just a couple acting in one body, acting in this tooth here, one of the premises is that the center of resistance is the center of rotation. No movement at the center of resistance, okay? But you can now be asking, so is this the only configuration in which the center of rotation is the center of resistance? Meaning I'm applying the same magnitude of the force at the same level or the same distance between the center of resistance and both forces? No, it is not. It is not. Regardless of the point in which you are applying the force here, it doesn't have to be 10 millimeters. It have, for both of them, you can apply at different height. You will have the same outcome. Meaning, in this situation, to simplify, to make things simple, I'm gonna show you the same amount of distance. Okay, so in this situation here, I'm sorry, not the same amount of distance. I'm sorry, I'm having 10 millimeters. I'm having numbers, easy numbers to do the calculation, just that. So I have here force 1 acting 5 millimeters higher than the center of resistance, and force 2 acting 15 millimeters below the center of resistance. So I have it here, and if I separate to do the calculation, I will do like this. Moment 1, I know that the force will cancel each other. They will be canceled. So we have here the magnitude of the moment resultant will be in one direction, in a clockwise direction, 1,000 grams, okay? Or 100 grams, I'm sorry, 100 grams here, times this distance, which is 5 millimeters in this example here, and we have the force 2 generating the moment 2 of moment is force 100 grams also plus 15 millimeters. 15 millimeters plus, times 100 grams. So let's do the calculation here. We have in one direction 500 grams per millimeter, and the other direction, and not the other direction, but in the other moment, same direction, other moment, we have 1,500 millimeters. They are acting in opposite sides related to the center of resistance, generating the same moment, the same direction, as you can see. So since we have the same direction of the moment, remember, we have both are clockwise direction moments. So we need to add those moments. 1,500 plus 500 grams per millimeter. So we have now 2,000 grams per millimeter. When you see this image here, there's something that's very clear for us. In all examples, the magnitude of the couple depends on the magnitude of the force, which are equal forces, and the distance between the two forces. It's easier to calculate that way. We don't need to calculate one and then the other one. We just need to calculate the force and times the distance between those two forces. The same thing always. So I don't need to do one calculation of the moment related to the center of resistance and then the other calculation to the other moment related to the center of resistance. I just take one of the forces that, for being a couple, they have to be equal. One force times the distance between those two forces. The same thing always. So now we have this possibility of doing the calculation. Okay? So what if I do now the two forces applied at the same side related to the center of resistance? Will it change anything in my system? No, it won't. Let's do the calculation for you to have this in your mind. For example, here I have still doing this isolated calculation, one moment and the other moment. And then we go with the calculation I just taught you. In this case here, one force 100 grams applied 5 millimeters from the center of resistance, but now we have something different. We have now a counterclockwise moment. So if I do this and calculate now the resultant in comparison with the other moment, which is 100 times 15 millimeters, we'll have this resultant. But now I need to consider one of those two moments positive and the other one negative, because they are acting in different directions. I'm not adding them, 1 plus 2, 1 plus 1. No, I'm not adding 1 plus minus 2, 1 plus minus 1. So this is the way we compare, because they are in different directions now. So now we have the first moment is 100 grams plus 5. Second moment, which farther from the center of resistance, 100 grams times, I will say plus, this times 15 millimeters. So now we have those two moments. I will consider the counterclockwise moment as a negative moment and the clockwise moment as a positive moment. So I have minus 15 grams, 500 grams, sorry, plus 1,500 grams. As a result, and now I have 1,000 grams per millimeter over in this kind of situation, but I have one direction, which is the direction of the higher moment. So we have a 1,000 grams per millimeter of a clockwise moment. And what if we do the way I taught you before? What if we do like this? Huh? And if I change the point of application of the force, what happens? Now I'm not pushing, now I'm pulling from buccal side. Doesn't change a thing. It's the same thing. Changing the point of application of the force along its line of application or of action, it does not change the effect of the couple. Okay? So let's do it because it's easier for us now, because you can do that. It's becoming more and more easier, because this is the way we act in orthodontics. We put a force in the buccal or lingual side. We can do, of course, in different sides, but we usually do at the same side. So we do this. It's easier for us now to understand. And shortly we're going to another aspect that will change everything. Okay? So here we have those two forces apply the same side again, but what can we do now? We can change the direction of the moment if we want to change the direction of the resultant. Now, let's see it before. We have it in this direction. This is a moment that is a clockwise moment, okay? So we have it here, a counterclockwise moment, okay? Because we have now those two directions acting. I'm so sorry. Let me go it again for you to understand, because I myself, I'm confused with so much errors. Let me go it again. So we have here this, and the resultant moment is the moment that is in this direction. A clockwise moment, because farther from the center of resistance of this and this system, okay? So now we have this other concept, which is changing the point of application won't change a thing about a couple. So now we have this couple acting in one side and having the same outcome. If I want to change the direction of the moment of the couple, it's necessary to change the sense of the forces. Okay, I'm changing now the direction of the couple, just changing the sense of the forces. What is the force resultant that we have here? Now, the resultant moment here is a counterclockwise moment, because what drives my attention here is this, the farther force from the center of resistance. Okay? Let me go now to another concept that will make everything clear for us, why I'm talking about it so much. This is the next concept we are using now. So, a couple is a free vector. It can be moved anywhere on the body and have the same external effect on it. So what did I do here? I just changed the couple and put the couple acting inside the slot. What is the force that generates this kind of moment, this kind of couple? What is the configuration that we have in orthodontics that moves this, that changes this, that can act inside the slot? A rectangular arch wire twisted inside the slot will generate two forces in opposite directions, same magnitude and non-collinear. Okay? Easy now, huh? Now it rings a bell. Wow, this is what I'm going to use when I use, for example, the retraction, or I want to change the inclination of those crowns. Okay? So, as you can see, these two forces here acting in this body, because the bracket is attached to the crown, now it makes just one body. And as you can see here, the higher the moment generated here, the resultant moment is always related to the fire moment, the moment that is more distant from the center of resistance. So which moment is more distance from the center of resistance? This one here. And it goes upwards. So when I bend the arrow, when I bend the vector around the center of resistance, I see that this is the moment that is generated in this system, is a counterclockwise moment. Counterclockwise moment, okay? So now we have the resultant force here is, what is it? If I calculate that separately, I'll have 1,000, which is my example. As we see that the distance between those two forces now are very are decreased, short distance, very short. If I want to have effectiveness in this situation here, I have to increase the force. I need to increase the force. And when we talk about the equivalent moments, when we talk about the force during the retraction, we will understand how we calculate this. So this moment here, this couple here, generated here, can be calculated like this. 1,000 plus 1,000 times 6 millimeter, the higher moment, and 1,000 times 5 millimeters, the lower moment. And the higher moment is counterclockwise. So what we have here, we have this difference, which is 1,000 grams per millimeter. And if we just calculate one force times the distance between those two forces of the couple, we'll have the same outcome. We have 1,000 grams per millimeter, because I'm calculating the resultant force just using the one force times the distance between them. Okay? Same thing. 1,000 grams per millimeter in this direction, which is counterclockwise. Very good, huh? So now we can understand that we can do this using this torque. I'll have the same outcome, meaning I'll have the rotation with the center of rotation being the center of resistance. Is that correct? What do you think about it? What do you think is that we have when we apply the force in our continuous arch wire mechanics? What do you think? Well, just to initiate a different discussion here, because sometimes we think about something and we just think about that and we don't consider other things. So we know that our rotation, a pure rotation, is only achieved when we use a couple. But let's invert this. Can we have a pure rotation applying a couple using this concept of continuous arch wire mechanics? No, we can't. Let me show you how it goes. So pure rotation is not easy to have in this situation. Why is that? Let's see. Now we have a couple because we have two different inclinations, one of the long axis of the rectangular arch wire and the long axis of the slot. So now we have a couple generated inside the slot. A couple, as you know, is a free vector. So it's supposed to generate a rotation with the center of rotation being the center of resistance, a pure rotation. So is that what really happened in this situation? Let's see. Well, for that to happen, we need to have this. Note that the rotation of the tooth with the center of rotation located at the center of resistance requires the crown to move downwards and distally, similar to the movement of a pendulum. Yeah, let's center the pendulum of the movement in the center of resistance, which is supposed to be the center of rotation. So if I had really a pure rotation in this situation, the crown needs to go downward and it goes distal. Is that possible when you have this configuration here? Is that possible when you have the contact points, one touching another, and we have this? The contact point restricts distal movement of the crown. So sometimes we think that this is what we had in the theory, but when we go to the practice is not the same thing. Another thing that needs to happen to have the center of rotation being the center of resistance is that the center of rotation, it doesn't move. For that, the crowns need to go backwards, need to go distal. Do you think it is possible? Just putting this here, configuration here, you just push all teeth, not for the center of rotation to move? Well, I don't think so. And another thing here, the anterior teeth would need to undergo relative extrusion. Remember the pendulum. This is what happens if I put the center of rotation in the center of resistance. It needs to go downwards. So, do you think it is possible using a rectangular arch wire to have this kind of configuration? No, it is not. So this is probably what we have. The wire stiffness and the small interbracket distance will limit vertical movements. No, we won't have the extrusion as they apply there. So what's going to happen? These restrictive factors change the center of rotation when a pure torque is applied, transferring it closer to the brackets of the anterior teeth. So in fact, what's probably happening here? The center of rotation is here, and we have this outcome. It may be very bad, huh? If we have proclined teeth and periodontal losses. If we have our patient, which is very common in our patient, the patient have periodontal losses where it is very, very common to be to the anterior teeth to be proclined. The repercussion may be very, very bad. So beware. So be aware of this. Take care. Understand what you're doing. We'll talk much more about this because this is very, very important. So guys, this is what happened in this situation, okay? And we need, just for finishing here, to understand that this couple can be related to the first or second order movements. We can have couples in first and second order movements, although we always consider a couple with third order. I don't know why, but we are going to mention those couples both in second and third order and in first order also. Hello, we're back with another information about the height, the position where we put our brackets or our tubes in height, concerning the centralization or going outside the centralization, up or down. What happens when we do that? Are there some situations that we can do and in order to increase our benefit for the patient, or in order to achieve an easier way to do something, for example, intrusion or extrusion, gingival margins? Are there some situations that this kind of changing the position, the height position of the bracket, can benefit the treatment or the patient? Yes, there are. You need to know that sometimes what we do, it imposes a side effect that's not positive. But in this case, when we do this kind of thinking, anticipating the errors, the mistakes that we can input in our treatment, doing something in order to avoid this kind of error, this kind of mistake, it makes the treatment easier and faster. So in this situation, specifically this situation concerning the gingival margin, for example, when we do the changing of the height in order to level the gingival margin, we can have a better treatment outcome, a better exposure of gingival margins, and a display of symmetry between gingival margins. For example, when we have asymmetric wear of the tip of the tooth, of teeth, asymmetric wear happens, for example, when we have crowded teeth. So if you have asymmetric wear of teeth and the gingival margin follows this extrusion pattern, so you have to do the intrusion or extrusion in order to level the gingival margins. And we know what are the best gingival margins exposure, because we know that when we have this smooth and beautiful waves showing the gingival margin of central incisor higher than the lateral incisors, and the lateral incisors above, and the lateral incisors, they have this gingival margin below the gingival margin of the canine, like for example 1 millimeter or half millimeter, we have this beautiful exposure. So central incisors higher than lateral incisors, and central incisor margins at the level or a little bit below the gingival margin of the canine. So this is what we feel, what we seek for the beautiful exposure during the smile. In this case, central incisor higher, lateral incisor lower, and the canine at the same level of central incisor or a little bit higher than central incisor. So this is what we know that is beautiful. Sometimes what we have is this asymmetric wear of the tip of the incisors due to asymmetric position of those incisors, which happens, for example, when we have this crowded incisors. In order to have this exposure, the symmetrical exposures, we need to choose. What are we going to do? Are we going to do a gingival surgery, for example, in order to do this in this gingival margin that is lower? We do this higher exposure or higher positioning, or we do the intrusion or extrusion of the other incisor, the contralateral incisor. We have to understand that when we do this kind of movement, intrusion or extrusion, the gingival margin, it follows the movement. When we have a periodontal health, the gingival margin follows the movement, both intrusion or extrusion. So when we have like this, a healthy gingival margin, healthy periodontal status here, we do the intrusion, we have the margin following this movement. So what are we going to do? Are we going down here? Are we going down here, up here? Or are we going to do the incision here in order to do this, to achieve the symmetry between those central incisors? First tip here is you have to assess the depth of the pocket. We have to assess if we have here a pocket, we have here a deep pocket in this central incisor, or we have a healthy periodontal status here. In this case, this patient had this periodontal perfectly healthy, so we didn't want to do this kind of incision of this gingival margin here, because if we did that, we should have to do both gingival and bone leveling in this case. So when we do this, we have to extend the bone leveling to the neighboring teeth, because we can do this vertical defect here. So if we did that, we would have to do the extension of the bone leveling to the neighboring teeth, which we didn't want at all. So in this case, for sake of periodontal status maintenance, we did this intrusion in this central incisor here. So we had the opportunity to do that since the beginning of the treatment, doing the bonding, doing the positioning of the brackets in the right position to do the intrusion of the gingival margin of this tooth here. So in this case, we opt to do this intrusion, and for that we used this differential height of bonding the central incisor brackets. In this case, this incisor, lower this incisor in a lower position compared to the contralateral. So this is higher and this is lower. When we do the leveling of this slots here, the slots of the bracket, we would have also the leveling of the gingival margin. So since the beginning, we can go forward in our thinking in order to do the treatment more smoothly, the treatment more linear, in a linear way, okay? So here we have the brackets representing the position of the bracket height, and doing the leveling here, we should also do the leveling of the gingival margin. In this case, my friend Yuri here, he did this kind of treatment because of this crowded teeth that he had and because of this canine which was impacted. So we did the expansion and other things in this treatment, but the most important thing for us here to show this at this point of our course is to understand that since the beginning, if we anticipate what's going to happen, what we are going to need during treatment, we can do things faster without the need of doing bands. For example, in this case, the position of the central incisor would save time for us doing less band as possible. As you can see here, we had to do some bands because we had to do the leveling of the gingival margin, and sometimes it's not that easy, it's not that sharp, and we have to do this kind of bend in order to do this compensation. And here we did an intrusion band or a step up band. We can call it both. I call it often intrusion band, and we did this individual intrusion band in order to do this leveling. So as you can see, we didn't take into consideration the gingival, the incisor tips. We took into consideration the gingival margin, which was now leveled, and here we have a very beautiful proportion between central incisors exposure, okay? So we have it here, almost leveled, and the end of treatment. At the end of treatment, it did compose in this incisor, which was more, had more wear than the contralateral incisor, and the gingival margin, they were leveled, absolutely leveled, and that was okay for us. So in this case, seeing the gingival margins, now you can see that we have that waves that I told you before, when we have this canine higher than lateral, lateral lower than central, central at the same height as at the same height as the canine, or a little bit lower than the canine. This is what we expect in a beautiful smile, okay? In this case, we finished the treatment and with the compost in this tooth, okay? So nowadays we have the opportunity to do the other things, beautiful, more beautiful than just the resin that we put here, but at that time it was completely acceptable, statically acceptable for this patient. So we have here the gingival margin already leveled, and we have the follow-up, the 4-year follow-up, and this photo is a 4-year follow-up of this patient, showing a very beautiful exposure and showing the stability of the intrusion that we did before. So in this case, patient wore the retainer, the removal retainer for 1 year, and after that we put a fixed retainer between central incisors in order to keep this movement, which is sometimes a little bit tricky, and we can have a relapse if we don't do this kind of retention here. So we have now, 4 years after the treatment, the stability of positioning of the gingival margin due to this kind of leveling that we did during treatment, okay? Now gingival margin completely leveled, and the tips are leveled, also leveled, And here we have this kind of stain after 4 years, but patient was happy with his smile. And here we have our friend Yuri after treatment comparing to before treatment, and the gingival margins after treatment are after 4 years after treatment. 4 years after treatment, we have still the gingival margin levels, and we have comparing to the initial position a more beautiful display of these incisors and the gingival margin. And here we have comparing pre and post treatment, pre and post treatment. We have more symmetry between exposure. Another situation in which we have to choose between the gingival margins is when we have, for example, absence of lateral incisor, congenitally absence of lateral incisor. So, for example, in this case, we have the agenesis of upper lateral incisors, and we have to choose between doing the closing or opening of space. And in this case, because of the position of the molars or position of the premolars, I chose together with the patient to do the closing of the space. So if I had to close the space, lateral incisors absent would be replaced by the canines. And we also know that the canines, they have the gingival margin a little bit higher than the lateral incisor, and sometimes, in this case, for example, we have it higher even than the central incisor. So if we do just the leveling of the arch, what would happen at the end? We should have, at the end of the treatment, the lateral incisor, the canine, replacing the lateral incisor with a higher gingival margin, which is not that beautiful for the exposure of the gingiva during smile. So in this case, we can do something to enhance, we can do something to increase the gingival margin exposure going downwards in this situation, and I'm going to talk about this a little bit later. So what else do we have to understand in cases like this? In such cases, when we replace lateral incisors by canines, we will have to do some kind of adjustment also in order to complete the correction of the inclination of the central and lateral, which is absent. So we have to change the inclination of the canine, which will replace lateral incisor. How can we do that? If you use, like me, a pre-adjusted appliance, for example, we have in almost all, at least at the majority of the appliances, the pre-adjusted appliance, we have here at the canine a negative torque, 7, 6, 5 degrees of negative crown torque. Lateral incisor, on the other hand, they have a positive crown torque. So one thing that we can do in order to save time and save the need for doing this kind of torque during treatment is putting this canine here, this bracket of the canine here, in a special situation, which we can see a little bit further. So let's go again at thinking about this. The position, just the position, the height, which is the topic that we are addressing now. The height of the lateral incisor canine, which is going to be the lateral incisor, the height of this bracket related to the gingival margin when comparing to the central incisor. So in order to do the extrusion of this canine and together with its gingival margin, what we do is to put this bracket a little bit closer to the gingival margin, in order to do the extrusion. So when you compare the height here in the canine to the central incisors, you can see that the central incisor is a little bit farther than the gingival margin comparing to the canine, because we want the canine to resemble the lateral incisor. We want the canine to replace the lateral incisor, fully replace, meaning you have to see the canine and think of him as a lateral incisor, not as a canine. So in this case, we wanted to do this extrusion of the gingival margin, and we achieved this very beautifully in this case. After that, we can do the wear of the tip of this canine, and there are other things to think about in this case also. Let's see. For example, here, this bracket, upside down. This is the bracket of the canine. Some people ask me, Professor, can we use the bracket, the proper bracket of the lateral incisor in canines in situations like that? And I say, yes, you can, but you have to do to prepare the canine to resemble lateral incisor, meaning to wear the buccal surface of the canine and the palatal surface of the canine in order to put it less thick than the canine crown, because if you do that, if you put the bracket of the lateral incisor, the canine being a little bit thicker than the lateral incisor, this bracket of the lateral incisor is embedded in this bracket. We have this thick basis, because it's what we have usually in these brackets is a thicker basis, because we have to do this kind of compensation of the lateral incisor, which is usually thinner than the central and the canine. So using the bracket of the lateral incisor, you have this thicker base, which is going to push the canine against the lower arch, because it's thicker, remember. So if you are going to use the bracket of the lateral incisor in the canine, which is replacing this lateral incisor, first of all, you have to do this wear of the buccal surface of the canine and the palatal surfaces of the canine, because it has to be thinner in order to use the bracket of the lateral incisor. But if you use the bracket of the canine, you don't need to do nothing of this at this moment. You do it later. So you have just to do is to put it upside down, because we are changing the inclination, the reading of the inclination, which is embedded in this bracket here. So we go from 7 degrees to -7 degrees. Another thing, we are going to finish this case with the molars, the first molars, in a class 2 position. We are going to finish this molar in a solid class 2 position, and for that we have to replace the tube of this molar, because a class 1 tube has inside it a -10 degrees of torque, and we have a rotation of 10 degrees and a tip of 5 degrees or 10 degrees. So in addition to the torque, we have in a class 1 tube tip of 5 or 10 degrees and rotation of 10 to 15 degrees. We don't want it here. We don't want it in this particular situation. So what we have to do, we have to change this tube for a tube without tip and without rotation, just maintaining the -10 degrees of torque. We have some prescriptions that has this kind of tube. So I use a MBT tube for this kind of finishing in a class 2 position. Let's see it in a graphic for us to understand better the situation. So I'm trying here to show you that when you do this kind of reposition in the bracket of the canine upside down, we just change the reading of the inclination, which we call torque. So in this case, the torque is -7 when we have a Roth or an Andrews prescription. Both of them have they have this kind of negative torque at the canine crown. So in this case, putting the bracket upside down, I'm changing the sign of the inclination from negative to positive inclination of the crown. In this case, for -7 to +7. For -7 to +7. So we have here now an inclination that resembles the inclination of the lateral incisor, which is very important for us in this situation, since the lateral incisor will replace the canine, will replace the lateral incisor, and it has to resemble, it has for purpose of aesthetics, it has to be the lateral incisor. So another thing, here we have the tip the tip is the same. We have the tip from 9 degrees. When you put upside down, you don't change the angulation, you don't change the tip, so you keep the tip. If you want to change the tip, you have to like just move a little bit, rotating the bracket for enhancing, for increasing the tip, or for putting the tip lower than what we have inside the bracket. So we can change. We can do this kind of rotation of the bracket in order to increase, or in order to diminish, or in order to lower the reading of the tip. So up to you. So in this case, I can just keep this, just putting the upside down, keeping this this reading of the tip in 9 degrees. Here, the molar. Going further, this information, we're going to have it again in another topic, but here we can see that in a class 1 tube, we have the tip, the angulation of this molar, which is 5 to 10 degrees, and it will not help us. It's quite the opposite. It will do a very bad work for us, because we can't do a very good settlement here. We can't settle this cusp here in this position if we don't do this kind of replacement of the tube, or doing a bend in order to do this kind of settlement here. To settle the cusp of the buccal, the mesial buccal cusp of the first molar, I have to understand that in a class 2 situation, it has to fit in this position by being more vertical than angulated. So I don't want the tip that is embedded in this tube, in this class 1 tube here, okay? So let's see how it goes inside the tube. We have this angulation of usually 5 degrees. We have prescription that has 10 degrees, but let's start with 5 degrees. 5 degrees is what I use in my day-to-day practice for a class 1 tube, and if I don't want it, I have to replace it for a tube with a tube that doesn't have this tip, which I have in my office, which I have in my armamentarium. So we have both 5 degrees and 0 degrees. So I use this in a situation where I want to do this, this intercuspation in a class 2 situation, okay? Which is when I do, for example, extraction, just the upper premolars, or replacing lateral incisor by canines. So keeping the canine in position of lateral, the first premolar in position of canine. So we just have actually one premolar in each, 2 premolars per arch, okay? So in this case here, the premolar is in the position of the first premolar, the first premolar is in position of canine, and the molar won't finish in a solid class 1 situation, so we have to do this compensation by doing this verticalization, this uprighting of this molar. And you can do it easy and softly using this kind of tube. So here we have it, and as you can see, we have a better settlement here. Okay, so after doing the extrusion of lateral incisor, as you can see, I'm doing the wear of the tip of this canine, which is going to be the lateral incisor, using a burr, okay, a diamond burr for that. And we do this wear in both canines, and now we have the gingival margin more, it's more like, it appears that we don't have the lateral incisor absent in this situation, okay? So we have it here, finishing the case with my beautiful bands and loops. And now we have finishing the case, closing the space, and we have a better settlement here between the central, the molar, the upper molar, and the lower arch because of the tube, choosing the right tube for that. And here the case is finished. Central, lateral, and canines, they seem to be central, lateral, canines. And here we have pre and post treatment, and patients smile, and we have it here without the need of doing this highlighting. So we have here the pre and post, and we have it done. Okay? So guys, as you can see, simple situations can change the course of the treatment. Simple changes, simple adjustments can do better for us and can save time for us, okay? Thank you. Hello, another important thing for you to understand and to think forward in order to avoid the problems that it can generate during treatment is the position of the incisor related to the rest position of the lip. So when you have a patient with less exposure, for example, than 2 millimeters or 1 millimeter in a rest position of the upper tip of the upper incisors, the tip of the upper incisors, so it resembles aging. We know that people don't want to have this appearance of aging. Of course, we have to respect. I'll show you that each age has its charms, but we know that people want to show less age than they really have, than they really are. But for that, we can do with our treatment plan, doing the proper positioning of our brackets. We can show more or less incisor tips, doing the right positioning right in the beginning of the treatment, an orthodontic treatment. So this is something very important. We know that men and women tend to feel better with less or more exposure, and I always ask my patients, what do you want for you? Do you want more or less exposure of the incisor in a rest position? So I show them examples of both less and more exposure of the tips of the upper incisors. So I let them together with me choose what's the best for them, okay? But we can do this in the beginning of the treatment. We can do this with the right positioning of the brackets during the initial phase of orthodontic treatment. That's important. And we know that with aging, we show less upper incisors and more lower incisors. In orthodontic treatment, we can change that also. We can trick age. How? We can just intrude anterior lower and extrude upper. It can be by means of orthodontic surgery or extrusion using skeletal anchorage for that, or even with elastics. So we can do anything, just we have to plan for that. What I mean here is that if we want to change the exposure, to change the youthness of the face, we can show less or more incisors, and orthodontically speaking, we can do that. Of course, we have to respect the age of the patient. We can't change completely the outcome, the features of the patient's age, but we can trick a little bit that. It's very important. It's very, for me, this quote here is very interesting. Aging gracefully is better than keeping up a facade of eternal youthness. So we have those beautiful ladies here, one of them my mother, another my daughter, and you can see that they have different exposures. You can see that they have different and proper exposures for their ages, but it doesn't mean that we cannot trick a little bit this age doing this kind of movement, extrusion, special extrusion of upper teeth. For example, here, if you look at this image here, you would probably pick like 50 years old for this lady. You probably guess she's 50 or more than 50, and for her, I'm sorry, she would show more incisor tip that she shows in a rest position. So we can do that. We can do that orthodontically. 0 millimeter exposure, meaning negative exposure in a rest position, is not good, and you can ask your patient what they prefer. For example, 1 millimeter is better than 0, but for me it's not enough. For me, something like this, 2 millimeters is good for this youthness preservation, so you can preserve youthness using this kind of trick, showing a little bit more exposure of upper incisors. More than that, some people like, others not, and we have also the excess of exposure. if I ask you to choose between all these 5 pictures here, you would probably be picking the number 1 or number 4. It's the medium of people who choose this as the best feature of exposure of the upper tip of upper incisors, okay? But one other thing that you can choose is the step between central and lateral incisors. We can do that. Orthodontically speaking, we can do that since the beginning, since the positioning of upper teeth brackets. And we have to choose based on patients' beliefs, based on patients' preferences. So I ask my patients, what do you want? Do you want a 0 millimeter of step? And I explain them what step means, and I explain them that I can change that. And I ask them, what do you prefer? And I know that step is beautiful because many people likes this kind of step because it also resembles youthness. So many people that don't have steps, they are beautiful, but when we have this beautiful step, this is my personal belief. Of course, there are many articles that don't show the same thing for us, that shows that people, it depends on the culture, depends on the place. You're asking people about this kind of exposure of central and lateral incisors, but here, at least in my culture, in my country, we tend to like a little bit more step, especially in women, okay? With women smile. So we have here this beautiful step, and even though some people don't have perfect teeth, this step gives them this beautiful aspect of youthness. Both women and men. Some men don't like the step, I know, but I really think it's beautiful, and we have the opportunity to ask our patients if they like that or not. Many of my patients would prefer the step, the presence of the step, like 1 millimeter or even more than that. Half millimeter is almost not perceivable, but after more than that, 1 millimeter, 1.5 millimeters, I think it gives us this beautiful smile, which tends to give us a consonant smile with the smile arc, giving that curvature that we like. So during the first phase of treatment, of orthodontic treatment, putting braces in position, we can change the height, and we can do this kind of step, just choosing the position of the brackets in the lower part of the arch, okay? So this is something that I like to ask my patients because I can change. So if I can change, I can give my patient this option. And if we want to do more or less step, it's up to our patient, but we have to show them how they can do this, choose this kind of steps. What I do is show them this chart, showing 0 step, 1 millimeter, half millimeter to 1 millimeter, and more than 1 millimeter. And I always play with this kind of exposure in order to achieve this response of my patient, if they like or not the step. Because in my opinion, to give the patient the best that he can achieve is that what differentiates you from other orthodontists. And I want to give them the best always. I want to ask them what they think is best, what's better for them. Do you want the step? Do you want to have this more exposure? What? And sometimes I try speaking with the patient about many things. I try to squeeze out of them what is his preference or her preference about their faces and what they really want to change. Because sometimes the chief complaint of our patient, it's hidden. They don't say loud. They are a little bit embarrassed of saying that they want to change their facade, they want to change their profile, they want to change because they don't like their smile and something like that. So I try to squeeze it out of them, asking many questions and asking what would they prefer about this or of that feature, and sometimes I manage to understand better what they want. So one of the things that I consider that can give that plus in our treatment is given the best step, the best exposure, and that we can determine in the beginning, at the beginning of the treatment, okay? So the step is one of these things, and the exposure of the upper tip of upper incisor related to the rest position of the lips. This is very important, and it gives really a beautiful and sometimes we can even say more sexy appeal, sexy face, if you can say that. But there is something that no of my patients would like, which is an asymmetric step. So when you have an asymmetric step, due to our own errors, due to our own mistakes in the beginning of our treatment, just putting the braces in different positions, the brackets in different positions. So sometimes we build this asymmetric steps. So this is something that no one likes, and we have to ask patient, which one do you prefer? In this case, my student was one of my students. She was treating, and she was in this phase of the treatment, and I asked her, what is the step that you prefer? And she told me, Kleber, I'd like to have this step. I don't like this much of this step in the left side. And what I did was to do the correction by means of bends, in this case, a step down bend or extrusion bend. So we can manage to do this modification if patient don't want during the treatment, but at the beginning of the treatment, we can also do this, avoiding sometimes the need for doing this kind of bends during treatment because we anticipate the mistake and we did it before treatment. This is very important. So sometimes we can do this in order to achieve a better exposure of the smile arc, and we are going to do this by means of the bonding, or if you already bonded, and if you have already bonded your patient and you didn't manage to do that at the beginning, you can change this doing this kind of bends that we will see thoroughly during our course. But now, just for an example, I'm going to show you this step down bends. They are made in order to have that beautiful smile arc. So we can do that both by means of bonding at the beginning, different heights of the incisor brackets, or if you want to change or even increase that step, you can do that in the course of your treatment, okay? Hello, my friends. So now we're not talking about bends or loops or even elastics. I'm going to show you situations where you can just prevent the doing of bends and loops in order to correct something that you missed during your treatment. So before doing bends and loops, if we do the correct way of bonding our brackets or our tubes, we can prevent doing bends in order to correct something. So this is important because you want to do a smooth treatment, doing the treatment from the beginning to the end, right, like a line, you know, like doing everything correctly in order to do a very short treatment. So you are shortening your treatment line because you don't miss, you don't commit mistakes in the beginning of the treatment. So this is now what we are going to focus on, okay? Bends and loops. Let's begin with these two beautiful words for me. Bends are made in order to correct the positioning of a tooth or a group of teeth in three planes of space. They are named according to the movement they impose on teeth in first, second, and third order bends. Same thing with movements. So when we think about doing a first order movement or second order movement or a third order movement, we have to understand. We have to keep in our mind what we are doing. So let's establish from now to the end of the course what is first order, second order, or third order bends or movements as it matters. So night-tie wires, may not be completely efficient to tackle some nuances of poor dental positions. So sometimes we have to do the bends in order to correct or in order to do a better movement or a smooth alignment or leveling of our teeth. So let's start with first order movement. This is the same thing that we're going to do during our course in order to understand the movements and the bends, okay? First order movement. So those are the movements that we see when you do the bends or correction, looking from behind our model, for example, from behind our upper or lower arches. So we do this movement, for example, when we correct the rotation of our tooth or teeth, and we do this kind of insets or offsets bends in order to correct the position of the alignment inside the arch wire, okay? Inside the arch of the patient. So we have the second order movements. Those are the movements that are made in the vertical direction. So when you see laterally our teeth or our model, we see the movements that we do in this situation. So angulation is a second order movement, and intrusion or extrusion are also second order movements. So we have the third order movement, which is the inclination that we impose to the teeth or a group of teeth or an individual tooth, for example. So we do the angulation. We do the angulation on the sectional part of our rectangular wire in order to create a couple that will correct the inclination of the tooth. So when we do this, we do a different inclination to our tooth or to our group of teeth, okay? So this is how we speak orthodontically. So this is how we create a unique vocabulary in order to communicate between me and you to do the correct movement and to understand what we are doing in our patients. So before doing this kind of movements, we have to understand that there are some topics that are very important in order to do a very correct, a very smooth treatment planning. And before doing the bends, we have to understand that we can prevent them. Okay, we can't avoid doing this kind of bends because we did the right bonding, we did the right positioning of our brackets or tubes, and we anticipate the errors that could have been made during the course, and we completely eliminate those errors. Of course we can't. We can't eliminate them at all, but we can lower the amount of bends and loops that we have to do in order to correct something that was incorporated to the treatment in the beginning of the treatment. So let's do the thinking of not committing these mistakes, okay? This is what I'm calling you now to understand and to do with me. So finishing in orthodontics begins with the bonding of the brackets and tubes. We're going to talk individually about all those situations, the centralization of brackets and tubes. For class 2 and class 3, we're going to say something that is important. Height of an angulation of during the bonding of the brackets and tubes. Those are very important also. So we're going to do this one by one. First of all, the centralization of the brackets and tubes. Why do they matter for us? Because when we commit mistakes during the decentralization, we're putting our brackets or our tubes outside the center of the teeth, looking obviously looking from behind, from above the models or their teeth. When you see these brackets, they are not centralized like this. We'll have something happening that we'll have to correct in some point of our treatment. For example, this case here, we have the decentralization. It is not centralized, the bracket in the tooth crown. You can see that it's a little bit distalized. The bracket was positioned a little bit distalized. So what happened? It went, the middle part of the tooth, it went down, or in this situation, it went palatally, it went in direction palatal, okay? So what happened here was this, and now we have to correct. We can do this We can do that very easily when you use bands, for example, a Z band, a first order Z band, but we are not talking about it now. We are just anticipating the errors. We are just trying to avoid the errors of the treatment, okay? So first thing, we have to centralize the bracket or the tube and the teeth, or the tooth, I'm sorry. So when we do this, when we do the centralization, the first thing is covered. We are not going to commit this kind of mistakes. We're not going to have to stop our treatment in order to correct something that we have done in the beginning of the treatment, okay? So this is important. Another thing that is important is to avoid the excess of composite in the base of the bracket. This is important because when you do this, we are incorporating we're incorporating something like an inset band, putting this kind of a rotation of the tooth going palatal, the middle part of the tooth, because the excess is located here, so it will work as an inset band, which we do not want in the majority of the case, of course. You may want that, but when you don't want this, what happens is that you have to correct. So in this case, you have this palatal movement of the medial part of the central incisor because you have this excess of the composite in the base of the bracket. So when you put the bracket, you have to make sure that you are squeezing the bracket against the bracket in opposition to the tooth. So it goes like this, and you have to remove all the excess that is incorporated during the bonding process. This is something that's very important, because when you commit this kind of mistake, you are doing something that you have to stop the treatment and to correct in some point of the treatment with bands or with rebonding the bracket, which is for the patient, which is not something that you would like to have, because you will have to correct, and we don't want that to happen. So we prevent this being very careful about the bonding process since the beginning of the treatment, okay? So we have here this excess in the medial part of the bracket, which is going to put the incisor it's going to input to the incisor a rotation, and this rotation will have to be corrected at some point of the treatment, okay? So this is a photograph of a situation like that, where the composite was in excess in the medial part of the bracket. So we had to stop and to do the correction of this thing that we did wrong. So we want to avoid that, doing the right positioning of the bracket since the beginning of the treatment. Okay, so centralization is very important, but are there some situations where we won't centralize the bracket or the tube in our teeth, in our group of teeth, or in our specific tooth? Yes, we have. In class 2 or class 3 cases, we have seen that before. McNamara is very precise about that when he says that when we have class 2 or class 3 cases, we can put the bracket in a different position as that position that we are centralizing in a normal, in a class 1 condition, because this thing, this detail can change the position of the cusp in order to do the centralization of the cusp between two teeth, two opposite teeth, of course, and this part of the teeth that it sits and gives that beautiful intercuspation. Let me show you, because saying is not that important, but seeing is very important. Let's show it now. So if we have a normal situation, a class 1 situation, we just try to centralize, to put the brackets and tubes centralized in the crown, looking obviously in this occlusal view. So what do we do in order to, let's say, facilitate our intercuspation in a class 2 case? Think with me. If we just move the bracket visually in this situation. What will happen when we do this leveling of the arch, when we do this straightening of the arch wire? What will happen to those teeth where the bracket is not centralized? They will rotate. You saw that. You have seen this in the anterior part of this class, and when we do not centralize the bracket, we'll have a rotation. And in this situation, in which direction will rotate those bicuspids? They will rotate distally. So they will rotate in this kind of movement, bringing those beautiful tips backwards, bringing those beautiful tips distally. So this is something that will allow us to correct smoothly a class 2, and the intercuspation can be better when we do this kind of trick. Sometimes we think we're doing something to cheat the leveling and alignment, but it's not true. It's just a little trick that will help you to finish in a better intercuspation. And I have to admit that I do that often. I really like to do this kind of movement because the intercuspation, the interdigitation of those tips in that position between two lower teeth, it's very beautiful. Let me show it now to you. This is an example in which I did this kind of visually positioning of the brackets. So you can see here that we move those brackets just a little bit forward in order to do the rotation of those crowns and to help the correction of the class 2 and a better and a beautiful intercuspation, as you can see here. So we have this class 2. Obviously, it was not just this tip that corrected the class 2. We had to do another thing. We had to do other things. For example, in this case, moving the mandible forward, and this patient used a forceps appliance to do the mandible, the anteriorization of the mandible. It went forward because of the forceps, but it helped when we did this kind of trick here, moving just a little bit forward, just a little bit visually, the position of the bracket. So in this case, you can see a nice intercuspation here between upper and lower premolars. So this is something that you can do just in order to help you to do a better intercuspation. Okay, so let me show you another tip that's very important for me. When we do the positioning of the bracket of the canine, something that I do very often is to move always since the beginning in class 1 or class 2 or class 3 cases. I move it mesially. I move it towards mesial, because when you do this, we do the rotation of the mesial part of the tooth, and the canine sometimes it not compensate the bracket. I'm sorry, it doesn't compensate the thickness of the canine compared to the lateral incisor. So when we do this kind of mesial, moving the brackets toward mesial, we do this kind of rotation, allowing to a better alignment of those teeth. So when we do this, we can prevent this kind of need of doing this bend, this first order bend, to correct the rotation of the canine, to correct the position of the canine. Let's see an example of this. So in this situation here, as you can see, the bracket is very mesial positioned, is mesially positioned, I'm sorry. And when we do this kind of mesially positioning of the bracket, it goes with the mesial part of the tooth, it goes toward buccal. It goes this way, it goes buccally. So we can have a better alignment between those two parts of those teeth. So we have here the lateral incisor, the distal part of the lateral incisor, and the mesial part of the canine. They are smoothly aligned because of this position. Let's take a look to the other side of this very same arch. Let's see here what happened. Let's see here what happened because of something that I missed during the positioning of this bracket. I just put the bracket in the center, in an occlusal view in the occlusal view, I put the bracket in the center of the crown of the canine. So what happened? The canine went lingually, towards distal in this position, or lingual in this kind of view here. So it went in this position. So what happened was a not soft alignment between lateral incisor and the mesial part of the canine. So of course you can correct this. Of course we can do bends for that or rebone the bracket. But if we anticipate this kind of mistake, we can do a treatment, more smooth treatment, without the need of going backwards in order to correct something that was not necessary to correct if we had this kind of care in order to do this positioning of the canine related to other brackets. Okay, so in this case, we can do, of course, you can do the correction. For example, you can use here this kind of band is a first order band, like an offset. We can call this eminence band, canine eminence band. When we do this, just this shoulder here and the arch wire to put this tooth to bring this tooth towards buccal in order to correct the alignment in this kind of occlusal view. So we can do this to prevent the occurrence of this kind of disalignment between lateral incisor and the canine. We can anticipate this mistake, and we can do just this positioning of the bracket more mesial, towards mesial. So this is something that's very easy to do, and we can have the correction in this situation. Okay, so first part of our course, we're just trying to anticipate the errors. We're trying to tackle this kind of something that we do during treatment, that we have to stop treatment. We are avoiding this, just paying enough attention in the first part of our treatment with the positioning of the brackets. There are some other things that we have to do, but for now it's very good. Just think about it, and we come back and... Hello, so we're back with those informations that are very, very important before doing bends. I have to say to you all the time that the first part of our course, it concerns to the anticipation of those errors that we commit during our treatment. So we are doing here the anticipation of the treatment, anticipation of the bends, because we are doing the treatment in a smooth way. Meaning we are doing the treatment without the need of doing so much bends and so much loops in order to correct something that we incorporated in the treatment because of our mistakes. So we're here trying to anticipate. First part, we are just dealing with the positioning of the brackets and tubes in order to avoid bad position of those tooth or those teeth that we have as a result of our bad positioning during the first part of the treatment. So now we're going to talk about the height of the position of the bracket, concerning to the height, concerning to the position, the incisor to the occlusal, through the incisor to the cervical part of the teeth. Okay. So in this part of our course, we're going to deal with the height, the positioning of the bracket and the tube concerned to the height. Okay, so we have to check all the time, because we can do some errors. We can incorporate some errors in this part of the positioning. What I mean with this is that when we think about the centralization of the bracket and the position, the vertical position, we have to think about the center of the clinical crown. Why we think about the center of the clinical crown? Kleber, are you not going to use a positioning device to put the bracket? No, I just focus on the center of the crown, because the majority of the brackets that I know, that I work with, they think about the positioning on the center of the crown, because the bracket is the pre-adjusted bracket. I mean, the pre-adjusted bracket is the bracket that I use. It probably probably you also use, because this is the most acceptable and most spread technique that we have today, nowadays. So we think about the center of the clinical crown because the bracket is designed to have that position to read the inclination, the angulation, and the ins and offsets that are incorporated, that are embedded inside those brackets, because they are pre-adjusted. So they have inside them both angulation and inclination, and they have in addition the in and the out that are the thickness of the base of the bracket that are incorporated in order to have a compensation of the thickness of each tooth. So let me explain it better with images. I love images because of that, because sometimes we just try to explain something, but an image is worth a lot in this kind of situation in order to clarify all those thinkings. So this is what I think when I put the bracket in the center of the crown. So here we are centralizing the bracket with the center of the crown. The base, the center of the base, the center of the slot is positioned at the same height. We're just talking about height here, not angulation yet, but we're at the same height of the center of the crown, the clinical crown, which is this red dot here, and here we have the center of the slot of the bracket, okay? So why does it matter so much? Because the inclination, especially the inclination in this case, of each bracket, of each tooth, each bracket, because we are having here a pre-adjusted bracket, we are working with a pre-adjusted bracket. So in this case, they have the inclination of each tooth embedded in its structure, okay, in its base. For example, if we have something like 0 degrees of inclination of the crown, if you want that, we have this parallelism between this blue line and this red line, which is the base of the bracket, this wall of the bracket here of the slot, and the base of the bracket itself, okay? So if we have something different, for example, 3 degrees of inclination, or 7 degrees of inclination, or more than that, 12 degrees of inclination, what we have here is the difference between the inclination of the base of the bracket. Most of the brackets work this way because they have this differential inclination they may have inside the slot, not in the base of the bracket. Some brackets are like this, but they incorporate some errors also. In this case, we're thinking a bracket with the inclination embedded in its base, okay? Their base are 2 degrees, 1 degree, 3 degrees, whatever the company wanted to put inside, so they have it in the inclination of the base of this bracket. So we have here 3 degrees, and we have here 7 degrees, and more than that, 12 degrees. So as you can see, we didn't change the inclination of the slot of the bracket. We didn't change it. It's in the same position since the beginning. So what changes here is the inclination of the base, okay? So what is this, how is this related to our inclination of the teeth, or of our tooth or individual tooth? In this case, every time you choose a bracket, you choose a prescription of brackets, you have to understand what the prescription will give to you in order to position the inclination correctly of your crown, okay? So if you want, for example, a class 3 with a huge inclination to the upper incisors, you pick a different inclination, different prescription compared to a class 1. In a class 1 situation, we have, for example, 7 degrees. We're talking about the Andrews prescription, approximately 7 degrees of inclination. If you're using this bracket in a patient which has a class 3 situation, you need a more inclined upper teeth in order to compensate the position of the mandible and the maxilla, to compensate the malocclusion. So, for example, 12 degrees. So what if we change the inclination, change the prescription of the bracket? Will change the inclination of the crown. Of course, we are just simplifying things here because we have many things to think in this situation. For example, the interrelation between the slot, the size of the slot and size of the bracket, the play between the slot and the wire, the slot and the wire. There is a play that we have to have in mind, that we need to have in mind in order to understand what is going to happen. We'll tackle this in another moment, but for now, what is important is to understand that we have different inclinations that are embedded, that are inside the slot, inside the base of the bracket, okay? That is built inside this base of the bracket. So 12 degrees, 3 degrees, 7 degrees, they will show different, they will display different inclinations, because when we put our full size arch wire inside a slot, it will read the inclination that is embedded in its body, in its base. So we have here this 12 degrees. When we compare to other inclinations, to other prescriptions, we should have those different inclinations, both in crown and roots of those teeth, okay? So this is important because we are choosing the prescription that we want to correct the malocclusion that we are treating. So when you do this kind of reading of the inclination, we are trying to do a more smooth, a more linear treatment without the need of doing many torques or many bends to correct individually the position of those teeth, okay? We know that's not what we are going to do in our day-to-day practice, but this is how the thinking goes. This what was planned when the prescription is sold, when the prescription is, when we buy the prescription to put in our patient, okay? So we try to do less bends, we try to diminish, we try to lower our treatment time, our treatment with the patient in our chair. So we try to lower this time, lowering also the need for doing this kind of torques and bends and loops wherever it needs. So we're trying to save time here in our treatment, doing the right prescription, using the right prescription, using the right torque, using the right positioning of our brackets in order to save time in our treatment. So we don't need to do this kind of torque all the time, of bends all the time, because we did the correct positioning, we did the correct prescription, we chose the correct prescription for those patients. So let's move on. What if we change the height of the positioning of the bracket, for example, in a central incisor, for example? What will happen to our teeth, or our tooth in this case? So let's think about the center. This is what we have. So when the teeth is perfectly positioned in its perfect situation, let's say, we'll have a bracket centered in the crown and this vertical aspect. So it is centered here. The reading of the torque here will be exactly 0, because the inclination of the tooth, inclination of the crown, you know that Andrews, when did this 6 keys of a normal occlusion, he thought just about the crown, and he prescribed those brackets, those nice brackets in the center of those crowns in a class 1 situation, firstly. And here we have a class 1 case where the central incisor is perfectly inclined. We're saying about inclination, we're talking about inclination here. So we have the central incisor with the inclination of 7 degrees concerning to the horizontal line, 7 degrees here, so 7 degrees of inclination embedded in this bracket, in this pre-adjusted bracket. Okay, This is important because when you put here our arch wire, our rectangular arch wire, full size rectangular arch wire, it will read the inclination that is built in this bracket. And what if we change now this height? What if we change now the position, vertically speaking, the vertically positioning this bracket, for example, upwards? What is going to happen? Now, we don't know the interaction between the inclination of the arch wire, which is 0, I'm talking about the relationship, or we don't know what will be the real relationship between the inclination of the vertical, the inclination of the transversal section of the arch wire, the rectangular arch wire, and the inclination of the slot of the bracket, because we changed the inclination. Remember, the buccal face of the incisor is not flat. It has this curvature here, which will change the inclination of the slot when we change the position that we put in our bracket. So in this case, we will have not a passive relationship between the inclination of the slot and the inclination of the rectangular wire, the transversal section of the rectangular wire. So they have now an active relationship, not a passive relationship as it was before. So now we know what we are going to have now, because it's going to generate here a couple when we do this kind of positioning of the arch wire. So now I'm going to position the arch wire inside the slots of the posterior teeth and inside the tube of the molar. When we do this, we'll generate here a couple which will generate a palatal crown torque. So in this case, even though you didn't want the palatal crown torque, you're going to have it, because the relationship between the rectangular arch wire, a full-size rectangular arch wire, and the inclination of the slot will generate a palatal crown torque. So this is important to have in mind, because sometimes you do that. Can you pick a situation where you do this very often? For example, an anterior open bite. In this case, we try to avoid the center of the positioning of the bracket, and we go in an apical direction. We go in an apical direction, and when we do that, we will change the relationship between the rectangular wire, a neutral, meaning no torque in the rectangular arch wire, and the angulation, in this case, the inclination of the slot of the bracket. So this is what we see here. Let's move on, and we have this palatal crown torque, which we didn't want at first. And the majority of the cases that I can think now, I don't want that. Why don't I want that? Because when we do this, for example, a class 3 patient with an anterior open bite, when you do this, we will throw the root of those anterior teeth against the cortical bone in the maxilla, for example. So they go with the crown backwards and the root forward. So the root goes forward and it goes against the thick palatal plate of the maxilla, which can generate root resorption, which can generate fenestration in this part of the buccal plate. So we probably don't want that to happen in the majority of our cases. Of course, you don't want that to happen. So take care of that, my friends. When you do this, you have to keep in mind that you have to do some kind of regulations here in order to avoid this situation, throwing the root against the palatal, the thick buccal bone of the maxilla. Same thing in the mandible, of course, but we are doing the example of the maxilla here. So this is what's going to happen, and if you want to avoid that, you have to prepare yourself to do torque. We'll deal about this later in our course. We'll talk a lot about torque. We'll speak it thoroughly because it's very important, this relationship between the rectangular arch wire and the position of the bracket. A rectangular arch wire and the inclination of the slot of the bracket. So this is something that we'll have a lot to talk about later in our course. So for now, you have to keep in mind that when you change the position, vertically speaking, when you change the position of your bracket, you're going to change the relationship between the bracket, the slot of the bracket, and the rectangular arch wire. Because what was thought for that specific tooth was a specific inclination that it's going to be read, it's going to be applied when you put the bracket in the center of the crown. In the center of the crown, in a vertical aspect. In the center of the crown is where you will have the right reading of the inclination of that bracket, that specific bracket, okay? So, is that important just in anterior teeth? It's the opposite. It's much more important in posterior teeth. Why? Because they have a huge inclination of their crown, especially the lower second and first molars. They have a huge inclination, lingual inclination of those crowns, and when we choose to do this kind of variation of the height, when you do the positioning of the tube, we can change a lot of the inclination of that teeth. Let's give you this example. The name here we have here, this expression, relative torques, are the reading of the inclination of those teeth, those tubes, those brackets and tubes, when you insert, for example, a rectangular wire with a certain inclination, which could be zero, could be a positive inclination or a negative inclination. We'll deal with this later, but now, just for explaining, just for understanding's sake, we're going to explain for you what is going to happen when you change the height in posterior teeth, which is very common. If you think about it, it's very common because sometimes you want to escape from the bite when you have a deep bite, trying to escape of the contact between the crown of the upper teeth and the tube. Sometimes we do that without thinking. We flee for that position, we escape from that position, going down with the position of our tubes. So sometimes you do that. Sometimes we want to do that in order to not be necessary to put, for example, bite ramps. Just go downwards a little bit and we think it's okay. It's not okay. In the majority of the cases, we have two problems with that. First of all, you will not have the crown leveling of the crowns of the ridges of those crowns because you have different position. So the first thing. The second thing, which many people don't think about, is the torque, is the inclination. So that's why here is written relative torques. Let's understand a little bit more about this. When you put, for example, a perfect positioning of posterior teeth, let's say a second molar. So you put the band here, you put the tube here, and at the center of the bracket, at the center of the tooth, So you positioned correctly, and now you have a neutral torque, meaning you don't have an actual torque in your rectangular wire because you didn't do this torque. You just bought those wires and they come neutral, and you put this wire here inside this tube. What is going to happen? Nothing. You will have a relative passive torque, meaning you won't have a couple generated here which would change the inclination of this tooth, this specific tooth. So in this case, the crown is well positioned, is perfectly positioned, and the bracket and the tube here was perfectly positioned during bonding, okay? So now, putting this wire here, a full-size wire, nothing happens because we have here a passive relative torque, meaning nothing will change concerning the inclination of this tooth. But what will happen when we change the inclination, when change the position, for example, upwards of the position of this tube. When we go upwards, when we go in an occlusal direction with this tube here. As you can see, let me move it again. As you can see here, we have now a different relationship between the inclination of this tube and the inclination of this wire. So now, when you insert the wire inside the tube, you will generate now a couple, you will generate now an active relationship between the wire, which is neutral, no torque, and the inclination of the tube which you moved. And since you moved, you changed the relationship, the inclination of the slot. So now you have a torque, an active torque, which we call a lingual or a buccal crown torque or a lingual root torque. Okay, and when you do the opposite, when you do in the opposite direction, when you go downwards, when you go apically with this positioning of this tube, what is going to happen? Quite the opposite. It's going to happen quite the opposite. It's going to happen a torque, a negative crown torque, meaning the crown goes lingual, the crown goes negative, and the root goes buccally. So when you change the position, when you go to the rectangular wires running our sequence of arch wires, we reach the rectangular arch wire, especially the stainless steel rectangular arch wire, we will change the inclination that those teeth or this tooth is going to read, because we changed the height of the positioning of the bracket or the tube. Okay? So I'm going to use two examples here of a situation where we have to choose between tubes of class 1 or class 2 cases. So I have a class 1 case here, up here, where we finished in this solid class 1 case, in solid class 1 situation, a molar having this intercuspation, this very beautiful interdigitation where we have this solid class 1. So here, down here we have a class 2 molar in a class 2 position. And what do we have to do in order to achieve a better settlement in this situation? Just use the right tube for that. So just for example, I have some situations where I need to finish my case in a class 1. So I use for that a 5 degrees tube for that, because using this I can have a better settlement of the cusp of the upper molar between the lower first and second molar. So we have this angulation built in here. So 5 degrees is the median of the angulations that I use, the tips that I use in my brackets. So what we have is a beautiful intercuspation. In this situation we have the settlement of the cusp, the buccal distal cusp of the first molar between the lower first and second molars. And we also have here the rotation, which brings a better settlement yet. So we have a class 1. If we do another thing, a class 2 situation, we don't need to have this settlement in a class 2 situation. It's the opposite actually. If we have this settlement here, if we have this angulation, better saying here, I will have this not very beautiful settlement in the anterior part of the arch. Let's see it again, how it goes. I will extract the first premolar and I will close the space. Now we have the canine in a class 1 relationship, the premolar in a class 1 relationship, and we have the first molar in a class 2. But what we have that is wrong here is this angulation, is the tip that this tube here brought me when I used it, because it was thought for a class 1 finishing, not a class 2 finishing. So in this case, what do we have to do? Just change the tube. But I mean, do it first. You don't do it after having this kind of mistake. You do it first. You think forward. Before doing the positioning of the tube, you have to choose the right tube. Are you going to finish in a class 1 or in a class 2? Are you going to finish with extraction in the upper arch or with replacement, for example, replacement of the canines by the lateral incisors by the canines? So is it what is going to happen to your case? Choose another tube. Choose a different tube from a class 1 tube. In this case, we will choose a zero-tip tube, which is a zero-tip tube for the first molar, meaning it will end in a class 2 relationship. The zero-tip tube will allow this angulation to upright the molar. So uprighting the molar, you have this better settlement of the mesial cusp of the first molar between the second premolar and the first lower molar. So we have here a better settlement. So how can we do that? Just thinking forward and choosing the right tube for that. In this case, a class 2 tube for the molar. Many prescriptions have this kind of choice. You can choose this kind of tube, and for example, a MBT prescription, this tube has like 20 degrees or 10 degrees of negative torque, but no tip and no rotation. So this is the tube that you want. You may be asking yourself now, but what if I do use an edgewise tube instead of a class 2 tube? Is it going to work for me? Yes, it will work for you, but you have to do the torque in the wire in order to compensate the absence of torque here in the tube, because the edgewise tube, as we know, is not pre-programmed, so it doesn't have rotation, angulation, or inclination. Rotation, tip, and inclination, or torque. So you will have to do the torque because it's the only thing that you need in a class 2 situation. So in this case, just use either an edgewise or a class 2 tube, okay? So you will have a better settlement. Compare these situations here. In the upper example, we have the class 1 finishing, and the lower example, the class 2, but both with a very good settlement, with a very good intercuspation. And let me try to use another example of that, how you can use your mind in order to change the outcome of the treatment. In this case, for example, when we have this first upper molar lost due to cavities or whatever, so what can we do to close this space? Remember, when you try to close the space using the force at the level of the crown, you'll have this outcome. So let's see how it goes. If we use just the force, if we use the tube, the class 1 tube for that, and we don't prepare to what is going to happen, I'm trying to do the retraction and I'm trying to lose anchorage. If I do that just without thinking, I'm going to have this outcome. I'm going to have the angulation of molars with the crown forward and the root backwards, and the angulation of the premolars with the crown forward and the root backwards. So this is what's going to happen. At the end of the space closure, I would have this kind of displacement of the roots in a V shape, okay? So what can we do in order to achieve a better result of that? Just think forward. I can do the angulation of the neighboring teeth, neighbor of the space, of course, and I can do the angulation that will change the position, like throwing the roots to the space of the extraction, okay? Remember, it goes against the extraction space with the movement. Now we go in this direction, just changing the angulation. So think forward. We can do that, just changing the angulation in order to help us to finish the case better. And we have to think forward in order to do the right torque also, because sometimes we do the angulation, we do the retraction, the retraction during the space closure, and I don't pay enough attention to the torque. We'll go We go to see this, we are going to see this in another part of our course, but it is important to think forward regarding the torque also, okay? So here we have the situation, finishing the space closure, and since I did this superangulation, trying to throw the roots towards the space, I did a better movement, more parallel movement. So this is what I achieved. This is what happened to this treatment. And if I didn't do that before, I surely had to, at the end of treatment, spend a lot of time trying to correct those positions. So think always forward. Plan and do whatever you have to do in order to shorten your time, your treatment time, okay? So in this case, what happened was just thinking of counteracting the tendency of having this very much inclination of the crowns. I did the opposite. I just put the brackets and the tubes, throwing the roots, directing the roots to the space. So this is the opposite that we have in this situation. Meaning now I have a more parallel movement. At the end of treatment, of course, sometimes I have to do some adjustments, but they are easier because I did it during the treatment, okay? Another thing that's important, if you want to do without the rotation, if you don't want the rotation, one tip is putting the force for palate in the palate also. So having this enforcement of the mechanics doing the counteraction of the rotation. So you can do, can put here a bottom bonded here, a bottom in both teeth, and you can put the force by palate also, okay? You can put in buccal and palatal aspects, so you have a more parallel movement. So what did we do here? We thought that we would have a huge loss of inclination, a huge inclination of the crown, and it would really be difficult to fix at the end of treatment. So before having this outcome, I anticipated that doing the angulation of both tubes and brackets in order to put the root, throwing the root towards the space of the extraction. So this is what I always think. What can I do in my treatment in order to achieve a better result without the need of stopping during the treatment to do some kind of adjustment? I adjust first. Before doing the bonding, before doing mechanics, I think what I'm going to have as a bad outcome of my mechanic, and I try to anticipate that and do whatever I have to do and use whatever mechanism I have to use in order to achieve a better result without the need of stopping the mechanics, okay? Okay, so in this case, just a simple angulation of brackets and tubes helped me a lot. Because if I didn't do that, if I haven't done that before, what outcome should I have in this kind of situation? What outcome should I have had in this kind of situation? Of course, not a translatory movement. Of course, not this almost parallel movement, but something like this, which would really compromise my finishing and would compromise my treatment time. Okay? So this is what I want you to understand. We have always to think about the bad outcomes of the biomechanics. And they are there. And we know them. Okay? So if we think forward, if we just prepare ourselves to counteract the bad outcomes of our biomechanics, we can do our treatment in a faster way, in a more smooth and direct way, straight way, and this is very good for us and for our patients, okay? Hello, now we are getting in the main part of our course, meaning we're getting in the practical part of our course of orthodontic solutions. We are going to see now the first order bands, loops, elastics, torques, anything that you need, everything that you need in order to get the best results in orthodontics, the best results in refinement of orthodontic cases, okay? So the first of those bands that we are going to address is the first order bands. First order bands because they are the easiest bands that we can use in orthodontics. They are easy to do, they are easy to think, so it's good to begin with them, okay? So let's see how we do these bands, let's see how we're going to use them. We don't use that much the first order bands because we have other options that we can put in our armamentarium in order to have the same result using less force, using less amount of force. So this is important for us, especially in the lower arch. When you do bands in the lower arch, we don't have an interbracted distance so big or big enough in order to apply a low level of force. So this is something that we have to take into account when we are going to choose which kind of device, which kind of band or loops we are going to apply in that situation. So with that in mind, if you want to do a band, a first order band, just think, can I replace this first order band for example, a loop, a simple loop, a double loop, or something like that? If you can do this, it's better for you, it's better for your patient, it's better for the treatment. Since you have less force and you can do just like a more physiological, do that in a more physiological way. I'm going to show you cases where I use this band, but I have to say that these bands are not my preference, but I do them in some situations where you can solve some cases, solve some problems. So first order bands, it's all the bands that you do in the horizontal way, meaning when you look from above your model or your dental arch. So you're going to do the bands in a horizontal way. They are called first order bands. So when we do this, for example, a Z band in order to correct a rotation, or a inset band in order to correct or to adapt a different thickness of teeth. So you can do this, you can use this kind of band here or this kind of band here. So first order bands are those made horizontally in the arch wire. So we do the bands just looking from above. If you put your band, if you put your arch wire seated on a glass slab, you see that you go out of the contour of the arch wire just in that place. This is important. So these are the first order bands: insets, offsets, canine eminence bands, which is like something like a shoulder, like a shoulder. When you do this kind of band, a curve, for example, we call them eminence, canine eminence. You do that obviously in canines. Toe in, toe out, first order Z band. So we have some options of bands to use to solve problems or to adapt to some situations, some special situations. This is what we are going to do now. Inset band. So it's very common if you did edgewise for a while, if you are, or this time you did with some patients, used an edgewise appliance, not programmed appliance, for example, an edgewise, a regular edgewise, standard edgewise. You had to do that, this kind of band, because the bracket, it doesn't adapt, it doesn't compensate the thickness of the lateral incisor, which is thinner than the central incisor and the canine, their neighboring teeth. So when you do this in an edgewise appliance, you don't want to put your lateral incisor in the arch wire. You don't want to go towards palatal with the lateral incisor. Usually you want to adapt the difference between the thickness of the lateral incisor, the central incisor, and the canine, which is something like 1 millimeter of difference in thickness from the contact points to the most buccal side of the lateral incisor, comparing obviously to the central and the canine. So this is something that we usually do in edgewise appliance. But you have some situations, for example, when you have a peg-shaped lateral incisor, you have to adapt that also because you don't have the thickness. Even if you are using a pre-programmed bracket, a pre-programmed straight wire appliance, sometimes those thickness embedded in the bracket, they are not enough. Let's say they are not sufficient for doing this kind of compensation. So you have to do a little bit more, and for that you can use this kind of band, a first order band, because if you have a thinner lateral incisor compared to the neighboring teeth, you are going to have this lateral incisor more buccal. Its tip is going to be more buccal because it goes like a little bit forward because of the thinner shape of this lateral incisor, which comes with the comparing to the central and canine. It brings them, those lateral incisor, a little bit forward, but just inclining them. So sometimes you have to do this kind of bend in order to compensate or in order to correct, if you didn't do that before, in order to correct that difference between lateral incisors, central and canine. So you do this kind of bend to align the tips, to align the tip of the lateral incisor, the central incisor, and the canine cusp. So for that, one option that we have is using this kind of band. It's making a first order band to go towards palatal with the lateral incisors tip. So this is what we do, and this is what we expect to happen when we do this kind of band in order to correct this difference between the lateral incisor, the canine, and the central incisor. So this is not always that you have to do, because your pre-programmed brackets, your pre-programmed straight wire appliance, it has compensated inside its base the thickness that you don't have in the lateral incisor. So sometimes you have to do that because you don't have the exact amount of the thickness of the base in the lateral incisor bracket. Sometimes you do that to compensate. So first order bands. What's important in a band like this? As you're going to see when you show you how to do step by step those bands, the practical part of our course with exercises, you are going to do this band, but you can't get out of the contour of the arch wire. If you do that, you're producing another kind of band. So you have to do the band, the inset, you go inwards, you go towards palatal. So you do that and you go back to the contour of the arch wire without angulation in this part of the band. So this part of the band is parallel to the anterior segment of the arch wire. So it just goes inside here and here. Then it goes back to the natural, to the contour of the arch wire. This is important for us. So how do we do this? How do I show my students how to do that? So for me, I start as a reference the medial part of the arch wire. So thinking always doing the first bend medially to the plier, thinking about the arch wire, the center of the arch wire, the center of the midline. So you start from there, and goes to the end of the arch wire, doing this bend this way, starting medial to the midline. So you do this kind of bend. First, you pressure your toe. For example, I use my toe for that. You can pressure your toe against the arch wire, grabbing firmly the plier here. Don't let the plier, don't let the wire rotate with the plier. You have to grab it firmly. So grab it here. You have to mark. You have to do the marks, of course. You're going to see step by step in the practical part of our course. So this is what we do. We grab the arch wire here and we go inwards here. We go inwards towards palatal, okay? So pressure is applied here from the thumb to the wire towards palatal. Okay, so this is what I do. The first is the in band, then you go without removing the plier, you go now you go out, you go buccally, you go towards buccal, put your finger, your index finger for example here, then you put this pressure and the opposite direction that you put the first pressure. What you can do in order to facilitate that for you is to give a little rotation of your wrist. Your wrist goes like this in order to help you to do the band. So this is something that I do, and once you get used to that, you're going to do that naturally. So you go with the pressure and you go with the wrist rotating, okay, like this. Pressure here and rotation in the opposite direction. It helps you. So here we're going to show how to do, but when you go to the practical part with the exercises, you are going to understand it better because it goes with videos and you see the video and you try to replicate that and it's easier for you to understand. But this is how I do. First in, then out. Keeping the plier on the same point, the second movement is done with the index finger distal to the plier on an anterior direction, meaning you go outwards now. So you first went inwards, now you go outwards. So first mesial, you have here the midline, the mark of the midline, then you mark the position of the lateral incisor, the mesial of the lateral incisor. So first you go inwards, then you go outwards, in and out. This is how I explain because it's easier for you to understand how this go in and out, because it differs if you use different relations, if you use different point of views. So I first go like the mesial part is my first band, then we go the distal part of the arch wire, the second band, without removing the plier of its position. So this is how I do. So first one, then you go out. First in, then you go out. This is how we do. As you can see, mesial, in, and you go distal out. Mesial, in, and distal out. Let's see it again. So you grab with your plier the arch wire, then you go mesial to the plier, in, and distal to the plier, out, without removing the plier of its position. This is how we do. At this point, you may be thinking, but we have pliers that are specifically used for this kind of bend. Yes, there are, but they don't have all the magnitude of the bends that you need to do. And sometimes you want to do a different bend, like an asymmetric bend. Here you go this way, you go with more angulation, less angulation of the active part of the band. So this is important. How do we do this? We do like that because I think it's more controllable. We can do we can control this band this way. We go in and we go out. We can do a little bit more or a little bit less of angulation when you do the band, so it will produce different bands. A lighter band or a heavier band. So this is something that we can do using the angulation of the first pressure that you're using. You can do a little bit more or a little bit less marked bend. This is something that you can use, and you will see during the course of your day-to-day practice that this is something that is very natural. You don't need many pliers for that. You don't need to choose the plier to search for your plier. You have this very beautiful plier, the 139 plier, or bird beak as you can call in other countries, or a jarabac. This is the same plier. So this is something that you can do with other pliers. Yes, we can, but this is something that I do with this same plier for most of the bends that I use in my practice. Keeping that in mind, we're going to the other bend. Now it's the opposite. We're going back. Now we're going back to the contour of the arch wire. So we go exactly the opposite that we did first. Now we go first outwards, then we go inwards, okay? So this is the second bend. We go outwards, then we go inwards. This is the second band for this inset band. As you can see, it's quite the opposite that comparing to what you did before. So we go first out, then you go in. First you go out, then we go in. Let's see it again, just one more time. You go out, put in your finger and the middle, you go in, put your finger and the distal to the plier. So this is the reference that I use in order to try to teach my students how to do. First you go out in this band, then you go in. Let's see it again, just one more time in order to facilitate the comprehension. So we go the first band, medial, so we go first inwards, then you go outwards. Again, inwards and outwards. So the first band is this, go inwards, then you go outwards. This is something that it's quite natural when you do it a lot. So you have to practice in order to understand that. This is the first band of an inset band. In and out without removing the plier of its position. Then you go, now you go in the second part, meaning the distal band related to the lateral incisor, go out, then you go in. So you go, first you go out, grab the plier, grab the wire with the plier, medial out, distal in. Again, let's see just one more time. We go up, now we go medial out and distal in. As you can see here, I'm using both my finger pressure and my wrist rotating. So I'm going both here. Rotating wrist and the pressure and my fingers, okay? This is the inset band. How can we be certain that this band is quite what I wanted to do? We can go in our, put this kind of band in a white paper or in your glass slab. In your white paper, it's better to see the first band that you do, and you try to see if you are using the band the right way, meaning you don't have an angulation here. Any angulation is produced here. We have the contour of the arch wire maintained. If you just think like a thin mark here, you're going to see that we have the continuing of the arch wire. In this part, you have the same contour here, and you just have this little part, which is the part that is active in the band, that is inwards, okay? So it's necessary to preserve the original contour of the arch wire. So this is something that is easy to understand since you do it a lot, okay? This is the first order band, the inset band, okay guys? So now we're back with another band that we use, not that quite much, but when we have to use, we have to understand. We need to understand how it goes, we do this kind of band, how we make it, and in what situations can we use this band. So the out band, the step out, it's another band that we can use that is the opposite of the inset band. It's the out band or outset band or step out. We have many ways of calling this kind of band, but the same thing, the same thinking of this is just when we want to go outwards with the buccal surface of our teeth, of our tooth. You can use it in more than one tooth, of course, but it's more used in just one tooth. So we go outwards first. This is the way we can do this kind of band. We grab the plier, grab the wire with the plier, then we go out, and after that we go in. The same thinking of the inset band is applied here. So first we go out, then we go in. The opposite of the inset band, but the same thinking. Without removing the plier of its position, we go first medial out. Remember, When you did that before, we did the inset band, we started going inwards, then outwards. Here we go different. We grab the wire with the plier, the marked position, then we go medial to the plier, meaning in a direction of the center. We go medial to the plier out, then we go in. Let's do it again. Let's see it again. First we go out, outwards, then we go inwards without removing the plier of its position. Another thing that is important here, it depends on the kind on the wire that you're using. If you are using a rectangular wire, it is easier not to rotate the wire, because you grab the wire here and it's difficult to rotate the wire. But if you are using for example, a 0.018 stainless steel wire, you have to grab it firmly, because if it goes in another direction, you will produce another kind of band, not just one first order band, probably a second order band, because you're not going horizontal to the plane, you're going in other direction, in other sense. So you have to grab firmly. Remember, you can use both round wires or rectangular wires. You can use stainless steel wires or TMA wires. It depends on your choice. I usually use the stainless steel round wires to start with these bands, because as I said before, this kind of band is done when we make this kind of bands when we have something to correct, and this probably you are in the beginning of your treatment yet, so you're not you haven't reached yet the rectangular wires in the sequence of wires that you are changing. So in this case, we can start with the round wires, the correction with the round wires. Then you go again in other wires with the correction. If you haven't corrected yet, you go with another band. You can intensify the band. You can keep the band if you want, or you can just, if you have corrected the problem, you can remove the band, but you have to do the correction by means of rebonding the bracket. So remember, this is something that we do in order not to go back in our sequence of wires. We go forward in our sequence of wires. So we have something to correct. You don't need to rebond at that moment. You don't need to remove your bracket and bond it again at that moment, because you can do the bands. And once you have, since you have the correction that you want, so you go with another band, with another wire, you don't go back, you go forward. So you go with another wire, a thicker wire, a stainless steel wire. You can change the band if you want. You can intensify the band. You can go with another direction. And when you have everything corrected that you wanted to have, so let's give an example. You have a step out band because you want to go buccally, you want to go towards buccal with the surface of your tooth. So you did that, it's not enough. You do in the second wire with another band, a more marked band, and you go and correct. Now everything is all right. You can do both. Keeping the band in position, a passive band now, because you don't want to correct more, because it's already corrected. Or you can just remove the bracket and bond it again in a passive way, meaning you put the bracket in position. Now you go with a straight wire, without bands, and now you just do the bonding passively, without need of doing any kind of adjustment, because now you have everything correct. So remember, this is something that you do because you don't want to go back in your sequence of wires. You go forward. So you can, doing this kind of band, you can do your treatment and in an easier way and more fast. It is faster. Remember, you do forward, not backwards. So this is important for us. This is the out band, the step out band. First band. Let's go to the second band now. The second band of the step out band. Sure, of course. Now you go inwards, medial, and without removing the plier, we go buccally, we go towards buccal or outwards distal. Let's do it again. Let's see it again, just in order to remember. Let's go. We go first inwards with the finger mesial to the plier. Then we go outwards with the finger distal to the plier. Again, what is important here is to keep the contour of the arch wire. You just have this band here, this active part of the band here, which is parallel to the contour of the arch wire. It's not angulated, okay? So we have here just a step out band, okay? And what is the way we can do to be sure to be completely certain that we are going to do the right thing for that tooth? We go with the band, we put the arch wire in the neighboring teeth, and we can check if the band is doing the movement that I want it to do. So in this case, I won't show you what is the case, but in a while, in some classes ahead in this course, I'm going to show you how to do this in rectangular wires and why we do this when we apply, for example, a second order band. So this is a band that's important to understand because we're going to do it frequently when we do, for example, an extrusion band. And I'm going to show you why we do that. But keep that in mind now. If you're doing an extrusion band, sometimes we have to do an step out band to compensate the tendency for another movement that we usually don't want. So keep that in mind for now. We're going back with this information. Don't be frightened. This is something that we're going to do easily, smoothly, and you will understand for sure. So this is the step out band. We do that band frequently when we do, for example, an extrusion band, a step down or extrusion band. So this is something that we use it much, with very, very frequently, okay? So another band that we use still in first order bands is a Z band, a first order Z band. Why do we do that? For example, in cases where you have a rotated tooth that you want to do the derotated, so you do this kind of band. But remember what I said before, I don't do this frequently because this band, especially in the lower arch, it's not a good band to do the correction because it intensifies the force that you're applying because the interbract distance is too short to have this band a smooth band. So it's hard. There are other options for that kind of bands, and we can substitute them with, for example, loops, which are very simple, and you will understand how to do and how to apply. But this is something that we, in some situations, with a slight rotation, for example, lateral incisor or a canine, we can do this kind of band in order to have this correction. So this is something that I don't do frequently, but sometimes I do. And when I do, I prefer to use lighter wires or, for example, a TMA wire because it has a less force applied per activation, less force per activation. So in this case, I prefer to use a TMA wire because it releases a less intense force in this kind of situation. How do we do this band? This is different, for example, for comparing to a inset band or out band. This is something asymmetric in its angulation. So we have an angulation here. We're going to do two bands now with in the same direction, but we have to keep in mind that the active part of the band, it has to be angulated, not horizontal, okay? And we'll show if you do that different from that, you'll have a different outcome in your treatment, in your correction that you want to have, so, okay? The first order Z band has as final result an angulation on the segment of the wire that will be engaged to the tooth, meaning the part of the wire which you will insert inside the slot of the tooth that you want to correct. Okay, so in this case, in such situation, we have to produce an angulated band. Okay, let's show it now for you. First, an inward band. Okay, let me tell you something different here from what you have been done till now. But in this case here, in this specific case here, we will have to do an angulation, but we have to keep in mind also in what direction we want to do the derotation. We want to derotate those tooth that we want to rotate, those teeth that we want to derotate. In this case, for example, I'm going to produce a Z-band, a first order Z-band, but this specific Z-band is going to rotate going medial in your tooth. Inwards, it will correct, bringing the medial part of the tooth inwards and distal part of the tooth outwards or towards buccal. Okay, first band is going to inwards, go in, and the second out. First bands go towards palatal, and the second band goes toward buccal. This is what you want in this situation, in this specific situation. You want to derotate the tooth, putting the medial part of the tooth inwards and the distal part of the tooth outwards, meaning it is rotated with the medial more buccal and the distal more palatal. So you want the opposite now. So this is the band that you're going to produce. The first band, we put that force that we know, that we already know, first grabbing the arch wire with our plier. Again, the Birdbeak, the 139 plier, it's what I'm using in almost all my bands. And now I put for the first pressure medial, okay, first pressure medial, and the second pressure distal to the plier. The first pressure inwards, the second pressure outwards. The first pressure towards palatal, the second pressure towards buccal. This is what we do. And again, we're going to have this in a more practical way with the exercises that you're having to. I'm just advising you that it's important for you to do, to practice, because you have those exercises to practice in order to be natural in your mind. There's a point where everything goes natural for you, but till you reach this point, you have to practice a lot, okay? So first, inwards, this is the second band, it goes outwards, okay? And since we did that, we have to keep in mind that this part of the band, it has to be angulated. It has to have an angle in it, because this is what is going to correct the rotation. The rotation will be correct by means of the contact point that you give medial and the contact point that goes distal when you put the wire inside the slot, okay? It's going to be easier to understand when we show the case. The next two bands, repeat the sequence on the first ones. Initially is pressed towards palatal, is the arrow, the red arrow here. So we're going first palatal towards palatal or inwards, then you go outwards or towards buccal here. Okay, the second, the medial segment of the wire with the thumb. So this is how we do. First pressure here, and the second pressure outwards. Okay, with the plier still firmly positioned, the wire is pressed buccally in its distal segment. So this is the same thinking, and we have two bands in the same direction, but in this case we are producing a very, very specific band because it goes angulated in this segment here. Let me show you. So we have here the second band with the plier still firmly positioned. The wire is pressed buccally in its distal segment, meaning we go outwards. So we have two bands in the same direction. First, we grab the wire with the plier and we firmly press inwards and outwards. Again, inwards and outwards. Difference here because we have an angulation in this portion of the arch wire, in this specific part of the arch wire. Let me ask you something here. Just stop recording there and think with me. What kind of correction you're going to achieve, you're going to obtain using this kind of band here? What kind of correction is proposed by this kind of band here? Is it a correction to putting the mesial part of the tooth buccally and the distal part, the mesial part palatally and the distal part buccally, meaning you want to go inwards mesial and outwards distal, or the opposite of it? As you can see here, just think about it. Think about the band, the first band. It goes inwards, so we go inward in the mesial part of your tooth because it goes touching here in the bracket. So it goes forcing the bracket in this part of the bracket, which is mesial, forcing this part of the bracket inward. And the outward here, the distal part of the bracket is going outwards. So this is what we want. We want to derotate this specific tooth going inward mesial and outwards distal. So this is what we do in this kind of band. What is important here? Again, to have the same contour in the mesial and the distal part of the arch wire. If you do not do this kind of specific contour here, if you fail doing this, meaning you don't have this kind of continuity in the mesial and the distal part of the arch wire, if you don't have it, you produce different band here. You will produce, for example, a inset band or this or outset band in different parts of the arch. Let me show you. It will be easier to understand now. This is what we don't want. In this case, we have two steps in the same direction, but we don't have the angulation here. This part here is not enough angulated, so it won't do the rotation. It's almost as if you have here just a step out band and another step out band. So this is something that you don't want. So keep in mind that much more than doing this kind of band, you have to practice to be very, very specific in this kind of contour of the arch wire. Because if you don't do that, you won't have the correction, meaning you don't have the correction you wanting to have. So this is something important. Check all the time if you have this continuity of the arch wire, if you have this arch wire in a line, and don't get out of this kind of line here because it goes in a different direction that you probably don't want. So we have here two step out bands. We don't have, in this case, this band, which is what we are producing now, we are making now. So this is the band we want. The mesial part is inwards in relation to the contour of the arch wire, and the distal part is outwards in relation to the contour of the arch wire. So we have now what we call the Z band, the first order Z band. Okay, so this is what we want. We want to derotate this tooth here, going outwards in the mesial and downward and inwards in distal. So we go towards buccal and towards palatal. So we go, and this rotation here, we are trying to do this derotation here. So in your mind, what do you think about the first band here? Does it go outwards or inwards? Of course, you already know that goes outwards. So the first band is out, second band in, another out and in, keeping the angulation in the point that you want to correct. So we're going to see it in a thorough way in our exercise, in our videos, step by step. Okay, here we have it. And this is another tip for you. When you do this kind of band, you tie this portion here of the band, because it's easier for you after you do that to do to tie the arch wire to the bracket, to the slot of the bracket. When you begin doing the tying here, so you go first in this place. Okay, this is something that I say. Let me show you. This is the correction proposed for this case to derotate that tooth. This is an example of it, which we have seen before in our first classes. This is that tooth that was rotated because of a bad position of the bracket, and the central, it was not central to the crown, so it went out of the center, and that forced the tooth to have this rotation. So we are trying to derotate it. As you can see here, we have a rectangular wire, but it is a TMA wire. So if I'm doing this, the first bend I'm doing in the rectangular wire, I don't do this kind of bend at all, because it's very rigid. What do I do? What can I do? I can go back. It's not good, but I can go back, and I can go back to a round wire, stainless steel round wire, or if I don't want to do this, I can use a TMA wire, which is softer than the SS wire, the stainless steel wire, and do this bend in the TMA wire, which is the case here, okay? And we have the correction made in just 1 month. So now I can go on with my stainless steel arch wire just to keep the correction in position, okay? Since this is a sapphire bracket, I didn't want to change it because it's expensive. So I kept this kind of bend in the sequence of wires that I used, okay? Which is very normal, which is feasible, so you can do this. Another thing, since you want to have the complete correction here, you don't use elastic ligature for that. You use stainless steel ligature for that, and this is what I do every time that I use bands and loops. I use stainless steel ligatures because we don't correct it with the elastic ligatures, okay? Here the correction, after the correction, maintaining it in position. Another tip that is important for you when you do this kind of bend, sometimes in round wire especially, you have this instability of the position of the bend. It goes mesial or distal because it's very, very easy for it, because it slides, the bend slides and it goes out of the position. What can you do to avoid that? We can use stops in specific positions, very, very close to some brackets, distal and mesial to the bend you're doing. So we use that in order to avoid that the arch wire, it slips out of the position and it slides out of the position. So we do this kind of clamping the wire in this position, avoiding it to rotate, okay? So you have a more rigid, a more specific bend in this situation. As you can see here, step by step, first I start with this, then I go like this, I put the ligature, putting it inside the slot in order to have it doing its job. So this is what I do first here, then I do in the other parts in the neighboring teeth, okay? Position, and now we have this clippable stops in position, and we don't allow the arch wire to rotate, okay? So the bend will be much more efficient if you use this kind of procedure here. So this is here in position, a little bit of an IPR here, interproximal reduction. So we have the teeth, both teeth here, these two teeth here, they are more they will easily do the correction because we don't have a very rigid contact point here. Sorry, a very rigid contact point here because we did an IPR in this position here. Okay, so after a while we waited, but after that, as you can see, I quit doing this kind of bend and I went for another option which I use more frequently, which is the the loop, the simple loop, the double loop with simple activation that I'm going to show you later, but did the rest of the job. It did the rest of the job for me, okay? So this is how I use this kind of thinking of correction of derotating tooth using a Z-band. And as I said you before, and as you can see, sometimes I have to change my option. And the Z-band, especially in the lower arch, it's not that good because of the interbracket distance, which is very, very short, and we have a very, very rigid arch wire, and we can't do the whole correction sometimes, okay? So we have options for that. That's important. We have options, and we're using the options we have, okay? Hello, my friends. I'm back with you here with another kind of band that I usually do in some situations where I have to do the alignment of the tips of the lower incisors with the canine. For example, the canine is a tooth. We've seen that before. Can you remember in the first part of our course, we tackled the situations where we do not want to get here to do the bend. So we, in advance, we think what we can do in order to avoid this kind of bend that we're going to show now, which was doing the positioning of the canine more mesial. Just for you to remember, we did that before, thinking of doing forward or thinking forward in order to avoid this kind of bends. So this is something that we do. I usually do that because I don't want to have this, to stop my cases, to stop my treatment, to do bends. If I can do it smoothly without the need of doing bends all the time, for me is better. For my patient also is better. And we go in a more, a faster treatment this way. So if we haven't paid enough attention for this kind of situation, and we put the braces, we put the bracket in the center of the canine, and the canine has this huge difference of thickness between it and the lateral incisor. What can we do? What can we do, and what is the wrong outcome that we will have, the thing that we'll have to correct is this kind of step between lateral incisor and canine. So we call this band an canine eminence band, because it's it's a little bit different from a step out band, an offset band, because it's not angulated. We do like something like a curve in this band to accommodate the position of the canine and the canine curve, the canine eminence itself, okay? So we have seen this before. This is why we have this canine discrepancy between the canine and the lateral incisor, because of the thickness of the canine, which is not always compensated in the base of the brackets, even being a fully pre-programmed bracket. So we have here the canine, which is thicker than the lateral incisor, and when we put the canine, the bracket of the canine in its center, what happens is that it goes inwards, it goes towards lingual, because it's much thicker than the lateral incisor. So we have this discrepancy here, which sometimes patients complain of. So sometimes you have to do this kind of correction. What can we do in order to avoid? Just remember, we can do this. We can put the canine more mesial. So being more mesial, it will be closer in thickness this from this, okay? So in this situation, when we put it mesial, we have more possibility of having a smooth alignment of the tips, because we have here the bracket more, the bracket is closer to the point of the contact point of the canine, okay? So this is what I was trying to say. The bracket is closer to the contact point of the canine, so we have the difference is not so big now, and we can have a situation more aligned arch in this regard, okay? So this is what I mean. It goes outwards here, and we have a tendency of being more aligned in this case than when we put the canine, the bracket of the canine in the center of its tooth, okay, of this tooth. So this is the example I gave you before. So we have here in one side, we have the canine more aligned, and the bracket here is more mesial, and it's okay. We think here we have a very, very good alignment, or very, very good contour of the arch wire without that discrepancy. But in the other side, we have a different situation. We have here this discrepancy, and we need to accommodate that with a band. Why did it happen? Because in this side, I didn't put the canine more mesial. So as you can see, even when we put the bracket in the position that it's supposed to be, which is mesial, which is centered, which is centered in its crown, sometimes we don't have the right alignment. In this case, it goes, sometimes you have a beautiful alignment, and when you do that, you go in your sequence of arch wires. When you reach a very rigid arch wire, for example, a 1925 arch wire, stainless steel arch wire, then you see that discrepancy occurring. So this is something that we have to avoid, but when we have this outcome, we need to correct this. So what can I use to correct this? A kind of offset band, which we call the canine eminence band, because it's sometimes you can do this different from the just an offset, an angulated offset band. How can we do that? Let's see. This is the problem we have, and in this side, I'd like to have it corrected. How can I do that? I use this band here, which is 139 mesial. I can go outwards, distal to the band. This is just one band, so I don't have two bands. This is just one band. So what I do, let's see it again. What I do here is go first. I grab the arch wire with my plier, then I go outwards, distal to the plier. Then I give the arch wire 3 tiny bends, trying to do this curve here. As you can see, we don't have an angle here. We have something much closer to a curve, here than just one offset band. So that's why we call canine eminence band. This is something that we do just for the canine, when the canine is in a wrong situation, and we do that in order to accommodate that. And it's very easy, very simple. Usually in 1 or 2 visits of your patient, 1 or 2 months, you have it correct smoothly, and now you can do whatever you want to do, whatever you need to do, but you have the correction already made. Okay, so we can do this, and we often do this in situations where we don't have the canine perfectly aligned to the lateral incisor, to the distal of the lateral incisor, and it occurs more frequently when we do not do this kind of compensation when we do the positioning of the bracket. As you can see here, this bracket is more mesial, and the correction here and the alignment here is perfect. And the other side, we have the positioning of the bracket is centered, and in this case we don't have that alignment, so we had to do, in this case it's mesial, and we don't have the alignment, the perfect alignment of this this 2 teeth here, 2 neighboring teeth here. So lateral incisor and canine. So let's see it again. It's good for us to see it again, to fix the way to do, fix in our mind the way to fix the teeth. Okay, so this is how we do. This is a canine eminence band. Good, but is there another way to do that? We're talking about solutions here, aren't we? So talking about solutions, is there another way to do that? Sometimes yes, there is. For example, here, in this case, I did it wrongly. I did it very bad. So what in the end, we saw this. At the end of the treatment, there was this huge discrepancy between lateral incisor and canine, which sometimes is due to a huge inclination of lateral incisors, so we have to tackle in another manner. Now, in this case, where the lateral incisor or the incisors are very well inclined, the problem is my position of the bracket. So what did I do to correct this? So in this case, I didn't want to go back in the sequence of the arch wires. I didn't want to go back doing the correction in a round wire, then go into a thicker wire till I reached again the rectangular arch wire. So what did I do for that? I just simply put the bracket more visual. I rebonded the bracket more visual, and I thought that would be a very good option here to put this kind of chain ligating the molar to the canine. So here I have, since the force is applied buccal to the center of resistance of this tooth here, I will have a rotation in this kind of movement, which can facilitate my correction of this tooth here, okay? So in this case, I didn't put the wire inside the slot, I just ligated it with a chain which was ligating the canine to the molar. So in this case, the rotation, which is usually a bad outcome when we use this kind of chains, in this case, I wanted it. I wanted to have this kind of rotation because the force is applied medial and applied buccally to the center of resistance. So I have this rotation as a side effect, or a weighted and a very good side effect, meaning this is something that I usually don't want to have, but in this case, it was a good outcome. It was something good for me. So I waited, and the first month, a good correction, but not enough yet. So I did another month. I changed the chain, and in the second month, I could see the perfect correction of the positioning of this rotated canines. Both rotated were derotated with this kind of solution. It's a simple solution. Sometimes it takes much more than 1 month or 2 months, but usually if you don't have contact points, so that's why we sometimes have to do here a IPR, proceeding IPR, the interproximal reduction, just using samplers for that, or just using those things that we use to separate teeth. So we have this kind of thing here, used here and here. This is enough. Those same strips that we use for IPRs, just that. And now we don't have the contact point here, so it frees the canine to rotate freely. Okay, this is what happens in this situation. So just another way to do this derotation when you have this step in a lingual aspect looking from above. So you have this step here, this discrepancy here of alignment. So you can do this in order to have the quick correction of this rotation that you got because of many problems. One of them, as you can see now, as you know now, is the positioning of the bracket. So putting it more medial in the canines, sometimes you can avoid this kind of bad outcome. Okay, so this is just a tip. It's important because we have one more information, we have one more way of treating this. So we're here enriching our armamentarium with many solutions that can help us in many situations. You can do that, for example, in premolars. You can do that without the need of doing the couple in the premolars. You have just one premolar rotated. You just put it more medial for if you have to rotate it distally, and you go like this with a chain, a simple chain, and removing the contact points. You can have the correction done very quickly. And after correcting, of course, you have to remove it, the appliance, and now you put a passive arch wire, meaning without the need of being active again to do the rotation. So this is how we do in some situations. and this is how I did in this case, okay? Hello, we're back now with another kind of band, which is a second order band. What is a second order band? So they are bands that are made in the vertical direction of the arch wires. As you can see, when you do the vertical bands, we want to do like angulation or tip, or we do intrusion or extrusion. So those are the bands that we use a lot in our orthodontic cases. We do that too much when you do, for example, a simple extrusion or slow extrusion or orthodontic extraction. So those are the cases where we use a lot this kind of bands. And when we want to do the correction of the tip, so these are situations very common in our practice, and we are doing this kind of band in order to correct or in order to do the whole treatment. Sometimes we just want to do this extrusion, the slow extrusion, for example. Sometimes our patients are referred to us just to do this kind of specific movement. So if we know how to deal with this kind of band, those extrusions, those little slow extrusions, we can do a whole treatment just based on the knowledge of this kind of band. So this is the second order bands, okay? We're going to say much about the intrusion extrusion later, but now we're focusing on the angulation, on the tip of the tooth or a group of teeth, okay? So in these cases, when we want to do the second order band in order to correct the angulation, we are doing almost the same thing as we do when we do the rotation, the derotation of the tooth, as we've seen before. So in this case, it's almost the same thinking. And now I'm going to show you step by step how to do this before you do the training on your videos, on the videos that you're going to receive, to do the training and your exercise book to do the same thing here. So first of all, in what direction do you want to tip your teeth? So if you want to distalize the root, for example, let's say an upper central incisor, and they want to angulate it, you want to tip it, going with the root distally and the crown medially, okay? So how do you do that? What kind of band do you have to use in order to achieve this kind of movement? So this is a second order band, a second order Z band. So this is the way we do. The aim here is to initially construct or to make a band upwards. This band will form an angle of approximately 20 degrees in relation to the arch wire plane. So first up. So my first thinking here is to do this banding in order to do the correction of the root. Okay. So if I want to go distally with the root, if in the upper arch, for example, I'm going to do this kind of movement. Are you with me? Look at my hand. So I'm doing this. For example, this is the midline, central midline, and I'm going to do this kind of bend. To go distally with the root and medially with the crown. So this is how we think the second order Z band. So when I want to do this movement, distalizing the root, I'm going first upwards in the first band. So I grab my plier, I grab the wire with the plier, and then I squeeze the plier in order to have a steady movement, okay? So now I'm going to do this first movement upwards. So this is how we do. First upwards. We can do both, just doing the pressure or just rotating our wrist in order to have the same kind of movement. In this case, I'm giving you here this other example of doing the same bend. So in this case, I can put my index finger on the medial portion of the arch. So grabbing the arch wire with the plier, I grab the arch wire here. This is my plier, and I'm putting the force in this position, medial to the plier. So I can do either the movement like this, with pressure in my index finger, or grabbing here, I just stop my index finger, and it's part of the movement when I do this kind of rotation of my wrist. Can you understand this? So I'm doing like this. So this is another way to do the same bend. The aim here is to initially construct this upward bend. So I'm doing this in another fashion, which is just rotating my wrist and using my finger just as a support. So I'm doing the rotation of my rib. This is going to do all the movement. Here is another way to do. As I told you, the first way I've taught you was just doing the pressure and staying with the plier almost without any movement. So this is the first, and now I'm doing this. So this is how I do. First upwards, the second bend without removing the plier from its position, from its initial position. Continuing to hold it firmly, steadily, is made by pressing downwards. Remember that the direction must be perpendicular to the plane of the arch. With the thumb or index finger, I do this kind of pressure. Why am I calling your attention for this point here? Remember that the direction must be perpendicular to the plane of the arch. Because if you just doing this kind of movement, if the wire rotates, you're going to produce another kind of bend, not a second order bend, probably something between the first and second order bend, or meaning with an angulation out of the vertical position. So firm, you have to grab the arch wire and you squeeze your plier in order to secure the arch wire for it does not rotate, okay? So grab it here and do the pressure. First upwards, second downwards. So first upwards in the mesial part of the arch wire, and the second you go distal without removing the plier from its original position. You now do the pressure in the opposite direction, meaning downward, okay? So this is what you're going to produce, and this is the angulation or the angle you want to produce here. Something like 20 degrees related to the horizontal plane of the arch wire, okay? So the other two bands are the same as the first bands you produce in the mesial, okay? So now we have upwards. Again, you can put your finger here and do just the wrist rotating, so like this, or you just secure your arch wire, you grab your arch wire with the plier and you do both, rotating your wrist and pressing your finger upwards. So this is something for helping you to do less force to do the bend. So now we're going back, and then we do the second bend, removing my fingers from the mesial, putting it distally to the plier and pressing down. This is the last bend that I'm going to do now. So let's read it here. The next two bends are equal to the first ones. Initially, it is bend upward, the distal portion of the arch wire here, okay, as you can see, which can be done either exerting a pressure on the wire distally to the plier, or as exemplified here, like I said, like I told you before, this is the second way, a second fashion of doing the same thing, okay? Grabbing here, so the finger is here just to support the force of the arch wire that goes down. It prevents it to goes down, so it's going just exert a pressure against the rotation of your wrist, okay? We're having the opportunity to say that again when you go to the videos with the step-by-step movements, and you're going to do the exercise on your exercise book, okay? So this is how we do, producing this angulation, which is going to tip the tooth. The finalization of the bend. Push the distal section of the wire downwards, okay? So this is the final configuration of the bend, the Z bend, the second order Z bend, and you have to do this now. You have to be sure that your movement didn't change the height of the anterior or mesial and distal portion of your arch wire. So now you have this kind of bend, this angulation in the middle. This is actually the active part of the bend, which is going to go inside the slot, and you have the medial and the distal portion of the arch wire, which has to be completely linear, completely in the same line here, as you can see. When you look from above, you put your arch wire in a position and you look from above, you have to see this. You don't have, nothing is outside of the line of the arch wire. So this is a second order Z-band. So you can see here, this is the wire going straight here without disturbing the line of the arch wire. So it is imperative to check the arch wire shape in both occlusal, this is the first view, occlusal, and lateral direction. The arch wire must remain with its outline not deviating from the line drawn from the parabolic arch. So this is something very, very important. We have to produce the right band, and to check, in order to check it, we go looking like this, lateral view, and an occlusal view, meaning you put your arch wire in a surface and you look from above, so you don't see any disturbance here of the line of the arch wire. So it remains like a line, as it says. So when you see laterally, when you see in a lateral view, you have to see this line continuing here and just having up and down related to the line, those 2 points. This is the second order Z band, and you use it a lot. As I told you before, I start doing this kind of band when I think that I have to do in order to correct something. For example, lateral incisors, upper lateral incisors are really tricky to do the position, to do the right position, the correct positioning of the bone of the bracket during bonding. During the first phase of treatment, the bonding of those brackets. Sometimes we misplace these brackets, and we sometimes commit some mistakes, like doing a little bit of twist of these brackets, and we don't have the correction of the roots. So this is very, very, very useful for us in our day-to-day practice. Since I see the mistake, when I see the mistake, like for example, when I have the Panorex evaluation, I always do that like 3 or 4 months after beginning the treatment, after starting the treatment, after starting aligning teeth. So I do a panoramic X-ray, and I check the angulations. I'm usually, if I have a slight moderate crowding, for example, or a mild crowding, and like 2, 3 or 4 months after initiating the treatment, I am probably in something like the 016, 018 arch wire. So if I see this problem, if I see that I committed some mistakes with the angulation, with the tip of those teeth, what I do is I start correcting now, because the next arch wire, the next wire I'm going to put inside the slot, it goes with another Z-band greater than this one, or the same size if I have correct already, or I can intensify the band in order to continue the correction. So it depends on what I find when I look for the case. So what I do is I'm going to check the angulation in this panoramic X-ray, in this phase of the treatment. I do the panoramic X-ray in order to see if everything is okay. If it's not okay, if I have to do some angulation, I do it now. I do it with this second order Z-band. What is the option for that? We can do rebonding now. We can rebond our bracket, but we have to go back. We have to go backwards in our sequence of arch wires. In this case, I'm going forward. I don't stop changing wires. I don't stop putting thicker wires in my sequence. And when I get this correct, I do the rebonding, and I do the positioning of the bracket now completely passive in relation to the arch wire. So this is how I do, and I think this is faster for my treatment, okay? So, being the second order Z band that important for our mechanics, for our day-to-day practice, I had to divide this in two parts. So I'm going to go from now explaining to you how we do clinically, how are the possibilities that we use this kind of band in our practice. So I stopped the last class saying to you that this is the way we have to check, and when we go laterally, you check this second order like this. We have to see this line with this continuity like you see here. In a lateral view, the posterior and anterior segments of the wire should also remain in line, under penalty of being generated an intrusion or extrusion step if this does not occur. So if you go like this doing the band and you don't have this angulation that you're seeing here, you don't have this beautiful angulation here, this angle generated here. If you have like something more flat, more horizontal, you're going to have two steps here. One step here and the other step here higher than this position. So this is how we see the band. You have to see this line continuing in the medial and the distal part, the distal portion of the arch wire. So you just have the disturbance of this line in this and this point, and you go like this straight. So we have to check this, because if you do not, if you have like a more flat step here, more horizontal step here, and the other step goes like this, higher like this, you're going to generate two steps, two intrusion or extrusion steps, not a real Z band, second order Z band, as we're going to see just a little bit further. Let's go, move on. How do we do this band? As I told you before, we're going to check this in our video step by step, and then we're going to practice in our exercise book. So this is how we do two bands that are the same way they're done, but in the middle of this band we have this angulation here, which is the active part of the band. So medial and distal to the band, we have the line. So like this, we are going to generate just a couple in the bracket, in the slot of the bracket, which is going to do the tipping of the tooth, which is going to do the angulation of the tooth. So this is the couple generated here. So again, down, medial, up, distal. This is a different band. And we go like this, down, here, medial, grabbing the arch wire and putting the finger medial, then distal. So are the same bands, as you can see. But in this case, in opposition to the other case that I showed you before, in this case, I'm going to do the angulation of this tooth with the crown going distal and the root going medial. It is different. We are going to see this in our third example of the band, of the clinical use of this band, when we want to do this counterangulation of the crown and of the roots in order to generate space between the lateral incisor and the canine to do the surgery. I'm going to show you in the third explanation, the third example of the clinical use of this kind of band. So let's move forward. Let's go on. So this is the band that I showed you before, the second order Z band, with the aim of throwing or bringing the root distal and the crown medial. As you can see here, what I'm going to show you here is the positioning of the arch wire inside the slot. When you put the arch wire, this portion, this active portion of the band inside the bracket slot, you're going to have the bracket slot following this angulation. So meaning when you put the slot in this angulation here, it goes with the crown medial, as you can see, and the root distal. So this is the aim in this kind of situation. We wanted here to do this the closure of this space, because this patient had this kind of discrepancy of a size discrepancy, and it's a colleague of ours, it's an orthodontist, and he told me, Kleber, I don't want to put veneers in my lateral incisor. I know they are peg-shaped or something like that, and I don't want it. I just want to close the space. One position, one option for doing this is doing the angulation of the crown, because the crown, it resembles a rectangle. So when we do this inclination or angulation, in this case, of this rectangle, we occupy more space. So we can close the space doing just this angulation of this crown, okay? So this is, in this case, in this specific case, our objective is just to close the space, angulating, tipping the crown medially in order to close the space. And yes, as you can see, in just 1 month of this beautiful band here, we managed to close the space, okay? So let's go to our other example. So we have another situation when we need to do this kind of inclination. For example, when we have the roots touching or they're very close, in this case it's very common between lateral and central incisors. If they are too close or touching or even touching, you have the reopening of the space, which we don't want, and it's not stable. So sometimes you cannot even close the space because the roots, the tips of the roots, they touch first. So they don't allow the crown to be close the space. They don't allow the crown to close the space because it's touching up there. So we do this angulation, we do this tip. Once we have it correct, we can rebond, we can do the rebonding of this bracket, and we put now a straight arch wire and a passive arch wire after the correction. So sometimes we don't even need to go backwards in our sequence of arch wires. Just go forward, putting more and more thick wires to correct this position. So in this case, in this specific case, we had to go back in our arch wire sequence because we had many things to correct, but sometimes we don't even need to do this. We just go forward, and when we rebond our brackets, we put them in a passive position, meaning I put the arch wire, a rigid arch wire, and we put the braces in position, and we do the consolidation of the bonding, okay? So here it is, and here is an example of a case where things went wrong. This is a case of a colleague of ours, a former student of mine, and she sent me these pictures saying, Kleber, you were absolutely right. I didn't have that care to look if the arch wire was linear, mesial, and distal to the band, and when I put it inside the slots, what I got was this. I got extrusion in one part of the arch wire and intrusion in the other part of the arch wire. So if she checked this in the wires, with the wire in the slot, she would have seen that one size of the arch wire was lower and the other side of the arch wire was higher than the middle where she wanted to do the angulation. So she did a wrong band here. She did two bands here actually, one intrusion and another intrusion here, and here extrusion and here extrusion comparing to the other tooth. I'm sorry. So this is what I always tell you. You have to check. I'm always giving this kind of advice because I've seen many cases where this kind of bad alignment occurred. So it's very important for you to check this situation. Is it inside the slot or not? Let me go back to this image here. As you can see, we have it here. We check it this way. We see if the band is doing the kind of activation that we want, and we check if there is a continuity between the mesial and the distal part of the arch wire, just having this part of the arch wire with a different angulation, okay? So this is important. If you don't do this, you may have a bad outcome. So let's go back to this image, and this is what you are going to have if you don't check, if you don't be sure that you're having the right band, doing the right movement that you want, okay? Let's go to another example how this band is useful in our practice. In this case, I had the opportunity to open the space here between the two lower bicusps in the right side of the arch, and I opened the space here. I had here mesial and distal to those two premolars, to those bicusps. I had this space here because patient lost her first molar long time ago, long time before this picture. So she had those teeth moved distally, the premolars distally, and the second molar mesially. So I had to choose in which space I should open the space in order to put the implant. So I chose to do this between premolars because I moved those teeth and their roots to a region that the bone was very, very thin, and I put this movement, and with this movement I brought those roots to a position with low bone and generating bone with my movement. This is something that is already proved that we can do this. We can do this slow movement, bringing the periodontal support together with the movement. Meaning, when I'm going here mesial, we go with the bone, and here the same thing, we go with the bone. We do the movement with the bone, not through the bone when I do this and the bridge of our bone bridge, okay? So if you go to the articles published by Eugene Roberts, you're going to see this outcome. You can do this slow movement, bringing bone together with the movement along the bridge, along the movement of the bone, okay? So in this case, I chose to do this in this position because of this. I would have to do the opening here, bringing this tooth forward and this tooth backwards in the middle of the space. It would be the space where the implant should fit, okay? So in this case, opening the space has a cost, which is we do this kind of movement, so diverging the crowns but converging the roots, and we have to deal with this. How do you do this? We can use a band, a second order Z band in one side and the other side, opposite one to each other, okay? So we do these two bands that are completely opposite one to each other. So this is how it goes. We go first doing the opening, but sometimes you don't have enough space here. We know we must have at least 1.5 millimeters between the implant and the root, the neighboring root. So in order to achieve this kind of space, this amount of space, I did two Z bands, two opposite Z bands going, opening space between roots. And you can see here that it was completely successful, and we managed to have the space between these two roots, and after that a very beautiful space and a very beautiful amount of bone, and it was completely possible to put the implant, to insert the implant without damage to the roots, to the neighboring roots. So as you can see, this band is fantastic. If you do the right thing here, and there's another tip that I shall give to you, which is if you want to have a more horizontal, a more bodily movement, you have to do this movement from buccal and from lingual. So we put here two buttons. We put here two buttons that could do this movement without rotating the premolar, or at least with a very, very slow rotation of this premolar, because it was controlled by lingual aspect. So when you look this kind of movement, if you go just buccal with this movement, with this kind of coil, of compressed coil, just buccal, you have this situation, but you have the rotation in first order. So in order to avoid this rotation, we can use here a lingual bottom attached to another place, of course, to another position here for the molar, and here the canine forward. So we did this by buccal and lingual aspects in order to avoid, during the opening of the space, the rotation of the premolar. So this is just another tip, and of course it's more common sense than one tip, but you keep that in mind, okay? So here we have the space opened, and again, the Z-band, the second order Z-band, managed to do the opening of this space, bringing the roots outside of the space of the implant, outside the position where the implant should be placed, should be inserted. Okay, so here we have, and to finish, the third situation, which I mentioned before, which is doing the opening of the space between the roots of lateral and canines. When do I have to do this? When I have to open the space in order to do the surgery, to put there the burr or the osteotomy here. We have to open the space in order to allow the surgeon to do the osteotomy between lateral incisor and canine. Meaning, when I do a 3-piece osteotomy, I have to open the space to do this V or Y shape here doing this kind of surgery. Let me show you this example in the practice. So sometimes you don't have enough space to do the osteotomy here because the roots are too close, and now I have to do this kind of divergence of the roots. So this is a second order Z-band doing its job, meaning doing the diversion of the roots. So in this case, it allowed to do the surgery with complete safety in between the lateral and canine. Okay, so here are the bands. As you can see, those bands are made for doing this divergence. And here's the surgery itself. As you can see, it's done in this place, and it goes downward at this position. So if you don't have enough space, you can have damage to the roots, to the neighboring roots. So the third option for us, the third example where we do this frequently, are those surgeries where we don't have enough space in between roots, so we have to open the space in order to create a safety environment to do the osteotomy. So this is the third example that I use a lot because I have many surgical cases in my office, and many of them are 3 pieces osteotomy. So in this case, many times, even though I do this kind of divergence right in the beginning of the treatment, meaning doing the bonding with a specific rotation or inclination of the brackets to do this kind of counter inclination to give room to the osteotomy, sometimes it's not enough. And when it's not enough, we go with this kind of band, which is a Z-band, a second order Z-band. It is fantastic. It is useful in our day-to-day practice. We use it a lot. And I can think a lot of possibilities to do this kind of band, but these are the most common in my practice. We have those 3 examples. When you have the proximity between roots, you do the divergence. When you have the roots that are too close to the implant, you have to do this kind of divergence, or in this case, to give room, to make room to do the osteotomy. So in this case, the second order Z-band was the most important mechanics to use to achieve this kind of the solution. Okay, So as you can see now, I'm happy. Why am I happy? Because I'm going to show you the band that I use most in my office. The band that I use in almost 100% of my patients at some moment of their treatment, because this is something that I do in order to achieve the best intercuspation that I can. Because I understand that intercuspation is one of the things that keep the case stable along the years that comes. So when you do this quite good intercuspation, the stability of the treatment, in my mind, it tends to be very strong. Okay, we have many things to consider in order to think about stability in orthodontics. And I know that the crowding, it comes back with time. And I know that there's a tendency for the relapse in the anterior region of the lower arch. Yes, we know that. But if we have a good intercuspation and we follow the protocol, the retention protocol, looking for a stability and all those possible parts of the arch wire or the arch, I'm sorry, that we have the contact between upper and lower teeth. When we do this, when we take care of every aspect of the stability, the retention protocol, the position of all those teeth, and the intercuspation, the solid intercuspation, and we remove the functional possibility of relapse, meaning tongue thirst and thumb sucking and everything that goes with the functional aspect of the things. So when we remove everything, the intercuspation is the most important thing to have the stability. This is what I mean. And here is the band that I use most, because this is the band for the intercuspation. So when we do this at the final stage of orthodontic treatment, the refinement phase of orthodontic treatment, we use it a lot. You may say that I use this kind of band a lot because I don't put the bracket in the right position at the beginning. Maybe, but we are just human. We are only humans. What can we do if we can have this precision in our eye to do the positioning of the bracket in the perfect position in 100% of the cases? And I don't. You know what? And I don't care, because I'm going to do at the end of the treatment this thing in order to achieve the best refinement as possible. Yes, I try to do things right at the beginning, but sometimes you can't. We have many variables here that we can't control in 100% of our cases. So in this case, in all of those cases that I use this band, I use the band in order to do the refinement. Because sometimes, as you can see here, you can't find the center of the tooth in order to put your bracket, because the center of the tooth that you see, the clinical crown here, is not the crown that we would have if this patient had a more long crown, a longer crown, which allowed you to do the positioning. So in many cases it happened. We have to escape from the right position, because we have gingival margins, we have the gingiva is filling the position. The gingiva is in the position where we want to put the bracket. So this is what I mean. So sometimes we can't do this. Or other times we really commit mistakes. We really commit errors in the positioning of the bracket. And it's okay. You are just human. Believe me, I'm 20 something years in this field of orthodontics, clinical orthodontics, and I do all these mistakes again and again and again. And sometimes, not every time, of course, but sometimes I have to do like hundreds of bends in order to achieve the best refinement possible. So this is what I do in my day-to-day practice, and I know you are going to need to know this band, because most of your cases with fixed appliance, you will need this to the refinement. This is the band, the extrusion, intrusion, or step up, step down band, which we're going to do. I do this band a lot since the beginning of treatment, like for example, the 018 stainless steel round wire. When I see some errors at that moment that I can't start to correct, I can begin the correction at that moment, so I can begin with this kind of band in like 3, 4, 5, 6 months after the beginning of the treatment. But most of the time I do this band in the refinement phase of our orthodontic treatment, meaning in rectangular wires. So this is something that we can do in rectangular wires. But one thing is important: when you do this band in rectangular wires, the intensity of the band, the size of the band, it has to be much smaller than the band that you do in a 018 round wire, for example, stainless steel round wire. You can do another thing here. You can change the wire. You can put a rectangular TMA wire to replace the rectangular stainless steel wire in order to lower the intensity of your band. But it's not something that I used to do, because I prefer to do with my rectangular arch wire, stainless steel rectangular arch wire, because I think it is possible. And I do that even when I use sapphire or ceramic braces. This is the case here. I'm using here a ceramic, it's a sapphire brace, as we can call here in Brazil. I think the same thing in many parts of the world. And here we have the sapphire braces. The bracket is more fragile than the metallic one, but in this case, if we have to do bands, we go to the bands and we calibrate those bands in order to do a soft band, not to break the bracket and not to have this cost in our treatment. So in such cases, I don't go changing the bracket position. I don't go rebonding the bracket position. First of all, because it's expensive. Second of all, because it's something that it's time consumed. I don't want to do this. I prefer to do the bands, because nowadays for me it's natural doing the band, and it will be for you too if you do the training that I'm showing you in our exercise book. I'm showing you in our videos. If you do this day to day, every day, if you do this, if you practice, and if you don't avoid doing this kind of bands, and if you don't avoid doing this kind of maneuver that you have to use to do the intercuspation, you will be a very good in doing bands, in doing refinement. You do well in doing refinement if you try to do it every day, if you do it every patient that you can. You don't escape from that. You try to go for it, okay? So this is what I always say to my students. Please don't avoid doing bands. Go and do that and train that. It is important to achieve the best refinement possible in orthodontics. So this is what I'm going to do in my cases, and this is what I can achieve doing this kind of bands. As you can see here in this patient, let me go back for you to see here. We have torque here in order to do the same inclination of this teeth, this anterior teeth here. I have here intrusion bands. I have here first order bands. I have second order bands. I have this intrusion, this segmental intrusion here. I have individual extrusion here. So I have many bands here in order to achieve the best refinement possible in orthodontics, okay? This is a case that was transferred for another orthodontist. I don't blame him for the positioning of the brackets, because I do commit a lot of mistakes. I do too. I also commit a lot of mistakes. So this is something that is my day-to-day. But in this case, I had to do many bands because it was not right, the intercuspation. And here we have, after elastics, after first, second order, and third order bands, the result that we got with this maneuvers, okay, in orthodontics. And here I'm going to show you a situation that is very common in orthodontics. Our second upper bicusp is a very tricky tooth, because its crown sometimes is much smaller than the neighboring teeth, meaning first molar and first premolar. So in this case, if you seek for the center of this tooth, you're going to have a difference, a huge difference in height when you put your wire in position. So putting the wire in position, inserting the wire here, you're going to have intrusion in this tooth and extrusion in the neighboring teeth. Of course, you have plenty more intrusion here than extrusion because you have other teeth to anchor the movement. So in this case, you're going to unlevel the marginal ridges, and unleveling the marginal ridges, you will have to fix it, especially at the end of treatment. And sometimes what we see is this: we do the intrusion, and doing this intrusion will have not a very good intercuspation when you compare. So here it is, the example I'm giving you. Now in this case, we have both in upper and lower arches, we have the unleveled regional marginal ridges. The unleveled marginal ridge, it's mandatory now to do something to do the intercuspation. And what can we do in this kind of case? For example, is it possible to put here a triangular elastic to achieve a better intercuspation? No, it is not. Why? Because you are using here a stiff wire which will prevent the extrusion in this case. So unless you remove the wire or you change the wire, you can't use in a case like this, you can't use this kind of device, this kind of maneuver, this kind of possibility of using intercuspation elastics. So in this specific case, the question is, what am I going to do to achieve the best intercuspation possible? In this case, elastics won't help because you have stiff wires and they will prevent the extrusion. So what can we do to achieve the best intercuspation in this case? We do the extrusion band to level the marginal ridges. So not possible to do with elastics because they want the arch wires, the stiff arch wires will prevent the extrusion. So we have to use another kind of solution, which is, in this case, the extrusion band in order to level the marginal ridges. This is something that you have to keep in mind all the time. When you see at the final phase of the treatment, when you see from a lateral view, you have to see the intercuspation. If it's not happening, you have to ask yourself what's going on. And most of the times you don't have the marginal ridges leveled, so you have to seek a solution for doing this kind of intercuspation. Elastics are possible when you're not using stiff wires in the posterior region. Elastics are possible when this difference here is very, very slow, very, very low. You don't have this kind of unleveling of marginal ridges. Just a very, very soft unleveling of marginal ridges you have. You can use elastics with night tie wires, for example, and we will have the opportunity to talk about it later in our course. But in this case, the best possible solution is using an extrusion band. But you have to keep in mind that second order bands, they come with a cost, which is they incorporate in them during the movement rotations. They incorporate something like a third order movement, which is an inclination of the crown. For example, in this case, when I do the extrusion band, the step down, in this case we call the step down band or extrusion band. This extrusion is made in the lateral view comparing to the center of resistance of this tooth, this specific tooth, which is looking from above, looking the occlusal view. The center of resistance is in the center of this tooth in an occlusal view. And when we do this, since we're doing the force, the extrusion force lateral to the center of resistance, we will have also an let's say a third order movement, which is the inclination of the crown downwards and inwards. It goes towards palatal. The crown of the tooth that is being extruded, it goes palatally, it goes towards palatal. So what can we do in order to avoid it? We incorporate another band here, which is a first order band, a step out band, or a first order band to do this movement towards buccal. So we avoid this movement of going inclining the crown palatally, inclining the crown in direction of the palate. We do this step out bend. We do this bend to compensate it. We'll have the opportunity to see this bend in another slide, in another part of this very class. We're going to see this, but you have to keep in mind that it comes, when you do the extrusion or intrusion, it comes with a cost, which is the inclination of the crown due to the position of the force that you are applying, which is out of the center of resistance, which is lateral to the center of resistance, okay? So we have to compensate that. This is the first band, and as I always say, you will have the opportunity to see it in a step-by-step way, and you have the opportunity to practice using our practice book, okay? We have plenty of exercise that you can do in order to train this kind of band, how you make this band, the making of these bands, okay? So this is the band, and here we have what I mean. This is the extrusion that you want, but you have to keep in mind that doing this extrusion, you will have this side effect that if you want, and almost all the time, we want to avoid it, and you have to do this kind of second bend, which is a first order bend, in order to have this movement towards buccal, okay? This is what we do here. And here is the case, as I'm showing you, the need for doing the extrusion and the extrusion bend plus a buccally direction bend. So this is what we do. We do downwards and we do outwards, okay? So this is what we do in this kind of bend. Here is the intercuspation after the bend. Here the case that I showed you before. We have here this intrusion band and the molar, intrusion band, upper and lower molars, which allowed for a better intercuspation, in this case leveling the marginal ridges, okay? So this is what I do in most of my cases. As you can see here, I have another band here in the canine. I have a band to change the angulation of the lateral incisor. So I go doing this band, I go making these bands because I know that I need them in order to have the best intercuspation that I can give for my patient. And I'm sure you want to do the same thing. And I'm sure you want to have the same result, the same outcome after all these bands and after all this training that you are going to have to have the best intercuspation, okay? So here it is, and so as you can see now, I'm very, very excited about this band because this is something that I use too much. Sometimes we use in the final phase of the treatment or in the final phase of orthodontic treatment, but sometimes we use it as the whole treatment. Meaning, when we do the extrusion, for example, in cases like this, we are solicited to do the extrusion, the slow extrusion or forced eruption. There are names for this kind of procedure, but we want here to level, at least to increase the bone level in order to achieve a better result to the bone defect. So sometimes you do this slow extrusion, or there are other procedures like a rapid, like a fast extrusion, but it's used for another purpose. In this case, in this specific case, we want to do the extrusion step by step, bringing with the movement the bone together and the gingival margin. So this is something that I usually do in adult patients with this kind of defect that we will see, especially in the x-rays. So this is the procedure itself. We don't need an orthodontic treatment, a full orthodontic treatment for that. Sometimes we just need to do this, and we have specific protocol for this kind of solution, which you will see in my article about this that will be available for you in our extra material. So this is something that I do very often, that I do in many cases, because I work in a place with many adult patients, so many adult patients and periodontal patients that comes to me with this specific chief complaint, or referred from me by the periodontist because he wants me to do this kind of treatment. So this is the extrusion band and a slow extrusion movement or forced eruption movement. As you can see here, as a result, we have a better position of the bone, and here is the procedure itself. So we do step by step, a half millimeter per 15 days or 10 days, at least 10 days, and we go increasing the step, and we go doing this adjustment in the crown in order to avoid the contact. You see this step by step, and this protocol in the material, in the extra material that I'm going to give to you. Okay, so this is the protocol of extrusion, and what we did here was just a slow extrusion. Here we have like the 10th band that we did in the same arch, and we have the result. Look at the difference, how the bone and the gingival margin follow the movement with this procedure, with this kind of treatment. Sometimes we go with this movement from the beginning of the slow extrusion to the point of extraction of this tooth, I'm sorry. But there are times that when we leave this kind of extrusion, because we have a positive relationship between the lever arm, which is with what is outside the bone, meaning part of the root and the crown, and what is inside the bone, where and sometimes we have this good relationship, which is called a crown to root ratio, 1:1. And if we leave 1:1 relationship between what is outside the bone and inside the bone, we can leave this tooth and this root in position, explaining to the patient, of course, that is something that with time it may not be something that we retain. It may lose something. The tooth may lose attachment. The gingival margin may go upward, and we have to change our plan. But in some cases, we can leave the tooth in position, which is the situation that we're seeing here. This tooth was left in position for years, and you will see this in this article that I'm giving to you, this article that we have published last year, some time ago, and this is the case when it was finished, and in the article we will see the case 3 years later. So this is a procedure that we do with this kind of step, this extrusion band, this step down band that is increased each 0.5 millimeter each time patient comes back to our office. Slow extrusion, forced eruption, so those are the names we call this kind of procedure, and we have the possibility of doing this using these bands, increasing these bands step by step. You will see this in the videos that are attached to this course, and you see this in the exercises they're going to give to you for you to train, for you to exercise, okay? For you to practice, I'm sorry. So this is another case in which this kind of procedure it was used. And here we have the step-by-step of the extrusion band in those two traumatized teeth. And in this case, we wanted to do the extraction. We wanted to go to the end of the procedure doing the extraction. But before doing the extraction, we did the slow extrusion, 5.5 millimeters, 0.5 millimeters each time patient came back to our office, which is 15 days. Each 15 days, he comes back and he goes with this procedure of doing another step. And when we level here the bone, so we go now to the extraction. In this case, we wanted to do the closure of the space, so we did the closure like this, closing the space step by step again. Here using another procedure, another height of the closing. And here we have the steps. And after that, closing the space, extracting the teeth, those teeth, first one teeth, then other teeth, then closing the space. And now we have lateral incisor in the position of the central incisor. So here we have the case before removing the braces, and I will show you this case also. I'll show this case, this article published some time ago, and with the outcome of this case, okay? So this is extrusion bands made step by step, increasing the step. Every time patient came from our office, we do this kind of increasing the step, 0.5 millimeters each time. So this is what we do in that kind of situation. This is another thing here. We're going inside the bone. We're going intruding the anterior teeth, the central incisors, in order to correct the gingival margin. So here we do the opposite. The gingival margin is going up in order to correct this position. So since the beginning, we did that thing that we advise you to do, which is doing the positioning of the bracket more incisor in the central incisors and more apical in the lateral incisors, to do this kind of refinement of the gingival margins, which we know already how to do. We know the central incisors are higher than the lateral incisors apex, the gingival margin. So we have here the zenith of the central incisor at the same level, and here we have the opposite. The lateral incisor is higher than the central incisor, so we wanted to correct this by means of intrusion of the central incisors and extrusion of lateral incisors. Even though we did this kind of procedure of positioning the bracket more incisor here, we didn't manage to achieve the best position of the gingival margin. What can we do for that? What can we do to do this refinement? We did here an intrusion band here in those two central incisors, as you can see, in order to give a better refinement of this gingival margin. So now we have a more beautiful situation. Even though we don't have the leveling of the tips of the central and lateral incisor, it will be done by means of a resin here, which is going to be done by a colleague of mine. And here we have pre-debonding and after debonding the case, and after doing the crowns here, the the central incisors, resin for replacing those two tips, which were wear with time, and now they are replaced, okay? But look at the beautiful gingival margin disposed here. We have now that beautiful situation that we seek for, okay? So now the correct positioning of the gingival margin by means of intrusion and a step, not only in a tooth but in two teeth, were made for doing this kind of intrusion here and correcting the gingival margin, okay? So this is something that we can do with our intrusion band, and now I'm going to show you what can we do to prevent one side effect that happens a lot when we do the extrusion or intrusion. We're applying the force outside of the center of resistance, so we're generating also here two movements, one extrusion, also the rotation in this position, which is a third order movement. So crown goes inward and root goes outward. So what can we do to prevent this side effect, which is almost always something that we don't want? We can do a first order bend. In this case, a step out bend is done, is made in this same arch. First we do the intrusion or extrusion, then we do the first order bend. In this case, since we would have the rotation, the inclination, of the crown, going the crown inwards and the root outwards, we do the opposite. We do the crown, go with the crown more buccally, or buccally inclining the crown, okay? Why don't we use a rectangular wire for that? Since we know that the rectangular wire in the rectangular wire, we may apply a force, a couple, that can manage to control this kind of inclination. Why don't we use this? Yes, we can use this kind of wire. Yes, we can use a rectangular wire, but we have 2 points that we have to consider in this kind of situation. First of all, if you do the rectangular wire when the tooth is perfectly positioned in this regard, thinking about the inclination is perfectly positioned, we can use this rectangular wire because it will control the inclination of the root towards palatal. How it goes, how it happens? We go like this, we do the extrusion. Doing the extrusion, we are applying the force outside the center of resistance of the tooth, so we have a moment generated here. The moment is in this direction, which is in this case, a clockwise moment, okay? Going inwards with the crown and outwards with the root. Better. Going towards palatal with the crown and towards buccal with the root. So I don't want it to happen. I don't want it to happen because here I have this thick plate of the bone here, and I don't want to press the root against this thick plate of the bone that I have here, so I want to avoid it. How can I do that? So one thing I can do, you have already seen this, is doing in round wires, doing the first order bend that goes opposite to the tendency of losing inclination. So we go outwards, we go towards buccal, we go with a step out bend. In this case, using this kind of wire, which is a rectangular wire, we have 2 points to consider, as I said before. One is that this rectangular wire is a very, very heavy wire to do the slow extrusion. Yes, sometimes we do here this bend and we don't have the bone following the movement because we did something very fast and we didn't have allowed for the bone to go with the movement, to follow the movement. So we have, in this situation, we wanted to have a slow extrusion, but actually we're having a fast extrusion, which is when we don't give time to the periodontal support to follow the movement. So this is something that we have to keep in mind. Stiff wires like the stainless steel rectangular wires, they are very difficult to work in this kind of movement when we want a more physiological movement, a slow movement. So this is something to keep in mind. The other thing is, I know they can control this effect, this moment that is generated by means of this. When you do this kind of extrusion, at some point it will generate a couple during the movement, a couple when it goes inclining, when the crown goes inclining towards palatal, and it generates a couple here that will control, because it's a couple that will generate a moment against the moment generated by the extrusion, the movement itself. So we have this red arrow here representing the moment generated by the couple. So we have those two moments in opposite directions, meaning that they will, if they have the same magnitude, they will eliminate one each other. So this is something that happens. Yes, okay, we have a better control. But what if we don't have a good inclination? That's very common, for example, when we have periodontal patients with periodontal problems. They have a very buccal inclination of the central incisors. So if you put your wire here without the care of reading the torque, in this situation, a neutral torque, meaning no torque, no inclination at the transverse section of our arch wire, of our rectangular arch wire. Let me say it better. We don't twist the arch wire. It is completely horizontal. Its transversal section is completely horizontal. So we have here what? We have here a difference between the inclination of this, the wire, the transversal section of the wire, and the inclination of the slot itself, okay? So when we put the wire inside the slot, what we are going to achieve here? Immediately, we're going to have a couple generated. But in this time, this couple here is a clockwise couple. As you can see here, we have a clockwise couple, clockwise moment generated by the couple, which is going to bring the crown towards palatal. And we have also here the extrusion movement, which will generate also a clockwise moment, which will magnify the moment generated by the couple here. So in this case, in order to avoid this situation, you would have to make here a twist in your arch wire in order to put the arch wire inside the slot without a couple generating it. Do you understand this? So if you have the slot like this, and you go, this slot like this, the inclination is this, in this direction, and you go with a wire without twisting it, you will have to, you will generate this clockwise moment, which here is tragical. Very bad for the case, okay? So in order to achieve another outcome, you'll have to do like this. Twist your wire, which we call torque, put an individual torque in that wire in order to insert it inside the slot without generating any couple. It's not easy to do. I mean, if you do it in one single tooth and you have already made the band, the down band, the step down band, it's very difficult to do this torque. It's very difficult to do a perfect torque that will achieve a perfect settling inside the slot. So I don't like it. I don't like it. When I do this kind of movement, I prefer to do this with the round wires using the two bands, the step down band plus the step out band. It's easier. It's more physiological. It's not a rigid arch wire. You will probably have the opportunity to see that when you do compare those two situations. But in this case, if it's the first time you're doing this extrusion procedure, it's the first time you're doing this slow extrusion or forced eruption, I advise you not to use rectangular wires. Go with the round wires. Which round wire I prefer? The 018 stainless steel round wire. Okay? This is what I use for this kind of procedure, and I advise my students, do not use a rectangular stainless steel wire for this kind of movement, unless you want to do a rapid or a fast extrusion. Even in this situation, you have to control this outcome, because if the tooth is too much, let me go back here, is too much inclined, and you have this situation like this, and you put a 1725 rectangular wire, you will probably generate a couple, and this couple is in this direction, is a clockwise couple, which should go down and inward with the crown, and you will sum this moment with the moment generated by the extrusion, which is in the same direction. Let's see here. So we have two moments in the same direction that are summed, and we have in many cases this outcome here. The contact between a upper incisor, which is being extruded, against a lower incisor, and this tooth, if you're doing the slow extrusion because you want to level the bone, you probably have a bone defect. So we have here a less support in this tooth, and doing this you will have a very disastrous situation. Okay, so be very careful about this kind of movement, and again I advise you to use a round wire and those two bends that you have to do in this kind of wire. Okay, and the more inclined the tooth is, more you have to do this step out bend, because you are more you are in a position, you are doing the force in a position that is far from the center of resistance. It's very far from the center of resistance. And when you do the inclination of the teeth, the point is go more distal. So this is very difficult to do, you know? So sometimes we have to do a very steep bend towards buccal to avoid this outcome of putting the crown buccally, putting the crown palatally, and the contact that may occur. Okay, so we will have the opportunity to train and the opportunity to see this in many details in our articles, in our exercises, and in our practice doing the video at the same time. So this is where we stop now. Hello, my friends. Now we're back with another very important topic in orthodontics. I would say the most important topic that we have addressed till now, which is torque in orthodontics. We are now trying to understand the way we think when we do torque, when we do some kind of adjustments in our treatments to get the best refined possible. So torque is this in orthodontics. Torque helps us a lot in our treatment plan, in our treatment management, okay? So here we're going to say everything about the torque in orthodontics regarding to straight wire appliance and edgewise appliance. You will see that I'm going to say many things about orthodontics and with edgewise appliance, because I always think edgewise even when I apply a straight wire appliance, pre-adjusted appliance. Why is that? Because when we know orthodontics based on the opportunity of doing this, the twisting of the wire, the bends and the loops, now we are the master of our practice. When we think orthodontics, just using what we have, what companies, what all those important and rich companies gives us, and they say that we have to use that way, we are very limited in our practice. Now we are doing different. We are thinking different. We are thinking edgewise, even though we are using straight wire. And I know that most of you, probably all of you, use straight wire in your day-to-day practice. I do the same thing in my day-to-day practice. In almost all my cases, I do straight wire. I use straight wire brackets, meaning pre-adjusted bracket. But I think edgewise. I think on about doing the adjustment of the wire so we can get the best possible result, the best possible positioning of our teeth, of our tooth. Okay, so here we're going to talk about brackets. We're going to talk about the relationship between our brackets and our wire, the angulation or the inclination of the wire and its relation with the inclination of the slot, the bracket slot, which is very important. This active or passive relationship between those two pieces, the arch wire itself, the torsion of the arch wire, the transverse section of our arch wire, and the inclination of our bracket. So this image here, I consider it very beautiful because here we have many possibilities. As you can see, we have a passive relationship here in the middle where the wire is inserted inside the slot, and we have here a different possibility when we have the inclination, different inclination between the arch wire, the transverse section of the arch wire, and the slot. Okay, now we have those two possibilities, those three possibilities actually. Here, the torque itself. What is torque? What we call torque in orthodontics. Torque, I like this concept here, is a moment generated by the torsion of a rectangular arch wire in the bracket slot. So when we do this torsion of the rectangular arch wire, we generate a couple or not. Sometimes we just do the torsion in order to obtain a passive relation between the arch wire and the slot inclination, meaning the inclination of the crown of the tooth itself or a group of teeth itself. So when we do this torsion, we have to be aware of the interaction between the torsion of the arch wire and the inclination of the brackets, okay, or the slot of the bracket. In orthodontics, it represents the buccal inclination of a tooth root or the crown, and it is an orthodontic adaptation used to describe the rotation around the x-axis. Let's see the concept of that Roche gave us back in 1959. So conceptually, the torque in orthodontics is a torsion of the rectangular wire or the arch wire where the crown accompanies the movement of the wire and the root shifts in the opposite direction. The inclination of the root and the crown are opposite. So when I do the inclination of the crown to buccal, towards buccal, I do the opposite with the root. So it's a buccal inclination and a palatal, meaning the arch wire inserted in the upper arch, dental arch. So buccal inclination of the crown means the palatal inclination of the root. So this is very important for us to keep in mind. So we have to bear this concept here. Let's see what happens when we do a torsion in the arch wire. So as you can see here in detail in here, when we do this torsion, we are going to obtain a couple, which are two forces in opposite direction with the same amount of force, with the same intensity, and not in the same line, okay? Non-collinear, not in the same line. So here we are going to generate a couple, these two forces, which are going to incline the crown of the tooth in one direction and the root in the opposite direction. In another example here, we're doing the reverse. We're doing the inclination of the transverse section of the arch wire, generating another kind of couple, meaning now a clockwise moment generated in the bracket or in the tube here. So we're doing this kind of rotation. Every time or anytime we want to do this rotation, we want to do these adjustments, we just have to understand, first of all, understand the relationship between the inclination of the slot of the tube or the slot of the bracket and the torsion that we gave or not in the arch wire, the rectangular arch wire, okay? Back in the date where we used torque in edgewise appliance, it was absolutely necessary to do the torque in any case, in every situation, because the inclination of the crowns, the inclination of the bracket itself, the slot of the bracket itself, it was not compensated inside the bracket. So we have here a bracket, edgewise bracket, which always keep this relationship between the slot and the base of the bracket, 90 degrees. So in every bracket, in every kind of situation, it is the same, 90 degrees between the slot inclination and the base of the bracket. So we all know that the crowns, they have different inclinations. The crowns, for example, in the upper anterior region, meaning central and lateral incisors, the crown is positively inclined, meaning it goes buccal, it goes towards buccal, and it has this inclination, this natural inclination. If we go back in the teaching of Andrews and his 6 keys of normal occlusion, we will remember that the only teeth that has this positive inclination in a class 1, in a very good occlusion, in an ideal occlusion, are the central and lateral incisors. Other than that, all other teeth in a human species, of course, in a class 1 relationship, in an ideal occlusion of class 1, we will have a negative inclination of the crown. So if we have in our bracket, edgewise bracket, always a 90-degree relation between the slot and the base of the bracket, we won't have a compensatory inclination for each bracket, which we have when we use straight wire appliance, pre-adjusted appliance. So if we have a negative inclination of posterior teeth, for example, and we don't do this inclination of the torsion, actually the torsion of the arch wire, the rectangular arch wire, we will generate a negative relationship between the arch wire, which is not torsion, which has no torsion, and the inclination of the crown, and the same inclination we will find inside the slot. So we'll have this, for example. Let's exaggerate for you to see. So we have this negative inclination in this portion of the arch, and we have this neutral, or meaning no torsion of the rectangular arch wire. So when it gets this way in the bracket, in the slot, it will change the position of these brackets, and in a consequence, the inclination of the crowns of those teeth. So this is important for us. In any situation when we are using edgewise appliance, meaning non-adjusted appliance, non-pre-adjusted appliance, we'll have to adjust, we'll have to compensate the inclination of the crown in the wire. So we have to twist the wire. It's nothing that we choose. We have to do it all the time. Okay, so this is the first part of our class. Just the difference between the edgewise appliance and the straight wire appliance. When we have edgewise, we have to do the torque in the arch wire. We have to do the twisting in the arch wire to compensate and to achieve the best positioning that we want to have for that tooth or a segment of teeth. So this is all the time we are using edgewise appliance. In opposition to that, when we use different appliance, pre-adjusted appliance, we'll have to think differently. Here we see what we have to do if we, for example, want to change the inclination of this bracket, which is, of course, bonded to a tooth. And when we have this inclination, when we want to change this inclination, we don't have it embedded inside the slot. We need to do the torsion of the arch wire to achieve the inclination we want to have. So let's say 18 degrees, for example. And here we have this fine gentleman who gave us this bracket, the edgewise black bracket. And this is Dr. Andrews, Dr. Engel, I'm sorry, Dr. Edward Engel. So when we wanted to do that back in the time, when we used just edgewise appliance, when we wanted to do the modification in the inclination of one teeth or a group of one tooth or a group of teeth, we had to do this. We had to do a distortion, which we call torque. We had to do distortion of the segment of the arch or the whole segment of the arch, or an individual torsion in some point of the arch wire in order to achieve this angulation, this inclination of the teeth. So for example here, 18 degrees, I'm applying 18 degrees of torsion. So we are going to have 18 degrees of inclination in this example here, a positive, meaning the upper arch wire. In the upper arch wire, let's think here of this bracket as a central incisor bracket. So if I wanted to have 18 degrees of inclination of that crown, I would have to give this kind of torsion in the arch wire to achieve this inclination. So it's completely different when we think straight wire. In the straight wire appliance, what we have is the torsion or the inclination of that crown or a group of crowns of teeth. We have the inclination embedded in the slot, in the base of the bracket. So if I had, for example, in this situation, a upper central incisor having an inclination of the crown of 18 degrees, and this is what we want to have in some situations, and we'll talk about that later. So if we have this 18 degrees inclination of the crown of this tooth, and I bond here a central incisor bracket with that inclination, when I put a neutral torque, neutral rectangular wire torque, meaning no torsion at all, when I insert this arch wire, this segment of the wire here, we are going to have no active relationship between the inclination of the slot and the torsion of the arch wire itself. So this is the difference. This is the basic difference. The basic here is to understand that when I use edgewise, I'm completely in the hand of the inclination of the tooth crown. When I use edgewise, I don't have this compensatory inclination embedded in the base of the bracket. So if I want to do something or not do something, not to change the inclination, I have to think to put my arch wire inside that slot without an active relationship, meaning generating no couple at all. So if I have this inclination or this inclination or this inclination, I have to twist the wire accordingly. For example, here, this way, here, neutral, and here I have to do the inclination of the torsion of the arch wire to achieve the passive relationship between the arch wire and the slot. I know it's a little bit confusing at this moment, but we're going further in this explanation in our next class, okay? For now, guys, just this. I want you to understand that there are differences between the thinking of using edgewise and straight wire. But when you understand this active relationship or a passive relationship between the inclination of the slot and the torsion of the rectangular arch wire, when you learn how to read this relationship, and it's easy to read, you have just to be aware of this relationship. When you learn how to read it, you will do anything in orthodontics in order to compensate, to decompensate, because everything will be in your hand, okay? Hi guys, so we're back with the same information, just we're continuing the same thing, the same discussion between the difference between the straight wire bracket and the edgewise bracket. So it is very important because sometimes I see many people saying that When I use straight wire, I don't need to know torque, to know how to do the torque, the adjustments with the twisting of the wire, because I have everything inside the bracket. Not true. Really not true. So as we can see here, this is a pre-adjusted bracket, which was given to us by this gentleman here, Dr. Lawrence Andrews. As we know, we had this important study in orthodontics, the 6 keys of normal occlusion, of ideal occlusion, which brings to the light the situation, the perfect situation in a class 1 position, in a class 1 relationship, in a class 1 phase. So when we have a class 1 phase, a balanced phase, a balanced skeletal pattern, we have the possibility of achieving the best possible position, meaning inclination, angulation, ins and outs for every teeth that we have in our mouth. So in this situation, and the origin was the 6th key of malocclusion, or normal occlusion, the study, and he brought to the orthodontics this beautiful, this amazing tool, which is the pre-adjust appliance. So Andrews gave us the pre-adjust appliance, and all those prescriptions that came after him was all of them they were based on his study, on his on the possibility of putting inside the bracket, inside the slot, inside the base, the position, the ideal position that we imagine is best for each tooth. Okay, so the pre-adjust appliance, and Andrews has this amazing statement, this amazing sentence that I quote here, which is, if you go on a long journey, you don't walk all the way. You fly most of the way, then take a taxi, and then you walk the final 100 yards. Meaning, he knew that giving for us this amazing tool, this powerful tool, which is the pre-adjusted appliance, he didn't mean to do this kind of magic healing of all the malocclusions, the magic correction of all the malocclusion that we have. He just gave to us the possibility of having less chair time, of having a better life. As we can say that, because when we do this kind of facilitation of the treatment, when we facilitate our treatment time, when we facilitate our mechanics, we spend less time in our practice. We spend less time doing the twisting of the arch wire, but he didn't mean to do the magic of treating all the malocclusions using just one tool. He knew that for us, the most important thing is to achieve a best possibility of treating the medium malocclusion, that malocclusion that is all right, a class 2, a class 3, but at the extremes, they are not tackled in this kind of pre-adjusted appliance, because we have to do the adjustment. So most of the time we can just use the pre-adjusted appliance, and we won't need to do those bends and all those torquing, because we have that embedded inside the bracket. But in some cases, and we don't treat just the medium patient, we treat all the cases. So in some cases we have to do the adjustment. So this is what differentiates a good orthodontist of a bad orthodontist, someone that just goes with the wave and just takes what the company gives him. We will not do this. We will do the individualization of our treatment. We will try to see our patient as a unique patient, and we will individualize our treatment. So this is what we do in orthodontics, the individualization. Okay, let me show you here. So what is the plane here? What is going to save us time? It's the bracket. It's the appliance itself. So the taxi and the final walk is us working the wire, working with bands, with loops, with elastics, just in order to achieve the best position of our teeth, because we have this huge amount of possibilities in orthodontics, in malocclusions. So we have to do the individualization of those treatments to achieve the best refinement possible for that patient that we are treating. for that situation that we are treating that moment, okay? We're not just treating the medium patient, we treat all the patients. So this is what Andrews meant with this statement here, with this sentence here. So we are using a very good tool, a very powerful tool to treat our patients, which is the individual positioning of each tooth that this bracket gives us. But we have just a medium possibility. We don't have the extreme, the low and the high difference between the class 2 that he treated, that he put inside the bracket, and the patient you're seeing. So sometimes you have to do more or less torque in order to do this kind of refinement. And there are other situations, and there are other things that we have to keep in mind. For example, those pre-adjusted brackets, they have different prescriptions. They have different prescriptions based on what the author wanted to do for that case. We have, for example, the prescription that is meant for moving teeth. We have the prescription for class 2 when we think about the teeth movement. So we're doing the retraction, and during the retraction, when we apply the force in the crown level, at the crown level, we have this moment that is generated by the force when you're doing the retraction. So during the retraction, we tend to lose the inclination, and sometimes we have a big gap, we have a big overjet, and we need to control the inclination of anterior teeth in order not to block our movement before we correct the position of the canine. So the class 1 of the canine sometimes is not already corrected, and we have zero overjet because we lost the inclination. So how can we deal with that? In this kind of prescription here, which is meant for movement of teeth, for the translatory movement, we have the thinking of embedding the torque, the extra torque in the base of the bracket. So we do this 18, for example. 18 degrees here is for a class 2 patient for moving anterior teeth without losing inclination. So we are here embedding a super torque in order to counteract the moment generated by the force of retraction. So when we do this, we tend to lose inclination, and the torque, the extra torque that is in this bracket, is doing the opposite, is trying to incline the root, palatal, and the crown buccal towards buccal. So we do this in order to counteract the movement during the correction of the overjet. So it is good, but we have to think that at the end of this movement, we have to stop and we have to rethink, is this the torque that I need now to do the compensatory treatment? Or do I have to lower the torque? Or do I have to change the brackets? Or do I have to change the wire in order to not to break the bracket to feel, to read the inclination that is embedded inside it? So we have to think about all this stuff, all these things, in order not to commit some mistakes in our treatment. And there are other kind of brackets that are meant to do the final positioning of the teeth when you have a class 2. In this situation, for example, we don't need a 18 degrees bracket because we just want to do the compensatory movement of anterior crown, upper and lower crowns to do the compensation of a class 2 patient. For example, a class 2 patient with a huge mandibular deficiency, if you want to do the compensatory treatment, which I don't think it's the best thing for the patient, but if you want to do that, you have to accommodate the inclination of lower and upper anterior teeth in order to have a very good overjet. So in this situation, you need more positive torque in the lower arch and less positive torque in the upper arch, which is different from, for example, the 18 degrees here, which is meant for movement, not for final positioning of anterior teeth. So all those things make very, very difficult for us to have just one tool to treat all our patients. So this is why we need to understand the relationship between the torsion of the arch wire and the bracket that we are using. So the relationship between the torsion of the arch wire and the inclination of the slot. So, but Kleber, we have 18. It's good for most of the patients when doing the retraction, most of the patients. But there are some patients where in which it's not enough, and in other cases it is too much. So we have to adjust. This is my point here. We have always to adjust. So sometimes more, sometimes less, and sometimes it's perfect. What we have, what we get by companies is perfect, but not in all the cases. This is why I think edgewise, even when I use straight wire appliance, pre-adjusted brackets, I need to think edgewise, because thinking edgewise, I know that the relationship and the angulation and the inclination and the ins and outs, they can be adjusted, they can be magnified, we can have a better refinement if we read all those possibilities here in our bracket, in our wire, in our arch wire. So I know that I'm very passionate about this because I know this works for me and for you. There's another quote here from another fine professor, another brilliant orthodontist, which is Dr. William Profit. I find the precise details of the prescription moderately irrelevant, because I know I'm going to have to make some adjustments for the specific patient in almost every case. Meaning I need to do that if I had this high standard of final refinement of treatment. If I have, and I know I have, and I know you have this high standard of refinement of orthodontic treatments, I need to understand these prescriptions. I need to understand the relationship between torque and between the arch wire torsion, and I need to know how to do these bands and torsion, which is the torque that I use for the final treatment, for the final stage of my treatment, the final phase of my treatment, and during the treatment also. Sometimes I have to do this, and I'll show you in a few classes ahead how to think, and how to compensate, and how to modify the inclination, and how to correct the inclination when things are not going that perfect track that the companies they say to us that the bracket they give us is going to give for us the right track. Sometimes it just don't work. It just won't work in some of our patients. Okay, so doing edgewise and doing straight wire, very different. But thinking edgewise, using torsion of the arch wire, I can do my real torque, the real torsion. When I do that, I can do all the compensation that I need. I can use neutral torque, meaning no torque at all, no torsion at all. I can do positive torque, I can do negative torque, and all those inclinations, all those torsions that I can give, and the magnitude, specific magnitude that I give to the arch wire, they will have a specific relationship with that tooth or that group of teeth. So we think edgewise even using straight wire. This is the main thinking of our class now. Okay? Hello, my friends. We're back with the same topic, which is very important, torque in orthodontics. Now we're going to address another situation where we have to look for in our treatment, in our practice, in order not to have many mistakes. For example, am I giving the right reading of the torque? Am I giving enough attention to understand the topic, the torque that I'm talking about? Am I paying enough attention to what is going to happen when I do this kind of positioning of the rectangular arch wire inside the slot? Is it what I'm doing when I put my first rectangular wire in my patient? I'm running a sequence of wires, so I'm going to, I start with a round wire, a night high wire, and I go with my sequence which I use first night tie wires, super elastic or thermal night tie wires. Then I go to stiffer round wires, steel round wires, like stainless steel round wires, 016, 018, 020, and then I go inside, I get in my first arch wire, rectangular arch wire, which is usually 1725, because I use 2230 in my slot. So I'm used to doing the first rectangular wire is not that thick. So I start with this rectangular wire, and now I have to evaluate the anterior torque which is present in my rectangular arch wire. So when I grab an arch wire from my stock, I just look at him. It's not round, it's not twisted. It's completely neutral, because I buy it this way. I buy my rectangular arch wire with this form, form which comes from the company, and then I can avoid doing, if I need to avoid doing this twisting, depending on the situation. What I mean is, when I want to do some torsion of the arch wire, I do, and I'm going to show to you how to do this and in your practice, and you will look anytime you want for these videos that I'm going to send to you, that I'm going to show to you in this class, not in this class, specifically this class, but in this course. I'm going to show you how to do, and you can practice, and you can come back, you can rewind the video and do it again and see it again and see as many times as you want in order to apply it in your day-to-day practice like it is normal, like it's natural for you, okay? And you are going to see how to do it. It is easy the way I do the torque. There are two ways to do the torque and the practice, and I'm going to show it to you, and you are going to have the opportunity to go back and go forth and do the torque anytime you want, and every time with this natural manner, okay? So the torque. First of all, we're going to address the anterior torque, the anterior segment of the arch wire, which is obviously going to get in the anterior segment of our dental arch. So I'm going to apply a torque or not, and I'm going to see how the torque is. And this is the real torque. We call it the real torque because this is the torque which is in the arch wire, not the torque inside the slot, or the torque that is felt, if I can say like this. It's the torque that the arch wire applies to the slot. No, this is the torque itself, the torsion itself. This is the torque that we apply to the arch wire, which sometimes has nothing to do with the torque, the relative torque, which is the torque that the tooth or the teeth will feel when you put the arch wire inside the slot. Okay, so let's move on. First of all, I'd like to see how the torque comes, and it comes almost always this way, completely neutral. So meaning there is no torsion in the arch wire. There is no torsion in any segment of the arch wire. This is the way it comes from the company from which I buy, and this is the way I put in the majority of my cases. The first arch wire is it goes with a neutral torque. Not always, no, not always. There are some cases in which I have to apply some kind of torque. You are going to see this in a few classes ahead, and maybe I just call your attention about this in this very class here, but we are going to see. We're going to see how it works. So first of all, the neutral torque. There's no twist of the wire. The base of the wire, if you just cut your arch wire here, let's think about this arch wire as being a segment of the arch that we buy, and we just cut this arch wire in the middle, like the middle of your midline. You cut this, and you're seeing it now. You're looking for this segment here. You are looking for this position of the rectangular segment. When you place it in the glass slab, you place it, if you just look with a magnifier glass, you are going to see this here. No torsion, it stays parallel to the glass slab. So this is no torque. You can do this by looking at the glass slab, but it's very difficult because sometimes you cannot see these slight differences of angulation of the arch wire. But the best way to do this is using our plier. This is a 142 plier, 142 plier. It's a plier meant to deal with rectangular arch wires. So this plier, I grab the wire, the segment that I want to evaluate, which is the torsion, and if it passes like at the same line of the middle of the plier, I'm going to see that there is no torsion at all in this arch wire, this rectangular arch wire. So in this case, we have no torsion, we have what we call neutral torque, so-called neutral torque. This is a real neutral torque, meaning no torsion at all, okay? So in this case here, it's different. Now we don't have the neutral torque. We have a torsion that is made in the anterior part of the arch wire, as you can see here. As I told you before, this is a segment. This is like we have cut the arch wire in the anterior, in the medium part of the anterior segment. So if we look at the midline, we just cut the arch wire here. This is the anterior part of the arch and the arch wire also. So we have now a torsion that was made in this kind of situation here. A torsion was made here in order to achieve a specific situation. So we won't address it now, but you have to understand that. Thinking about the upper dental arch, when I have this torsion like this here, forming this angulation between the glass slab and the segment of the arch wire. So let's see it here again. We have this segment here, and it's not neutral anymore. It's not parallel anymore. We have now an angle formed here between the glass slab and the base of the arch wire. We call it a negative torque, meaning for the anterior part of this, the upper arch, upper dental arch, if I put this arch wire this way, it tends to give to the anterior dental segment for the incisors. For example, if I do distortion from lateral to lateral, from distal to distal of lateral, upper laterals, when this arch wire gets inside this slot this way, the upper arch, the upper dental arch, the upper brackets, the anterior segment of the upper brackets, so we have a negative real torque. Sometimes this real torque, it won't move, it won't incline the anterior teeth negative. It won't incline palatally the anterior teeth because we have this relationship between the real torque and the relative torque. The real torque is one thing, it's just the torsion of the arch wire, what is present on the arch wire. It doesn't mean that you're putting this kind of torsion, which is negative for the upper, it's going to incline anterior teeth palatally. It doesn't mean that, because you have to understand this relationship between the inclination already present in the slot, which depends on the inclination of the tooth or of the teeth, the segment of teeth, and the inclination of the arch wire itself, the torsion on the arch wire itself. So this relationship between those two situations, the torsion and the inclination that the distortion will find when it gets inside the slot, it represents the movement that the teeth will feel, the teeth will have, okay? It's not clear now, but it will be clear in a few moments. Let's go further. So this is a negative torque for the upper part of the arch, okay? If we put this way, the same torsion here, we put this way with this inclination, in the anterior segment of the lower arch, it is different. It's going to tend to give a buccal inclination of anterior teeth. So in this buccal inclination, we call it this. This is a positive torque this way, put in this way in the lower arch. So it depends on the way you insert this rectangular arch wire. If it is upper or lower, it will be different. So if we want to do this, the same inclination, the same torque, the same real torque for the upper and the lower, so this is a negative torque in upper arch. For the lower, I have to put the arch wire upside down. I have to invert the arch wire for it to have the same reading, the same tendency to do the inclination in the anterior segment. So this is negative. If I want to do the same thing to the opposite arch, I do the inversion of the arch of the arch wire in order to have the same signal of torque. It's negative this way, and to have the same here to the lower arch wire, I do the inversion of the arch. Okay, so another way, which is very clinical way to understand the torque, the real torque, is grabbing with the anterior segment, which we are now evaluating. We grab the anterior segment of the arch wire with our plier, and the posterior part of the arch wire, it may go down, up, or, as we saw, neutral. So here we have a different situation from neutral. It's not neutral anymore. This is now a negative torque for the upper arch. Imagine this. When I go, like, I grab here, and I go horizontal here, what is going to happen in a medium situation, in an average situation? What is going to happen here to the incisors when I put this wire inside the slot? So when I go up here to the upper arch wire, when I put it inside the tube, inside the posterior slot, the posterior teeth slot, I'm going to change the inclination in an average position. I'm going to change the inclination of anterior teeth going negatively. So it goes towards palatal, which is a negative crown torque, because we are seeing the crown here, because the crown is what we see when we treat patients. The crown is what Andrews referred to when he did his 6 key of normal occlusion, of an optimal occlusion or ideal occlusion, as you want to call it. So we will see and we will name the torque according to the inclination of the crown. So when you go to the literature, many people refer to the torque referring to the root, because it moves more than the crown. It's obvious. But when we see things, we see the crown. When we want to do things, for example, I want to do a positive crown torque in order to have a more aesthetic, a more beautiful smile, because this torque is too negative and I want to go a little bit vertical or positive, neutral or positive torque. So this is what we call the crown. We refer to the crown. So in this situation here, this is a negative real torque, meaning a negative real torque when we think about the crown. Okay? So this is what we think, this is what we see, and the opposite, again, taking into consideration that we are going to insert this arch wire this way it is, in the upper dental arch. We're going to insert in the upper dental, in the upper brackets, in the anterior region, this way. So we grab the arch wire, and it has this inclination. When we grab it, the anterior segment of our arch wire, it is not neutral, it goes up. So if I insert this arch wire inside the slots of the anterior segment, we are tending to move it, inclining the crown towards buccal, which we call a buccal inclination, a positive torque, a positive crown torque. Okay? So if we want to do the same thing, we want to have a positive real torque to the lower arch, to the lower dental arch, I have to invert it. Okay, it will be clear in a few moments when you talk about the relative torque. So we have here three possibilities of real torque: neutral, negative, and positive. So what is the torque? Just the torsion. The real torque is just the torsion in the arch wire, the torsion that we make in the arch wire, the torsion that we give to the arch wire. Okay, so those three situations we call neutral: zero inclination when I grab the arch wire, zero angulation here. We have the negative torque, real torque, when we grab the anterior part of the arch wire and it goes down, meaning inserting this way in the upper dental arch. So we have now a negative torque, negative real torque. Okay, and here we have the positive real torque. So we have these three possibilities thinking about the anterior segment of the arch wire. Okay, just for now, just stop a little bit. Hello, my friends. We're back with the same topic, which is the torsion directly made to the arch wire, to the rectangular arch wire, obviously, because if it is a round arch wire, it won't matter if you do this torsion or not, because it won't make a difference. Okay, in this case, we're doing the torsion in the arch wire, in the rectangular arch wire, in order to achieve some kind that we desire to, some kind of inclination of this segment of the arch wire, to have a relationship between this angulation, this inclination of the arch wire and the inclination of the slot. So this is the most important thing. So I always say the same thing to you because I consider this very important. The relationship between the torsion of the rectangular arch wire and the inclination that this rectangular arch wire will find when it goes inside the slot. So we have the slot with very varied inclinations. We can do this, do that, and we have this difference in the relationship between the inclination of the torsion of the arch wire, meaning this is my arch wire, this is my hand representing the rectangular arch wire, and this is the slot. Okay, so this is what I mean when I do this or that. We do positive or negative inclinations here in the arch wire, and when it finds a different inclination here of the slot, which is obviously related to inclination of the teeth or tooth, we will have a different relationship. We can have many different relationships between this inclination here, real torque, and the inclination here. And this relationship, we call it a relative torque. So sometimes it has nothing to do with the real torque. We may have a real torque, a positive real torque, upper arch positive real torque, and we have here a passive relative torque. I'm jumping a little bit ahead because I want you to understand that the most important thing here is to understand the relationship between the real torque, the real torsion of the arch wire of the segment that we are doing the torsion, and the relation between it, the torsion, and the inclination of the slot. We have the bracket, we have the slot, and we go inside the slot with this wire, and this relationship between the inclination or torsion, meaning torsion of the rectangular arch wire, and the inclination of the slot. This is what matters for us. But we have to understand the real torque. We saw that the real torque in the anterior segment of the arch wire, we can measure it, we can evaluate it, and we can sometimes even measure the inclination, the torsion. I'm going to show it you here when I'm going to say when I say about the posterior torque, the posterior real torque, the posterior segment of the arch wire. Now we're measuring, we are evaluating this torsion. Here we have no torsion at all. So as you can see, we grab here the posterior segment where I want to evaluate, where I want to assess I go with my plier, 142 plier in this case, and I grab it here. I seize it here, and now I see what is the relation of inclination or angulation. I have this always this mixing of words, inclination and angulation. It may seem that they are both the same, but they are not. Inclination, it means the buccal, palatal or buccal lingual inclination of the teeth, and the angulation is the mesial distal angulation of the teeth, or in a specific tooth. So inclination is related to the third key of normal occlusion, which is the inclination of the teeth. And here we refer to the same thing. As I told you before, when I refer to torque, sometimes I know I have this confusion. I say torque meaning inclination of teeth, and this is the same thing in orthodontics. We are used to saying the same thing, to refer to the same thing when we refer to torque, the torsion of the arch wire itself, and the inclination of the crowns. And I told you before also that I'm representing here not negative or positive, so the signals are related to the inclination of the crown. I know many people refer to the inclination of the root. So sometimes we say a positive real crown torque, a positive real relative crown torque, a positive relative crown torque, positive relative crown torque, because it is what the tooth that we are moving, or the group of teeth we are moving, this is what they will do. They will do the inclination. The torsion of the arch wire will manage to do the inclination of those crowns. So I prefer to refer to the crown because this is what we see. This is directly what we refer to when I'm going to do some kind of adjustment in my group of teeth to do this correct refinement or intercruspation. Okay, so I'm referring to the torsion of the arch wire, and sometimes I say the inclination referring to the torsion. Same thing for us, and we will get used to doing the same way because we refer to positive, negative inclinations, which we do all the time in our day-to-day practice. We do it all the time. We do this kind of inclination to adjust some bad positioning of our teeth. And this inclination we refer to the crown because it's what we see directly. It's in what we are working in our day-to-day practice. We don't see crown, we don't see roots. We know the root is going to do the movement, but we refer as, and we meaning me, and here with my students, and many people in the orthodontic field do the same. I know that there is a huge amount of orthodontists that refers to the root, but when I say negative or positive buccal or lingual inclination, I'm just referring to the crown. Okay, just in order not to need to all the time say buccal crown torque, I'm going to say buccal torque. This is crown. Okay, so let's move on. And here we have the, coming back to our explanation here, here we have the neutral posterior real torque. So the neutral posterior real torque is no torsion of the rectangular arch wire in the posterior segment of our arch wire. So we have no torsion. It's like we buy it from a company and we put it in our stock. So this is how it comes for us. It comes neutral, unless you buy some different kind of a different brand of arch wire that already comes with torsion. It's not common. It's not something that I'm used to seeing in my country at least. Okay, so in this situation we have no torsion. It may be it may seem a little bit silly for you that I keep just repeating these concepts, but I think it is important. And the way I teach is like this: I go and I go back, and I remember that I told you before something, and I go there where I told you and say, do you remember that thing that I told you before? And this is the way I learn. And I think it's important for you to understand. This is the way I learn and the way I teach. I have to go back and go back again and refer to some concepts again and remember and remind you that concept is important. So this is the real torque, and this is the evaluation of the posterior real torque, the posterior arch segment real torque, or torsion, the real torsion of the rectangular arch wire. When it goes like this, it goes up when I grab the posterior part of the arch wire, and it goes in the opposite end, in the opposite tip, it goes up. So if I put my plier in a horizontal position related to the horizontal, the floor, when it goes like this, and I grab here in the posterior part of the arch wire, the opposite tip of this wire, it goes up. And again, this is something related to the upper arch wire. We refer to this as a positive real torque, because when we put it here like this in our posterior segment of upper teeth, it tends to incline posterior teeth buccally. So think of this image here. If I grab the posterior segment, the opposite posterior segment, it's not being grabbed here. When I go down with it, when I go to the level of the tube, in this part, meaning the opposite part of the arch, in which this tip here is inserted, in which this rectangular wire is inserted. So think of it. When I have it here, it is up. When I go like this, look at my hands. Look at my hands. So this part of the arch, this part of the bracket is going to feel, it's going to suffer a torsion, it's going to suffer a couple, which is generated by these 2 points of the arch wire touching opposite points and distant points of our bracket. So this is something that tends to move, tends to incline those teeth in a buccal direction, towards buccal, okay? So this is why we call it a posterior real torque, posterior real positive torque. So this is for the upper arch. If I am inserting the same arch in the same position, so in the lower arch wire, for example, this is, if I'm going to insert it in the lower arch wire, this is the left side of the arch wire, okay? I'm going to insert like this, and it goes up here. Same thing. I go down to the level of the tube, and we go like this with the crown. We go like this, meaning inclining the crown towards lingual. So this is a negative torque, meaning I have to read the torque all the time when I insert the arch wire inside a slot. So just for remember, you can have many situations, many inclinations that you find in your teeth and find in your, of course, the same thing will happen to the slot. So we have many different possibilities. We have all the time to remember to read the torque, to read the position in order not to mistake, in order to commit some mistakes in our treatments, okay? So this is for the posterior part of the upper arch wire here. I mean that I have here a posterior positive real torque. Posterior positive real torque, okay? So if this is inserted this way in the lower arch wire, we consider this a posterior real negative torque, okay? So what do I have to do, Kleber, if I want to have a posterior torque in the lower arch wire? We invert like this. We go upside down. We put this way, not this way. So we have here, for the lower arch wire now, we're going to have a positive torsion, a positive real torque, okay? But you have to remember that I'm not saying that every time that you insert the wire like this, you will have always a positive torque in the upper arch here, or a positive torque in the lower arch here. I'm not saying that. I'm just saying that in the average situation, we will have, when I do this kind of torsion, a real torque, we will have in an average situation a positive torque here to the teeth, a positive inclination, meaning inclination to the buccal, and here, if I'm using it in the upper arch wire, and here I'm having a negative inclination. Just think of it. Grab the arch wire in the posterior segment and think, when I'm going to a horizontal position of the arch wire, meaning I'm going to the level of the tube in which it will be inserted in a clinical situation, it goes to the tub, so we have here this, okay? So posterior, I put it here in the posterior part of the arch wire, the upper arch. I inserted this wire here, and it goes down in the opposite end. When I come like this, when I do like this, I'm going to have a tendency to a negative torque, to a negative inclination of the crowns, of the posterior crowns. So that's why we call it a real positive torque here to the upper arch. And if it's the same upper arch here, this is called a negative, real negative crown torque, okay? Same always about the crown, meaning always about the crown, okay? So let's see it here. Take a picture of this image here and you won't forget. So when I grab the posterior segment of the arch wire here, okay, and it goes up, for the upper arch, it is considered a positive real torque. If I put it the same way in the lower arch, it will apply in an average situation, it will apply a negative crown torque, okay? Always real torque, okay? And here, for the upper arch wire, for the upper arch, if we grab our arch wire in the posterior part of it, and this side, of course, in this side, when it goes inside the tube, inside the brackets, and we go up with the opposite end, opposite tip, and we go up to insert in the opposite tube, in the opposite brackets, we're going to, in an average situation, we're going to have a negative crown torque. So that's why we call it negative real torque, because in average, we're going to apply a negative torque to these crowns here, okay? The crowns in which this part, the segment of the arch wire is inserted, okay? So here it's down, upper arch, I'm putting inside the molars, the tube of the molars and the brackets of the bicuspids. So it goes down in the other end, posterior arch, I'm going up here. The tendency is a negative torque. So we call it a real negative crown torque. The opposite to the, here is lower arch, I'm sorry, here is lower arch. If I'm putting this here in the lower arch like this, it goes down in the opposite tip of the arch wire, and we go horizontal, we apply a torsion, we apply a couple, which is going to generate a tendency of inclining those crowns buccally. So it is a positive real crown torque, okay? As I told you before, it doesn't mean at all that this is the case for all teeth, because the inclination of those teeth may change this torque, this relative torque, which we didn't study yet. So we are going to see about this in the other classes, in the next other classes. Here we're just we're just giving a name to the real torque, to the real torsion. So we can have it positive, we can have it negative, or we can have it neutral. So the torsion can be neutral, no torsion, positive or negative, and it will depend, the name will depend if positive or negative. It will depend on the reference that you use. So upper arch is, which is positive to the upper arch, with the goal with the same arch wire, not changing not inverting it. If it goes this way, here is positive for the upper, and for the lower it is negative. So if I want to have a positive here, this is how it goes. Upper arch, it goes negative, okay? I'm just mimicking here, trying to get it a little bit more clear, but I know it's not easy. I promise you, things will get easier once we reach another part of our explanation, when we start saying about the relative torque, okay? So for now, it's just this: negative, positive, or neutral real torque, real torsion of the rectangular arch wire. Hello, my friends. So now we're back with torque, always torque. And this is a very important notion, a very important concept of torque. This is the relative torque. Now we're entering, this is very important. Now we are entering the realm of clinical orthodontics, something that we do in our day-to-day practice that really matters, really change our level of orthodontics. This is something that if you master, and you will master in your practice, you will have beautiful results. You will have a high level of refinement of your treatments. So this is something that you have to pay attention. This is why we took that long time to get in here. That time of explaining what is a real torque is for this moment, for the understanding of the relationship between the torsion of the arch wire, the real torque, and the inclination present and the slot. So we have now something that is very important, which is the relationship that will change the inclination or keep the inclination as it is, as we find before we insert our rectangular wire. You will see in this class, you will see in this course, that sometimes we commit mistakes because we don't know how to read the torque. We commit some mistakes, we have a very bad outcome because we can't manage to do this, adapt the torsion, to find the best position to put the inclination or the torsion of the arch wire inside this slot. Sometimes we can even have a very severe root resorption because we didn't understand what was going on in that inclination. And this is what I'm here trying to explain to you. We are calling your attention here about this topic. You need to understand what is going to happen when you put in, it seems very harmless, but it's not. You put a innocent rectangular arch wire inside a rectangular slot. Do you understand that? This is the most important thing for us. It's not harmless. We will cause a damage to the occlusion, will cause a tragedy sometimes to the resorption of the root. So let's pay attention in the relative torque. This is the torque expressed in the bracket slots and consequently in the teeth. In other words, what the twist of the wire will represent in terms of inclination tendency in this teeth. So what is going to happen when I put this arch wire inside the slot? So this is the relative torque. This is what the teeth what is the movement that the teeth will have when you put this arch wire inside the slot, when we insert the arch wire inside the slot. So we have the possibility here of having a passive torque, meaning not neutral. Neutral refers to the real torque. Here, when the relative torque is applied, when the relative torque is what we are thinking of, we use the expression passive torque, passive relative torque, okay? We can have it either passive or active. So when we have the active, we can do negative or lingual, meaning lingual, or positive buccal torque. Again, we are talking here about the crown. We are not referring to the root. When we refer specifically to the root, I'm going to say a root torque. So if I don't say anything, I'm referring to the crown torque. Okay, pessoal? Okay, guys? I was talking Portuguese here. Pessoal is guys in Portuguese. So let's move on. We're not here in this part of our course, explaining resistance torque. It will go to, it's very important when we're going to do the retraction. So later on, we are going to explain this. Now we are focusing on passive and active torque. And when we do active torque, the negative or the positive crown torque, okay? So this is what's going to happen. Let me go back again to this image here, which I love. I love this image here. It explains everything about the relative torque. We have the possibility of having a passive torque. As you can see here, we don't have activity here. We have no activity inside the slot. So the torsion of the arch wire, it found the right inclination of the slot. And if we insert this kind of real torque inside the slot, we are going to generate another relationship with what we call, which we call the active torque, active relative torque. What is this? Negative or positive? We're going to see in a moment, okay? So the other possibility here, same thing. Actually, you can see what is going to happen. The torsion here of the arch wire, being in elastic stainless steel arch wire, have this possibility of going back to its form. So when we insert this way, the inclination of the slot is going eventually to find the inclination of the torsion. So this is what's going to happen. We know that when we exert a pressure in our root, it goes to respond with those movements that we see with pressure side, tension side, resorption, and a position of bone, and we know the history about this. So when we exert a force, we exert here, in this case, a couple, we are going to generate a specific movement, which we call a torque. I'm calling your attention all the time about this terminology, this way we think and we refer to the inclination. It's a torque. I know. If I'm very straight about this, I know that torque is one thing and inclination is another thing. Torque is just a torsion. We know that. But sometimes, almost all the time, we refer to the inclination of our teeth as torque. Okay? So excuse me if I commit this mistake, but it's on purpose. I know this is different. I know they are different. There is a difference, better saying, but I'm going to refer the torque or the inclination or as the same thing when I refer to teeth. Okay? Okay, guys? So let's move on. Beautiful image. I love this image. I made this image. I love it. Let's go. Let's move on. Relative torque. The way to check, this is important, guys. The way to check the relative torque is to insert the rectangular wire into the bracket slot of the tooth or group of teeth that we want to check, and assess and evaluate in which position the wire tip, the wire end, will pass in relation to the molar tube. Because when we insert it in the molar tube and it goes to the molar tube, of course, you know that you won't rest like this in a clinical situation. It won't be like this. You have to insert it inside the tube. So this is the reference we have when we put it inside the tube. So this is the way to assess. This is the way to evaluate the relative torque. Okay, let's move on, and we are going to understand it in this next slides. Relative torque. Let's understand now what's going to have what's going to happen in this relationship here. So as you can see, we have here a different inclination between the rectangular arch wire, the transverse section of the rectangular arch wire, which is neutral, meaning no inclination, no torsion at all, and the inclination that we see here of our slot, our bracket slot. So we have different inclinations. So when we insert the neutral torque, and the neutral torque finds a different inclination of the slot, it will express some kind of force, because it's a negative relationship. It's not a passive relationship, you know? So this is what is going to happen. When I insert it here, now we have the rectangular arch wire inserted in this position, in the slot, and the slot has this inclination, which was different from the inclination of, or the torsion of the arch wire. So when we insert it here, it goes down, it goes occlusally, it goes toward occlusion. So what is going to happen when we force this arch wire to insert it inside the slots, inside the tube of the molar, inside the slots of the brackets of the premolars and canines, and on and on. So what is going to happen in this part of the arch wire? In this part of the interaction between the arch wire and the slot, it is going to generate a force. Can you see this? In which direction the force will act? What do you think? It will rotate, it will generate a couple, it will generate 2 points of pressure, at least 2 points. Let's simplify it here for this moment. 2 points of pressure inside the slot, which we call couple, to equal force in different same direction, different senses, okay? And horizontal, vertical, so the same direction, but different senses, one down and one up. And this couple will generate a moment, tendency to rotation, or if you want to be more straight, more direct, inclination, tendency to inclination of the crown and the root, okay? So it will express this active relationship now, meaning that we are going to have a very precise force applied to our crown and to our root, okay? Just see in the moment we're now. And here you will see what's going to happen. We will tend to do this rotation, and it's really a rotation. And let me call your attention for a very advanced concept here, which is the torque is a free vector. So in any position that we apply a couple, the couple is a free vector. In any position of a body that we apply a couple, it will rotate that body, being the center of rotation, the center of resistance itself. So the center of rotation here is the center of resistance itself, meaning this is a situation in which the body will move, rotating being the center of rotation, the center of resistance of the body. So this is what is going to happen. We'll have a tendency to a palatal inclination of the crown and a buccal inclination of the root. So if I have just a couple here, if I have just a couple generated by the torsion, as you know, generated by the couple generated here inside the slot, we will have this situation here, a palatal or negative, meaning negative crown torque, and a buccal root torque. Is that what you want? Sometimes you can feel, you can imagine that this is what you want, but it's very uncommon that you want this kind of thing just when you put the first rectangular wire. You may be thinking, and if you have already read something about this, You may be thinking now, but sometimes we don't have like this because we have a play inside the slot. All those things will be addressed later, okay? I'm just thinking simple here. I'm just simplifying the concept here. When I put this kind of wire, let's think that is a thick wire that fills completely the slot. And let's think what's going to happen when I put this wire inside this slot. So thick wire filling completely the slot. What is going to happen in this relationship? This is what we're talking about in this images here. So in that situation that we saw before, what did we have? We had an inclination of the root and the crown of the teeth, anterior incisors, or the incisors, anterior teeth. So when I put a neutral real torque, the interaction between the neutral real torque and the inclination of the slot changed the position of the crown and the root. So real neutral torque in that situation represented a negative crown relative torque, meaning what the teeth or the specific tooth will do, what it will suffer after we insert that specific real torque inside that slot, okay? So this is the most important thing. If it's not completely clear now, just hold on, you will understand, I guarantee that. Let's go on. So, but Kleber, you're saying to me that every time we insert a neutral torque in a specific inclination of anterior teeth, I'm going to have an active interaction. No, sometimes not. But sometimes if you have different inclinations, specifically in the extreme positions, okay? Very buccal or very palatal inclination of the crown, this interaction, it tends to be an active interaction, not a passive interaction. So let's see how it goes in this situation. Same torque, same real torque. See, same real torque, which is completely neutral. Neutral torque. No torsion at all in the wire. What is going to happen now? Same torsion, zero torsion, neutral torque, neutral real torque. Now we have a palatal inclination of the crown. So when it finds this palatal inclination of the crown and the negative inclination of the slot, because the crown is too negative, so the slot is down, it's downwards. The slot is inclined downwards. Okay, so it is this way. Neutral torque, it will find now an active relationship and a inactive interaction is going to happen now. So when I insert now this neutral real torque in this negative inclination of the crown, what is going to happen? What the couple generated inside the slot is going to apply to this specific tooth here. I'm putting in the whole region, it's the incisor, but let's see as a central incisor to make things simpler. What is going to happen? What is the tendency of inclination of the crown and the root when I apply this kind of neutral real torque in a crown inclined palatally like this? It is going to change the inclination, of course. It is going to change this way, buccally, inclining the root buccally. So sometimes we want to do this kind of inclination. Yes, many times actually. Think about, for example, a class 2 division 2. It's very common that we want to do this inclination before we do the retraction. We do the inclination, buccal inclination, then we do the retraction. So it's very common. I do it many times, but the opposite, not. So in this situation here, when we insert this neutral torque in this inclination, what is going to happen is a buccal crown torque. It's a buccal relative crown torque. I'm referring to crown just in order to intensify this concept. I'm just speaking about crown, okay? Torque, crown, torque, crown. If I have to do otherwise, if I have to refer to the root, I'm going to tell you a buccal root torque, but it's not common for me to refer as a root torque, okay? So as you can see, the same real torque applied two different relative torques to the anterior teeth, because the inclination of the teeth, the inclination of this specific central incised tooth is different in those two examples. First one, very buccal, inclined, great inclination to buccal, and the second situation, great inclination to palatal, to lingual, okay? So we have these possibilities here, and for me, the most important thing is to make you understand this relationship between crown inclination and the torsion of the wire, the rectangular wire. And we'll have many examples of that. But I want you to focus on this topic here, the relationship, the interaction between the inclination of the segment of the arch wire, the rectangular arch wire, and the inclination of the slot, which resembles the inclination of the crown itself. Okay? So we have different inclinations of the slot and different possibilities of inclination or torsion of our rectangular arch wire. So the most important thing is the interaction. Okay? Okay, we're back, and now we're going to say another thing about the most important torque that there is, which is the relative torque. We have to understand, again and again, I'm not tired of saying that to you, we have to understand the relationship or the interaction between the inclination of the slot and the torsion in the wire, the arch wire. So this is the most important thing, because it is in relation to which the tooth or teeth will respond when the arch wire gets inside the slot. So putting a torsion and having a determined inclination, some inclination, we have these possibilities, which are really great possibilities to do this kind of compensation. So now we are going to understand, because sometimes I hear people saying that, well, I work with straight wire appliance, so I don't have to think about torque. It's false. It's very simple. It's a simplification of the treatment. We don't want that. We have a high standard of finalization of refinement, orthodontic refinement. So we have to understand that even though we use just straight wire appliance, I do just straight wire appliance. I work with straight wire appliance. I have in my stock, I have like one or two cases or two sets of cases of edgewise, because I use sometimes, for example, in class 3s, I use sometimes the lower arch in order to avoid inclination and angulation. So this is something that I use very rarely in my practice. I usually use just straight wire appliance, straight wire brackets. Even using just straight wire brackets, I have to understand and I have to work with torques. Let's see how it goes. Let's see the motive. Why we use torque. We have to understand the concept of torque, even though we just use straight wire appliance. So brackets prescription. Sometimes we have a different bracket with a specific prescription. We have class 3 prescription, class 2 prescription. We have a class 2 thinking about the movement, thinking about the translation. So this is a specific prescription for translatory movement, and we have prescriptions that are thought just for finishing the treatment. So those are different kinds of prescriptions. We have talked about that before, and you must remember that I told you that when you do the inclination, we do the retraction, we tend to lose inclination of our crowns. And if I'm just using a prescription that is thought, that is planned to do this counter movement, meaning I'm going this way and I'm trying to counteract this tendency of losing inclination. So the prescription which I'm using here, it's a high torque prescription. It's very common, this kind of high torque expression used in straight wire appliances, in self-ligating straight wire appliances, okay? We know that we have the high torque, low torque, the standard torque, the same thing here. I'm just referring to high torque as an expression for you to understand that's a huge torque, a huge buccal torque that will tend to counteract the tendency of losing inclination, since we are applying the force in our crown and a distal direction. So towards distal, we are applying the force in this level, at this level here. So we tend to lose inclination, since we are applying the force far from the center of resistance of this tooth or the group of teeth that are moving. So this is the tendency of losing inclination. The torque in a prescription that is meant to do the counteraction of this tendency of losing inclination, the torque embedded in those teeth is a very high torque, okay, which works as a resistant torque, which are going to talk about and train and do all the stuff we need in order to understand, because I really want you to understand. I really need you to understand that concept, because this is what is going to save time in your treatment, what is going to avoid you stopping your treatment to counteract and to correct something that you generated during your mechanics. So in this case, we have to understand that when we do this movement, applying the force in the crown of our teeth, we are going to generate, it's very clear, I think it's very clear for you that we're going to apply a force and a moment when we do the inclination, we don't do the retraction using the line of action of the force at the level of the brackets. We're going to have the force, the distal movement, and the moment generated by the force applied far from the center of resistance, okay? So in this case, when you do the prescription, we use the prescription that is meant to counteract this tendency of losing inclination. We have a high torque prescription. So it tends to go buccal, to incline the crown buccally, because the buccal inclination, it counteracts the palatal inclination generated by the force, okay? So sometimes people tell me, oh, I don't need to know much more about torque. I don't need to apply torque in my cases because I just use straight wire appliances with high torque, with low torque, and that goes on and on and on. It's false. It's a very simple thinking of the mechanics. We don't want that. We won't apply that thinking in our treatment. We will apply a different thought. We will do the retraction using the inclination of the real torque, the real torsion, in order to achieve a relative torque that will simplify the mechanics, will favor our mechanics. So we will apply the thoughts that we need to know the real torque in order to achieve a relative torque that favors our mechanics. That's it. So let's move on. I'm really I talk too much, I'm sorry. So this is I've seen that before. This is the way we think in orthodontics. We read the torque, seeing in which position the anterior torque, of course. We read the torque, we're just focusing here in anterior torques now. After that, we go to the posterior torques, okay? So we know how to read the torque, we know how to see the torque, we know how to assess, to evaluate the torque. We just put our rectangular wire inside the slot, and we assess in which position the posterior tip of the arch wire will pass in relation to the tubes and the posterior brackets of our, in this case, upper teeth. Okay, so it goes down. What is going to happen now in this situation? We're using here a edgewise bracket. As you can see, we have no compensation in our bracket base, in the base of our bracket. So we have an edgewise bracket here. In this situation, and in the past, every time that we had to use this concept of using a rectangular wire, we had to do a torsion, a negative torsion, real torsion, in order to find the best relative torque that we needed. Most of the time, passive torque. So, as you know, as you can see here, for that, I can't use for having, for example, in this situation, a relative passive torque. We can't use in this situation edgewise bracket, no compensation in the bracket. So no, it's a standard bracket, so it doesn't have the inclination embedded in it. So in this case, we have to do the compensation of the torsion to find the best relative torque that for us to favor the mechanics. This is the point here. So in this case, if we just grab our standard rectangular arch wire with no torque, neutral torque, and we have an edgewise bracket, what is going to happen here? We will apply different inclination to the crown, different from this inclination that we find here. So what's going to happen? We will have a moment generated by the torsion, by the torque, by the couple generated here. We will apply a palatal crown torque, meaning a negative relative torque. It goes with the root for buccal, towards buccal, and with the crown towards palatal. So in this situation, applying a neutral torque, neutral real torque, having an edgewise bracket, if the crown is buccally inclined, which is normal, upper teeth, buccally inclined, we know that the lateral and centrals, they have, in a class 1 situation, a buccal inclination of the crown, of the buccal aspect of the crown, a buccal inclination. So in this case, if we don't adapt our real torque to that inclination, when the rectangular wire goes inside the slot, it will apply a negative crown torque, a relative negative crown torque. Okay? So this is something that sometimes you want, sometimes you don't want. Most of the time, we don't want that. But if I use a different concept for that, if I use, for example, a straight wire appliance, a straight wire bracket, in this case, for example, what we have is an edgewise. An edgewise is standard. They don't have the edgewise bracket. They don't have this inclination embedded inside it. So we have always this relation base against the slot, 90 degrees of inclination of the slot related to the base. So all the brackets, they have the same relation, 90 degrees between base and a slot. So if we have this kind of inclination or negative inclination of the crowns, they don't adapt, they don't compensate. The brackets, they don't compensate. So if we want to compensate, for example, to keep the inclination that we find there, let's think about the lower arch wire. As we know, the second molar in the lower arch, the lower dental arch, the second molar has a huge lingual inclination, a big lingual inclination. And this lingual inclination, in Andrew's study, he found 35 degrees of inclination of the crown in a class 1 patient, 35 degrees. So imagine that. Imagine that you're putting here a 0 degree inclination in your torsion, and you find here 35 degrees. When you put it inside the slot, you will have a huge force that will incline the root towards buccal. Is that what you want? Hardly. Is that what we want? rarely, okay, almost never you want this kind of precisely in the first rectangular wire that you put. You don't want that. You may want some kind of compensation of movement, and you may want to have some kind of torsion in the posterior region, but not in the same arch wire, the first arch wire, rectangular arch wires. Okay? Mostly I do that after that of the first arch wire in order to correct the inclination. But keep that in mind. You have to understand and you have to know how to read the torque, how to understand the torque you are applying, the relative torque you are applying, because if you do something that you don't want, it comes with a cost. Usually root resorption. Okay? Usually you have a mess in your occlusion, you find something that is relatively well compensated, then you put a rectangular wire inside the slot and everything goes downhill. It goes down, it loses everything. So keep in your mind that you need to understand how to read the torque every time you put a rectangular wire inside the slot. And I'll prove it to you in a few slides, and I'll prove it to you in a few classes in this very course here, okay? In this course, we will understand everything about it. Let's see. So edgewise appliance, 0 degrees. We have 0 degrees of the slot related to the floor. Okay, we have 0 degrees of inclination of the base of the bracket related to the wall, this wall of the bracket. So this is an edgewise appliance. But when we use straight wire, the thinking about this kind of compensation is like this. We have some inclination of the base of the bracket or the slot itself. Sometimes you have the torque embedded in the slot, and sometimes you have a brand of brackets that has the inclination embedded in the base, okay, which is better for us. Yeah, we're not talking about this now, but we know it's better. So we can have 3 degrees, we can have 5 degrees, 7 degrees. So we're changing here the inclination of the base, and sometimes we have the extreme inclination of 18, 20 degrees, and it's very common. As I told you before, depending on what that bracket, that kind of prescription is meant for, we have less or more inclination of the base. We have more inclination to do this compensation, less or more, depending on what kind of prescription you are using. For me, all the prescriptions, they are very good and very bad. We just have to understand what is the relationship between and the interaction between the rectangular arch wire and the inclination that we find in the slot in that specific case. Class 2 is one thing, class 3 is another thing. It won't matter if you use a prescription for class 3 or for class 2 because you are using for the average. You're not using for your specific case of extreme class 3 that you are going to compensate or to decompensate, and everything has to be thought for that specific case, for that specific patient. So sometimes we tend to simplify things, thinking like this. I have a straight wire appliance and I don't need to understand what goes on with torque because it is something for me very difficult. So I'm going to put my rectangular arch wire and I rely on the prescription that specific company gave to me. Is that true for you? Not for me. Let's see how it goes here. For example, if we are using this kind of thinking in this situation, okay, if we have an average patient with an average inclination of the crown, it's okay. You will do everything right in like 67% of your cases. But you don't treat just average. You treat different patients. So this is what happens when we have a straight wire appliance. If we have a specific prescription And the inclination of our teeth, anterior teeth, for example, just to simplify our thinking here, just to simplify the concept here. If we have very different inclination from average, that thinking won't work for us. That concept won't work for us because it will generate a negative interaction between the inclination of your slot, even though you're using straight wire, and the torsion, the neutral torsion, or the torsion you have here to that real torque, okay? So you have to think of it. You have different prescriptions, and those different prescriptions may not apply to your patient, may not fit to that mouth you're treating, okay? So for now, guys, this is the most important thing. We stop here and we come back with the mistakes that we commit when we don't see this kind of interaction. So we have straight wire appliance, we use straight wire appliance, and even using straight wire appliance, we have to think advice. We have to understand the relationship, the interaction, and I'm going to show you. Hello, my friends. So we are back again with torque. Torque is our topic, and it's a very long topic because we have many things to talk about. We have many things to speak of this kind of orthodontic solution, which is torque in orthodontics. We love to do our torques. We love to do our torques because we know when we can do this, when we apply this kind of thinking, when we do this torsion of the arch wire, we can control every case we treat. We can control the inclination of anterior teeth, we can control the inclination of posterior teeth, and the intercruspation also. So this is something that's very important in our practice, and as I was talking to you, this is something that I do in my day-to-day practice all the time, okay? Torque, and we're speaking of the torque, the relative torque. We're talking about this, and this is very important even though we use straight wire devices, even though we use straight wire brackets, because you know that they are pre-adjusted. So sometimes we may think, I don't need that much because I have pre-adjusted brackets, pre-adjusted straight wire appliance, so I don't need it. I don't need to understand torque, so I will change the brackets, I will apply another prescription, I will choose the prescription that I want to use for that case. It's wrong because, as I told you before, the prescription is made for one average case, not for all the cases you treat. So the average case, okay, you will treat. Most of the cases actually you will treat on your practice, they are covered by these prescriptions, because they are the average, and we know that the average patient, they have this kind of malocclusion in class 1, in class 2, in class 3s, but there are some cases in which it won't work. This is why you have to be prepared to do the adjustment yourself with your bare hands, and not with your bare hands, your pliers, and of course your hands will help to do the kind of torque that we will use, but you will use pliers for that. And here I have an example what happens when I use straight wire appliance in an average situation, okay? So nothing of torsion, no torsion at all. In this case we have neutral torque, and given this neutral torque for this case here, what is going to happen? So if we have, for example, a prescription in which the upper central incisor is embedded in the prescription in the bracket, 7 degrees of inclination, and we have this wire. When we insert our neutral rectangular wire in this situation here, of course, as you can see, 0 degrees related to a horizontal reference, and 0 degrees of inclination of this transversal section of the arch wire, the rectangular arch wire. So, as I told you before, for now we're just simplifying the math. We're filling the whole slot with our rectangular wire, and we know that this is not the case. But in this case, just for for the sake of the understanding, we are going to fill the slot, the whole slot with our rectangular arch wire. So in this situation, when we have a good inclination of the upper incisor and we have a neutral torque and also a pre-adjusted bracket, the reading of the torque or the inclination is okay because the crown is well positioned. So being well positioned, the torque embedded inside the bracket, the inclination embedded inside the bracket, it will adjust with the inclination of the torsion, which is neutral, which is zero, so it's okay. But if it's not the case, but what happens in other situations other than when relative positive torque is equal to neutral torque, real torque. So we have neutral real torque, and in this situation, when we will assess the relative torque, we will see that in this case we have a passive torque because nothing will happen. There's no active interaction inside the slot. In this case, the interaction is completely passive. So this is the example I'm giving to you in a dream situation where everything is good, the perfect storm. So everything is good, and I'm putting inside the slot the rectangular arch wire, in which in this situation is completely passive. No interaction, no passive interaction, no active interaction, sorry, just a passive interaction. So in this case, it's completely fine for us. But we know that we have some situations, many situations actually, in which we don't have this beautiful inclination of the crown of central incisor, which is our example here. Sometimes we have a compensation of upper incisors, for example, in a class 3 patient. Sometimes we have a different inclination, or sometimes we have a huge overjet with this huge inclination of anterior teeth, and in this case also we'll have a different situation from that that we saw before. Okay, in this case, in this example here, just for the sake of understanding, we will do the math. For example, in this case we have 20 degrees of inclination of the crown, the long axis of the crown. Okay, here we have, and we have 20 degrees of inclination, which is the same thing that we have here, the inclination of the slot. In this case, in this specific case, we have a difference of 13 degrees because inside the slot, let me go it again, cover it again, inside the slot we have embedded 7 degrees as I showed you before. So we have here, let me pass just a little bit, yes, and now we have a different inclination, and in this example here we will think of 20 degrees of inclination of the crown. Okay, so if we have 20 degrees, just be doing the math, and we have 7 degrees of inclination embedded inside the slot, we have a difference of 13 degrees. So 13 degrees are, in this case, are not covered in this prescription here. So what's going to happen if I insert inside the slot this thick arch wire, rectangular arch wire, in this case filling the whole slot? In this case, this is the volume of the rectangular arch wire is equal to the volume of the slot in this example. What is going to happen in a situation like that? After this, in a few classes or in a few slides ahead, we'll see that we have this difference in the thickness, in the height, for example, of the slot and in the height of the transverse section of the rectangular wire. So we have to do some kind of a compensation in a compensatory thinking in this case, okay? So what is going to happen in this specific case? We have the slot which has an inclination of 13 degrees. Remember, it has embedded 7 degrees of inclination, but the crown is 20 degrees inclined buccally. So we have a 13 degrees difference, okay? 13 degree difference is it's a huge difference, a big difference, okay? So in this case, what is going to happen? the neutral torque will not be equal to a passive relative torque. Remember, neutral is the torque, the real torque, the torsion that we apply to the arch wire, so no torsion. In this case, because we have a difference between the inclination of the slot of the bracket and the inclination of the torsion of the arch wire, in this case 0. So we have 0 here, neutral is 0, and we have 13 here. What is going to happen? This crown is going to the inclination of the arch wire, because we know the arch wire is a thick arch wire, is a heavy arch wire, and it has this possibility of changing the position of the crown of the root, because it's going to apply a couple which is going to generate a moment that will rotate the tooth, the whole tooth, being the center of rotation, the exactly place of the center of resistance. Remember that we have in this situation just a couple. When we have a couple, the body that we are applying in which we are applying the couple will rotate, being the center of rotation, the center of resistance or mass of the body. In this case, I'm just simplifying the thinking here. I'm just simplifying the explanation here. In this case, I'm going to have an active relationship between the arch wire and the slot. So the interaction is an active interaction. In this case, as you can see, we'll have this movement of the crown palatally and movement of the root buccally. So especially when we have a proximity between the root, the apex of this root, and the cortical plate, the buccal cortical plate, this thick plate, we have the possibility of causing a root resorption, an important root resorption. So can you think about a situation like this? A clinical situation in which this is very dangerous? I can show you. This is a class 3 case, for example. When we have a class 3 case with a retruded maxilla, and there is this proximity, and if you see a CBCT, you will see that the proximity is very close. This is very close indeed, and we have the root apex here and the cortical plate right here. So when we do this kind of movement, when we do this movement caused by the torque, the relative torque, which sometimes we don't want to apply, this is the real case. Sometimes we really don't want that to happen, but we go without thinking and we just put our rectangular wire inside the slot, and the slot will apply the couple, and the couple will throw the root against this thick cortical plate, and you have the very big possibility of causing here this iatrogenic situation, this situation in which you will see a very big root resorption. Root resorption caused because you did this. So you have to be aware of that. This is something that you have to be concerned of, because it happens in our day-to-day practice. Don't let it happen with your cases. Don't let it happen in your patients, okay? So be aware of that. Don't do this. Think well, think again, and try to see where is going to where you are going to apply your force, and what force you want to apply. Actually, what kind of force do you want to apply? Do you want to apply this force to do this movement of the root against this cortical plate? I don't think so. So in this case, you have to think different. You don't use this kind of bracket. And you may think now, but Kleber, if I use a prescription that is meant for class 3, is it going to save my root in this case? Not always, because sometimes, as I told you before, you don't have the right amount of inclination embedded inside your bracket for that case, for example. So you don't have that precise inclination, and in this case you will have, again, an active relationship, an active interaction between the torsion of your arch wire and the inclination of your slot. But it tends to be slower, to be lower. It tends to be a lower torque, because you have not 7 degrees, but sometimes you have 12 degrees. So if you have 12 degrees of inclination embedded inside your bracket, you have this difference from 7, which is medium for class 1, and from 7 to 12. So we have this less torque generated by the same torsion of our arch wire. So in this case, it's good for you to use a class 3 prescription, but even when you do that, you have to be aware of this situation, because it can happen in this case. It can happen in extreme cases, okay? So be aware of that. This is the most important topic here. In the situation, neutral torque and relative torque are not equal, okay? If you have this inclination, different inclinations, the real torque and the relative torque may be very different. So the real torque neutral and the relative torque is going to be generated because this interaction between this zero and the inclination which is present inside the slot. The inclination of the slot, which sometimes is very different from the zero inclination of a neutral torque. And now you're thinking, so what is my exit? How will I fix this situation? How will I do something to avoid that to happen in my case? We're going to see in a few moments. See you guys. So, my friends, let's try to answer the pending question from the last class. What do we have to do in order to avoid those bad outcomes that we can have if we apply a non-wanted torque to our teeth? So in that case, and I'm going to show you a very, very interesting example of this. So we have here a situation that I saw in one of my courses. One of my students, he came to me with that situation. Doc, please, prof, come with me and see what's happening in my case. I'm trying to put the arch wire inside the slot, inside the bracket slot, and this is not coming in because it has a huge friction, and I'm not being able to put inside the slot. And that make me thrill. Wow! Let me take a picture of that. So in this case, if he had the opportunity, if he managed to do this insertion of the arch wire inside this slot, this is the picture, this is the case I'm showing you, this is the example I'm showing you now. If he managed to do that, what was going to happen to this patient? Because this patient didn't have enough bone buckled to the root. So the bone was very thin, and it was very, very close to the root was very close to this thick cortical buccal plate. So what was going to happen in this case? Probably fenestration of the buccal plate and root resorption. So thank God he didn't manage to do that, because it was a very, very bad mistake. So we don't want that to happen. What should we do to avoid that? What should we do to avoid this kind of bad outcome, this kind of side effect? It's not actually a side effect, because if you know that thing happened, I think it's not more like not knowing that this thing can happen. So in this case, it's not a side effect actually, because this is something that he didn't know. Even though he had that class, he didn't know that. So he was trying to insert this arch wire inside the slot. And then when I came to the patient to try to fix the situation, I told him, you have to be aware of that, my friend, because if you manage to do this, you would have a very bad outcome. And I explained him what was going to happen, and he understood, and he told me, I'm so sorry, Prof. He really told me before that, and I'm going to pay more attention the next time. So in this case here, as you can see, we don't have a neutral real torque anymore. So in this case here, we have this inclination of the crown and this inclination of the slot, which is the same of the crown, minus the inclination embedded inside the bracket. But let's think, for example, as a edgewise appliance. being the same inclination of the slot and the crown. So the buccal surface of the crown has some inclination, and the slot will be at the same inclination because it's 90 degrees against its base. So they don't have compensatory inclinations. As we know, edgewise brackets, they don't have compensatory inclinations. So in this case here, for example, just in order to simplify our exercise, our mental exercise, we're going to think of this case using an edgewise bracket, for example. Let's see. So now, as you can see, we have this inclination here, this white dot line. We have this inclination, which is the same of this red line here. So we have now this red line related, of course, to this blue one, because here we have a perpendicular wire, a perpendicular line related to the floor, related to a real horizontal reference. So here we have this line. This line is a horizontal reference, and here we have this perpendicular line related to this going through the center of our crown. So now we have this inclination here related to the vertical, which is the same inclination we have here related to the horizontal. So in this case, we have an inclination of the crown and an inclination of the slot, which are the same because we are using edgewise in this example here. And now we have the inclination of this transverse section of the rectangular arch wire. It's equal to the inclination of the slot. So being the slot inclined, for example, 20 degrees, we have here the inclination of the rectangular arch wire section, the transverse section, the same inclination here. So when it comes inside the slot, it won't apply a negative force because the inclination is the same. And here we have a relative passive torque. So in this case, even though we don't have the inclination, horizontal inclination of the slot, the bracket slot, we will have here a passive relative torque because we managed to do the inclination, the torsion in the arch wire equal to the inclination of the slot. So we managed to do that. So in this case, we won't have a negative interaction. We will have a passive interaction, which we call a relative passive torque. So this is important because sometimes we want to keep this inclination and we want to do we want to adapt the inclination of those teeth in another phase of our treatment. So sometimes you just want to incline a little bit and we do a very little torsion, and this little torsion makes a little, it generates a little couple, a very, very light couple, which will do the inclination that we want. And this is the benefit of orthodontics. We can see what is happening the next time patient come back to our office. So that's why I believe that I have to see my patient every month, because I have to do the compensatory movements. I have to understand what's going on. And when I see my patient every month, I have the opportunity to choose my path. I have the opportunity to change the way things are going or to keep it like it is. But sometimes we have to change. And for that, we have to see our patient. We have to have our mechanics in our hands. We don't let the mechanics to the fate. No, it's not good. We have to have it in our hands, and we have to be the managers of the mechanic. We have to be the kings of the mechanic. We have to do everything in order to adapt to each situation, to each specific situation. So this is what's going on here in a class 1 situation. In a class 1, just to compare now, in a class 1 situation with good inclinations, if we don't apply any torsion to our arch wire, it will be in most of the cases okay, because average inclination of incisors in a class 1 It's the same or almost the same, and we have display inside the slot between the bracket, the thickness of the bracket and the thickness of the thickness of our arch wire, and the space inside the bracket. Sometimes we don't apply couple, even though we don't have the same inclination, the couple is not applied because we have display inside the slot. But again, for the sake of our mental exercise here, we're thinking of an absolute situation. Putting a rectangle inside the slot, a rectangular arch wire inside the slot, we are going to generate some kind of movement if the inclinations are slightly different, okay? This is just for us to understand what's going to happen. And we are going to sophisticate our thinking in a few hours, in a few slides, in a few classes ahead, okay? So let's see it in different situations. Let's think, for example, a class 3 patient. What is going to happen when I have these compensatory movements that I achieved in this patient during my sequence of arch wire? I was changing my arch wire every time patient came back to my office, every month, and everything was going fine, smoothly fine, and everything was very, very good at this point. We are still using round wires here. And we used elastics, and everything was very, very good, and beautiful inclination, a beautiful occlusion, compensatory occlusion, of course. But now it's the time that I'm going to use my rectangular arch wire. What is going to happen now? If I don't think about this, if I don't know how to do the reading of the torque, the relative torque, if I don't know how to manage it, if I don't know how to assess the relative torque, if I'm not aware of these problems that I told you, what is going to happen in a case like this? For example, I'm inserting here a 1925 rectangular arch wire in this slot, which is 2230 slot. What is going to happen now? Because everything you did till now is completely okay. It's right, it's okay, it's what was meant to be done. But now you are using a different concept here. We're using the concept of generating a couple inside the slot, because you know that round wires don't generate couples. They don't have couples because they are round. They don't have those tips, and they can't generate couples. So in this case now, I have this class 3 patient, and I'm not using the pre-treatment for surgery. I'm not preparing this patient for surgery. I'm doing a compensatory treatment. I'm doing a camouflage. So in this situation, in this specific situation where we have these inclinations, what is going to happen if I'm not aware of this, if I don't pay enough attention and I just insert my rectangular arch wire inside a slot? What is going to happen in this situation to this teeth, to this upper and lower teeth? So in this case here, we have 22 degrees of inclination, and just doing the math again, we have many things to consider. Of course we have, but just for sake of understanding, let's see absolutely like things are here. 22 degrees of inclination, 7 degrees of inclination of the inclination is embedded in the bracket, the upper incisor bracket. So we have a difference of 15 degrees, a 15-degree difference between the inclination of the crown and the inclination embedded in the slot. So in this case, we have this difference. And we have to understand that this difference of inclination, it will apply a different relationship between the arch wire and the slot. Let's see. The lower incisors, they have a difference, also a difference. So we have minus 15 degrees of inclination of the crown, and we have embedded inside the bracket just minus 1 degree. So we have a minus 14-degree difference, okay? So this is important for us. This is important for us because when we do this, and if I don't apply a torsion to my arch wire, to my rectangular arch wire, this is going to happen to my patient. you may not have this amount of problem, but you will generate a problem. You will generate some kind of mistake to the treatment, okay, to your treatment. So we have here, we insert the rectangular arch wire inside the slot, which is 15 degrees inclined related to the horizontal plane. Remember, 15 because we have 22 degrees in this example, and we have 22 minus 7, we have 15 degrees of difference, okay? A 15 degree difference. So in this case, this difference will play a hole, very bad hole in our treatment. It will disturb the position of the incisors, which was very well compensated. The camouflage that you did till now was okay, and now you will do a very bad thing to your treatment. So in this case now, we are applying the same concept here with zero neutral torsion of the arch wire is going to be inserted inside your slot, and your slot is very inclined. So this is an active relationship. It's an active relative torque. And this torque, this active relative torque, will do something like this to your teeth. So to the upper arch and to the lower arch, different moments are generated. To the upper arch, we will have a negative crown torque, and in the lower arch, we will have a positive crown torque. So we had this before, and now we have something like this. Again, this is not what's going to happen in all your cases, because sometimes you have a bracket prescription which has 12 degrees, for example, and you have 20 degrees of inclination. So you have a rectangular arch wire inserted there, but this rectangular arch wire, it has, just going a little bit further here, forward here, we have this play between the size of the arch wire and the slot itself. So we have this play which allows the arch wire to do this without generating a couple, because it's a little bit loose inside the slot, okay? So, but in this case here, we're considering that this is an absolute relationship. So we don't have space generated between the arch wire and the slot. So we will have a very bad outcome because we are going to generate something like this. What do we have to do? What if we do a torsion in our arch wire, which resembles the inclination of the slots, the bracket slots and the anterior segment of our dental arch? So what if I do this? What if I generate this torsion? It will happen that you will generate a very good situation, because you will do the best thing for the case, being the inclination of the arch wire equal to the inclination of the slot, because you don't want to change that. At this moment, everything was okay, and now you don't want to change that relationship, that incisor relationship. We want to keep that. So I can't insert a rectangular arch wire inside the slot without looking at without evaluating in what position it will pass in posterior region, what position it will pass related to the level of the tubes and brackets and posterior region of our dental arch. So in this situation, to have a passive relationship, what matters here is the relative torque. To have a passive relative torque, we can't generate an active relationship. So be aware of that. Anytime you put something inside, a rectangular arch wire inside a slot. So this is what's going to happen. I will apply a torsion to my arch wire, a real torque, which is equal to the inclination of the slot. In this case, 15 degrees. Of course, again, I'm just thinking absolutely here, just thinking as a precise fit of the rectangular arch wire inside the slot. And we know that's not the case in most of our cases, okay? So this is what's going to happen. And this is how I do the torsion in the anterior segment of the arch wire. You will have the opportunity to stop here and go to our videos, to our tutorial videos showing how to do this. And you come back again, you go again, and you go forth, you go back, and you can do this all the time. This is a very good thing in our online courses. You can stop here, you can go back to the concepts that we applied here, you can go back with the practical exercise, and you exercise again. This is something very good for you. And you will have this, our ebook, in which is everything explained, and the videos related to each point of the ebook and each point of our class here, which I think is very good. I'm really, really very proud of this ebook and these videos, these tutorial videos. I tried my best to do that. I hope you enjoy. I hope you can do that all the time. Go back, practice, and come back here to the theoretical classes and go back to our practical classes. So do that. You will learn. Do that. So in this case, I have this torsion. I have the real torque, the positive real torque, which has the same sign and the same amount of torsion, of inclination, the same amount as the inclination of the slot. So when I put it inside the slot, this real positive torque inside the slot, real positive torque inside the slot, which has a positive inclination. This positive inclination is the same of the torsion I gave here. So as you can see, when I insert it here inside the slot, the posterior segment at the end of our arch wire here is going to pass at the same height, at the same level of our tubes, of our premolars and canines brackets. So it's a passive relationship, and this slot here, it won't generate a couple here because the torsion is the same, the inclination of the torsion is the same of the inclination as the inclination of the slot. Okay? So hope you understood everything here. In this case, we have a real buckle, or meaning positive torque, and we have a relative passive torque. Okay? Very important. Every time you do this in your patient, you have to do you have to apply this kind of concept. If you don't want to change the inclination, if you don't want to change the position at that point, you have to do this reading of the position. You have to assess the position of the tip of our rectangular arch wire. Rectangular, it's a strong word, rectangular arch wire inside our slot. You do this inside of the anterior slots, the anterior teeth, and you see here in which position it will pass. If you don't want to have any interaction, if you don't want to have an active interaction because you have passive interaction, if you don't want to have an active interaction here, if you don't want to generate a couple and of course an inclination because of that, you need to do this passive relative torque. So to see that, the height of the tip of our arch wire has to be at the level, at the same height of the tube of the first molar and second molars. Okay? This is the most important thing till now. Guys, so this is for me something very important, and anytime I have the opportunity to say to my students, pay enough attention for that, because we can do harm for our patients, we can do something bad to our cases. I always call their attention about this. Pay attention, pay very much attention to that, because if you mistake this part here, you may cause a very bad outcome. Okay? Look at the situation. After that, student of mine called me we did the torque and we inserted here, and it was completely passive now. Okay, this is what I wanted. Okay, so guys, see you in our next class. Hello, we're back. More information about torque. We will still talk about torque, but now we will change a little bit our concepts of this kind of relationship of the arch wire and the slot and the bracket slot, because we have some variations in torque that can be attributed to the design, the bracket design. You can have just more or less thickness, you can have more height, more deep depth in your bracket slot dimension. You can have a wire size playing this role in the control of the inclination, the clearance or play, which I told you before, between the wire and the slot, the wire stiffness, because sometimes we apply, even using rectangular wires, sometimes we apply a torque, and this torque won't be expressed in that teeth or that tooth, specific tooth, because sometimes the stiffness of the wire is not enough to do that, or it takes a long time for you to get that. The ligature mode, we'll see that the bracket deformation, so sometimes you use a bracket of not that high quality and we have more or less deformation. The torsion and the kind of bracket you're using, of course, because if you use plastic brackets, they won't work. They will always have this deformation. The torsion magnitude of your rectangular wire, the bracket bonding errors, they play a very important role, as I'm going to show you a few classes ahead. The irregularities in the morphology of tooth crown, sometimes you have many difference of the tooth crown and the bracket which was thought to be bonded in that position, and that crown has a different inclination, so sometimes we have some differences in torque expression with this kind of very big variations in tooth shape, for example. So we have the torque, we have the real torque, and we have the relative torque. So as you know, the most important thing for us here is the relative torque, because it is at the end of the day what's going to move your teeth. So you have to understand this relationship, as we told till now, just many things about that, and now we're moving on for a clinical situation. So we have this variations in our topics that can express less or more the torque that we are applying. And let's see first of all this relationship between your bracket, your slot, the dimensions of your slot, and the dimensions of your arch wire, of your rectangular arch wire. So in this case we have a 030 or 022 bracket slot and a 017 or a 025 the dimensions of the arch wire, of the rectangular arch wire. So what's going to happen if I use a different combination? For example, a 18 slot with a 17 or a 16, 25 arch wire. We will have difference, of course. But there's something that I would like to say to you. It's not something that I can address some kind of article, scientific article about, because this is, you will have the opportunity to see all the articles that we saw in these classes. I will do the reference for you at the end of our ebook. You'll see that. But there is something that's very clinical for me, which is I can manage to adapt the inclination of teeth when I use a stiffer arch wire. I really like the combination between the 1925 with a 2230 bracket slot, because I know that I can apply more force to the torque. I can make the torque more effective, if I can say that. I can make the torque more clear for me. I see the torque happening. I did use this combination before, the 18 bracket with the 1625 arch wire, but I didn't like that. I felt that I didn't have that in my hand. I didn't have the control that I had when I used 22, 30 brackets and 19, 25 arch wires, rectangular arch wires. So I used just that for that. To control the torque, for example, during the retraction, when I'm doing the retraction of anterior teeth, when I'm moving anterior teeth backwards in class 2 cases, for example, I always use a 1925 rectangular arch wire in a 2230 bracket. Always. And you may be thinking now, but you have the posterior part, if you use as I use, usually the sliding mechanics will have a greater friction in the posterior segment. Yes, it's true, but you can trim that arch wire, you can wear that arch wire, and you can polish it after that. So you have the two things that are very good. First, in the anterior segment, we need to have very high control during retraction because we have 19, 25, and in the posterior region we have a wire which is now less thick. The wire now is trimmed, the wire now is worn. So in this case we have less friction in the posterior segment and more control in the anterior segment. I know that there are mechanics that use that concept using different dimensions of the bracket in the anterior and the posterior part of the dental arch. But I prefer to use like this. I prefer to think like this because I use and I like to use it the 2230 bracket. Okay, so I have the possibility of applying these two concepts here, and I use always the 22, as I'm telling you now, the 2230 bracket, okay? But what if I use, for example, a 1725 rectangular arch wire to do the retraction, thinking of decreasing the amount of, in the posterior region, the amount of friction. What if I use this? Is it going to work for me? It depends. It depends because you can use since the beginning the concept of relative torque using a real torque in order to counteract the tendency of losing inclination. Because if you don't do that, for example, we have a perfect position, a perfect inclination of anterior teeth, of incisors, and I'm doing the retraction because it's a class 2 patient, but I already like the inclination. I think that inclination is okay for me. What if I apply this concept here? What if I try to do this? What's going to happen? This is going to happen. First of all, you're losing a lot of inclination. You're losing a lot of your inclination. So this kind of retraction using this slot, 2230 slot, with a 1725 rectangular arch wire. So what is going to happen? You will lose some inclination. Yes, you will, because you have this play between the arch wire dimension, and the slot dimension. So it's not that tight. So in this case, you will lose some inclination until you have established the couple, in this case here, 2 points of couple, and we have now a more reliable retraction, a more controlled retraction, okay? Because now we have this couple generated here, which will do a moment, it will apply a moment, it's contrary, a moment in counteracting the tendency of inclination this way, because here, applying the force this way, distal force here, we have the distalization of these crowns, and we have also the inclination of those crowns, because we have here this tendency of losing inclination. And when it establishes the couple in the inside the slot, now we have more control of this retraction, because we are now generating a moment here that will try to counteract the tendency of losing inclination. Is it going to be enough? Is it going to be enough to control the inclination that I already lost? Or am I going to have to apply more torque for that? This is the magic of orthodontics. We can see that, and if we think we're losing the inclination, and we feel that too soon, I'm going to block my retraction because anterior teeth will contact anterior lower teeth. So if it's happening, I have the chance to stop doing the retraction now because I'm seeing the case, I'm seeing and I'm controlling the case, and I'm losing inclination. I stop to do the retraction, and I stop now and do the correction of the inclination. This is important for you to understand, because if you go further, if you go again, doing the force again, and again, what is going to happen is that you are going to lose more and more inclination. And soon enough, you do the blocking of your treatment. You will have your treatment blocked because it will contact anterior teeth to anterior lower teeth, anterior upper teeth, anterior, of course, incisors will touch lower incisors. So in this case, you may not have already corrected the class 1 situation of the canine, and you have already touched the anterior segments. So this is how to not to miss this point in orthodontics. Always think about inclination during the retraction. Always try to control the inclination, because if you do that, you will have a direct treatment, a more smooth treatment without the need of stopping all the time in order to correct something that your mechanics has generated to you now. So be aware of that. So anytime you have a patient to have to retract, you have to pay much attention to that, because it's very common and it's very fast. You do the retraction, and fast you will see soon that you touch anterior teeth, and you will block your treatment. So that's something that we have to avoid. We have to try to avoid, at least. When I use 1725 rectangular arch wires for trying to do this situation here of retraction, I feel that I don't have that much control. Even though I'm applying much force, I'm applying too much force, that I don't have this control, because this is not a stiff arch wire. It's not as stiff as the 1925. Of course it's not. We know that the stiffness of the arch wire is related to the height of this dimension, the height of your rectangular arch wire, directly related to that. So when we do this, when we increase the height, for example, 17, 18, 19, 25. 25 is the same, but the height is different. I prefer to use the 19, 25, because doing this, I feel I have much more control during the retraction, which is very important, because this is what at the end of the treatment will do the best for your patient, will make your patient have a beautiful smile. Because negative inclination, anterior segment, very bad. We need to have this correct inclination in order to have a beautiful display of our teeth during the smile, and beautiful display during the talking. And this is what we do when we do the control of our movement, when we control our movement during retraction. So this is important for us, the clearance or play between the wire and the slot. So if you can't afford to have at least some kind of losing of inclination, you need to do some torsion before you start doing the retraction, or at the same time you're doing the retraction. Because if you do not do that, you will lose some inclination. It's fact. You won't fly. You won't flee from that. You will have this inclination, this during the retraction being, or every time patient come back, you see that you lost that inclination, and lost again and again and again. Okay, so be aware of that, and try to control that. So this is my advice for you. Use a 19 instead of 17, and 1925. So it's wrong here. It's 19 in this case It's a 1925 comparing to previous. So this is what I'm trying to tell you. Try to use a thicker arch wire. This is a 1925. It's around here. I'm sorry, but you can see that it's different. You can see that you have more. You can occupy more that space, okay, inside the slot. Now you have a little bit more control. Even though you don't use any torsion, you will lose less inclination, and since it applies the couple here, you will have more control during the retraction. So as you can see, now you can have at least 7 to 10 degrees in this combination here of losing inclination, of play inside the slot, because now we have a thicker arch wire. Okay? So guys, this is what I wanted to show you in this part of our class. The relationship between the arch wire and the slot dimensions, okay? Hello my friends, we're back with torque, torque and torque again. And now we're going to address more things that are more variations that can apply some role in our treatment related to torque and related to things that concern the torque the moment that you use the torque. For example, now we're going to say something about the ligature mode. All cases that I treat in my office, all cases I treat with torque, I understand the difference between the torsion that I'm applying and the bracket slot, what kind of bracket slot I'm using, and I try to assess every time my patient come back to the office the torque, the possibility of keeping the torque or increasing the torque or lowering the torque. I always be aware of that, because sometimes we have a thick wall of our bracket that won't have deformation, but sometimes we have, and sometimes I'm using a different bracket for that. For example, you know, I'm not that fan of bracket that I use just one kind of bracket, just one kind of brand. No, I do not do that. Always I try to see in different situations. I try to apply different brackets for me to understand how things are going. So I use lots of brackets in my office. I don't have any bracket that I love. I love to do biomechanics. So being that said, I'm able to show to you that we have some differences between brackets. For example, I'm using here 2 brackets that are different in their shapes, which are the conventional bracket. This brand here is Brazilian. It's a Brazilian brand. It's a Brazilian company that produces this bracket, and both brackets are produced here. But you may have the same difference in your country, the same differences between different companies. So in this case, the ligature mode, when you compare, for example, doing the retraction or applying a torque, a real torque, in order to obtain some relative torque that we want, sometimes we may not have the result that we want to have because of the shape of the bracket we are using. And we have some differences. In this case, for example, of course, we don't have enough time to tackle all the nuances here, all the differences here, but I'm going to show you why you have to be aware of the situation, why you have to pay attention in the bracket you're using. In this case, for example, I use a self-ligating bracket, an interactive self-ligating bracket. Here in Brazil, this brand is called Morelli, but you can use what you want, any bracket that you want to use. So in this situation, in this specific situation, we have this shape of the bracket that doesn't favor me to control the torque. Why not? I'm gonna show to you how it is in this case here. You know that our slot of the bracket that we use, it has embedded the inclination, it has embedded everything that we want, the in and out, and angulation also. But look at this bracket here. what is the size that we have in this wall and what is the size that we have in this wall. Are they the same? As you can see, they are not, because this here, the shape of the bracket in this wall is sacrificed to do the closure of the bracket with this little thing here. So this cap, this night tie cap here, it has to slide in this position, and for that, for it to lock, we have this difference in our walls, the upper and the lower walls. So what is the hole that it plays in our retraction, in our bracket, in our torsion of our arch wire? The expression of the relative torque. The expression of the relative torque is directly associated to the force that we apply. And the force that we apply in the couple, it is directly associated with the distance between those two forces of the couple. So if I have this short distance, I have, even though I have the same torsion, I will have less force than when I have more distant points separating those 2 points of contact, okay? So I have this long and short distances and brackets, not that long, of course, because it is a bracket, but we have these differences, and it plays a hole here. Look at the lower arch wire. I think in this case, it's much more shorter, this wall, than this one. And this is very difficult to control when we want to apply this torsion, this real torque, in order to obtain a relative torque which is capable of counteracting the tendency of losing inclination. You know, guys, because this is I always say, guys, I'm just sorry. I was recording here and I remember that I always say, hi guys, because we say guys for men and women. This is something that we use very commonly, and I'm sorry. My friends, I'm sorry. Guys, it is related to both women and men, okay? So, in this case here, I really have doubts that I can control because I know that I use that very much. I use self-ligating brackets. I use many brands of self-ligating brackets because many companies, they give me those brackets for me to test because I'm a professor. I give classes and they want me to test for them. The concept is good, but the shape is bad. Most of the cases, even in passive self-ligating brackets, we have problems because the closure of the system to lock the system, this little window that they put here, and passive or active self-ligating brackets, it plays a hole in losing control of our inclination, of our torsion. In this case here, the walls play a very important role in decreasing our control in this kind of using rectangular arch wires. For example, here, I'm using a 1925 rectangular arch wire, and now I'm going to insert it in both brackets, in a self-ligating bracket, in an interactive self-ligating bracket, and this is the shape the company itself showed me. So they have these differences in the two walls here, the upper and the lower wall of our self-ligating bracket, and here we have our conventional bracket with its distances, with its dimensions that we already know, 22 for 30. So we now have to apply that concept of doing the torsion. And before this class, I told you about the play. I showed you that there's a play between the bracket slot, the bracket dimension, the slot dimensions, and the rectangular arch wire dimension. So both brackets, they will behave differently in this situation because of the dimensions of the wall. Let me show you it now. So when I do here in this bracket, when I do this inclination, and we do the same inclination here in the conventional bracket, as you can see, the point of contact here, the points of contact here are different from the points of contact in the conventional bracket. Why is that? Because the dimensions of the walls are different. So being different, as you can see here, we have a shorter distance between those 2 points that represent the couple. The couple here, it's now, in this case here, is the force, one of the forces is here and the other one is here. So this is the distance, and in this case we have the force applied in this wall and in the other wall. If we compare, of course, having taken into consideration the small size of the bracket, we have a high distance here and a long distance here, and a short distance here between the two forces of the couple, as you can see in this image here. So we know the play here, but we don't know the play here. So sometimes we have to apply a much bigger torsion, real torque, when we are trying to control the inclination, when we are trying to apply a relative torque to a interactive self-ligating bracket when compared to a conventional bracket. I'm just now explaining about this kind of bracket. Kleber, is there a difference between brackets and self-ligating? Of course there are differences. Many differences. One of those differences is a wall that you can put in the middle of the body of the bracket, the self-ligating bracket, just in order to establish this couple in a more favorable position. So yes, I've seen some brackets that have this kind of shape, which is good for us, which is very good for us, okay? But in this precise situation, you have to be aware of that. But how can I do that clinically, Kleber? I can do that just seeing the position. Same thing applied to the conventional bracket. I do my torque, I do my torsion, I do my real torque, and I'm going to see, I'm going to assess, I'm going to evaluate the position that the end of the tip of the wire will pass in relation to the tubes and the brackets. So in this case, you see that you have to apply much more torsion to the arch wire when you insert in this kind of bracket than you have to apply when you use conventional brackets. But it's something just to remind you that you have to look for the result that you have, that you will achieve when you do the torsion. The result meaning the position that the tip of the arch wire, the end of the arch wire will pass in relation to the tubes. Always. This is simple. So you use any bracket you want, you have to do the same thing. If you use self-ligating, passive self-ligating, interactive self-ligating, conventional brackets, ceramic brackets, it's the same thing. Of course, you have to keep in mind, of course, you need to keep in mind that different materials that brackets are made of, they play different roles. For example, the friction between a stainless steel arch wire and a ceramic bracket is much bigger than the same thing with a metallic bracket. Okay, so it's something that's important because we usually use sliding mechanics for retraction of anterior teeth. I use different ways of doing the retraction as we will see during our course, but it's common that orthodontists use use sliding mechanics for that. So we have many things to consider, including the relationship between materials. But in this case, in this specific case, what I'm calling your attention for is the interaction inside the slot, which is different when you use self-ligating bracket, an interactive self-ligating bracket with this shape, this specific shape here, comparing to a conventional metallic bracket, for example, which is now we are comparing here. Okay, so just for you to understand the importance of seeing always the position after doing the torque, after applying the concept of the torque, you have to assess the position of the tip of your arch wire in relation to a horizontal component, which is the tube height, the posterior bracket's height, the posterior slot's height. Okay, so if you want passive, if you want passivity, if you want to be passive, you want this. If you want to be active or active, both positive or negative, you want different inclinations of posterior tip of the arch wire, okay? I hope everything is clear for you till now. Anytime you want, you can contact me. You know that, and anytime you want, you can go back to our ebook. You can consult the ebook, you can see the ebook, you can see the videos, and this is just for you to understand the importance of this point, which I'm always talking about, okay? Hello guys, so we're back with this important information, which is torque in orthodontics, but now torque related to another situation. When I do the retraction of anterior teeth for example, correcting a class 2 case, or if you want to correct a class 3 case in the lower arch doing the same thing. The most important thing here is not the arch in which we are going to apply this kind of thinking. Most important thing here is to understand that we have two things that are very important in orthodontics. The force that we are doing the retraction and the moment generated by this force, and you need to generate another moment to counteract that moment of the retraction, because we are applying in this situation here. I'm giving the example here in which I'm doing the retraction of anterior teeth with a continuous arch wire mechanics, meaning what you do in your daily practice, what I do in my daily practice, and the most part of orthodontists do in the world, which is the retraction using the sliding mechanics. So the most important thing here is to try to do this ratio between the relationship between the retraction, the moment of the retraction, and the moment of the couple, the moment that we are going to generate inside the slot. Inside the slot, meaning we are going to deal with this couple. You need to remind that from our previous classes, especially the basics in orthodontics, that we use this kind of couple to counteract the moment of the retraction. So now we're going to deal with this. But before that, we need to understand that retraction is mostly related to the face. So when you're doing the retraction in your patient, you need to understand that you have a side effect mainly in the upper lip going backwards. So if you don't control the retraction of anterior teeth during retraction with the correct inclination of anterior teeth, you are going to lose more and more inclination, and this is very, very bad. In most of the cases is very, very bad for the lip and for the face itself. So the most important thing here is face. Extraction of permanent teeth is one of the situations that we apply the retraction in orthodontics. So the retraction of the anterior teeth may be necessary in some situations. Extraction, very common. Space closure after distalization. We may use the distalization of upper arch and then upper molars, and then do the distalization of anterior teeth. This is one way of correcting the overjet. Space closure in cases of generalized anterior diastemas. So we are doing the retraction. There are some situations in which we don't even need to do extraction or distalization, just during the retraction of anterior teeth that are flared and with diastema between those anterior teeth. Class 2 correction without extractions, meaning I'm going to do the retraction of the whole upper arch at one stage, just one retraction in one piece. Meaning I'm doing the retraction without the need of distalization, without the need of doing extraction or anything like that. I just retract anterior teeth with this upper arch distalization at the same time, okay? So let's see what happens here. Mechanics for retraction of upper teeth, it has like sliding mechanics. We can use sliding mechanics with extraction. For example, we have to slide that arch wire inside those slots, those posterior teeth slots. Class 2 elastics is possible to use this kind of mechanics to do the retraction. Retraction of the entire arch with TADs, mainly with TADs, or using, for example, mini plates or IZCs or everything like that. So we need to understand that this situation is very important to use TADs, absolute anchorage, for doing the retraction. Otherwise, you're not going to have perfect anchorage to do the anterior arch, the whole arch retraction at the same time. Loops, yes, we're going to have some example of going to retract using loops for that, not sliding mechanics. But most important thing again is the face. The face is what we have to put in the first place when we need to analyze what is the retraction that I need to do in that situation. We need to do occlusal analysis, of course, for sure. This is important because class 2, we need to do the correction in a half step class 2, 1/4 of class 2, or full step class 2. So we have some situations that we need to understand because that is important for establishing what is the best mechanics for that. For example, if I have one full step class 2 to be treated, I'm probably not using elastics for that because it's too much for us to do the retraction using elastic in a full step class 2 because we have to correct 8 millimeters. And 8 millimeters because we are dealing with the size of a premolar. The error here is 1 premolar, so we have 8 or 7 millimeters to be retracted or to be considered to do the correction, because not in all cases I'm going to do the retraction. Sometimes I'm going to deal with the mesialization of the lower arch for that. So everything needs to be considered because we don't want to ruin the face when we do the retraction of anterior teeth to correct a class 2. So let's move on. Face in first place. Face, most important thing for us to consider. Let's move on. Let's deal with our dear Maria here to understand her face. We have here, for example, a class 2 because of the distalization of the lower jaw. We have an upper jaw, and the maxillary arch is well positioned. We have a good nasolabial angle. We have good protrusion of anterior of the lower upper lip. And we have this receded chin, meaning we have this class 2 because the mandible is retropositioned. The mandible is forward in relation to the upper arch. So we need to do the distalization of lower arch for that. We wouldn't like to have this in this kind of situation, but sometimes we need to. For example, if you had here just one quarter of a class 2, just 2.5 millimeters of a class 2 to be correct, we are not going to ruin the face during the retraction of 2.5 millimeters, especially if we can go forward a little bit with the lower arch. Meaning, if I want to do the correction knowing that the mandible is the problem, doing the correction of the class 2 in the maxilla, I need to consider that sometimes the most important thing for me is not to do very much this retraction. I can split the correction between maxilla and mandible going forward with the lower arch, if we have space for that. If we have enough space in the symphysis for doing the mesialization of anterior lower teeth, okay? If we have it, we are dealing with something that is good because we know the problem is not the mandible, it's the maxilla, but we are doing the retraction because this patient, I can go forward with the mandible because, or I don't believe in growing mandibles, or I don't have enough room enough housing of anterior teeth to do this kind of inclination of anterior teeth, or I reached the limit of inclination of anterior teeth and I don't want to do that further. So sometimes we have to retract. Sometimes we have to retract upper arch, even though we know the problem is not located in the upper arch. But we know that for that correction, the only way I have to correct this is doing the retraction of the upper arch. In this case, what I have to consider is doing the retraction of the upper arch, and am I going to jeopardize the beauty of the face? Am I going to distalize so much upper arch that the lip is going along with the upper teeth and going to ruin the lip posture, the position of the lip, this beautiful protrusion of upper lip? So if yes is the answer for this question, sometimes I just don't do the treatment of camouflage. I have to go to surgery for that. And you can say, but my patient won't go with surgery for that because here in my country, they don't do very much this kind of surgery, or my patients here that I treat, they can't afford for the surgery, or some things like that. But if this is the case, I would advise you, avoid doing that, because when you do this, you're signing up your name in that face, for good and for bad. So if you're doing this kind of retraction and this is going to retrude upper lip that much, that's going to be felt by this patient and their family with something that is very bad for the face, I wouldn't do that. I wouldn't do that at all, okay? This is very important for me. Not doing a treatment to ruin the face of my patient, because at the end of the day, what I'm selling here is beauty. It's a beautiful smile and it's a beautiful face. So I don't want to go backwards with that lip that much that may jeopardize the beauty of the face, okay? Moving on, we can see here that the upper lip is well positioned. If we could hide the lower part of her face and just look at the upper part of the upper lip from here up, we're going to see that upper is good, but lower is bad. If I'm doing the retraction in this situation, I may have a very bad side effect in this case, okay? Let me give this example for you. It's a good example of a class 2 elastic that can have a good side effect for the occlusion, but a bad side effect for the face. For example, here, I'm doing the correction of the occlusion, but in this case, her face may be worsened. So if you understand, and I know that you understand, this is something that we've seen before. We've seen that the same video here in our previous session in the basics of biomechanics, so showing the side effect of the elastic. So we know that the side effect is very bad for the face and good for the occlusion. What do you think is best for your patient? The outcome for the occlusion or outcome for the face? I really doubt that this patient could choose this kind of treatment if she were advised that this could be a very bad side effect for the face. So keeping that in mind, be aware of this. Doing the retraction of upper lip, especially when you're increasing the lower anterior face height, it may be very bad for patient's face, okay? So when we compare before and after, what happened to Maria's face after correcting the occlusion for a full step class 2 for a class 1, going from a full step class 2 for a class 1 occlusion, I know that you can see this is good for the occlusion and very bad for the face. Meaning I did something good for the occlusion, but not that good for the face. As you can see here, the lower anterior face height is increased, and we have now the lower lip in a more protruded position comparing to the upper lip, which is very, very bad. So first of all, face comes first, always. And with that said, we can go on with the mechanics itself. But I wanted you to understand that my course is not about biomechanics, just biomechanics. Biomechanics is part of this course. I want to warn you always that we are dealing with a face, with occlusion, with emotions, with a smile and everything. So if I'm doing something in that regard for correcting the malocclusion, I need to understand the side effects and everything related to the face and many, many other things. And TMJ and everything must be considered before we go on with the biomechanics, because biomechanics is a slave of the diagnosis, okay? So it comes second, and in the first place, you have to be very accurate about face and diagnosis, okay? So see you in the next class. We're going to move on to this part of very intriguing part, which is the biomechanics itself of the retraction. Hello guys, we're back with this important information, which is retraction of anterior teeth. Now we're going to deal with the biomechanics of it, okay? So first of all, we need to understand that the face comes first always. But now that we know that, we need to understand how to do the retraction itself. One of the situations that we understand that we can do is for doing the retraction, during the retraction of upper teeth. We do that losing anchorage or not losing anchorage. So what can we apply in this kind of thinking when we want to choose what kind of retraction we are doing? Here I'm going to show you some situations that are very common in orthodontics when it comes to extraction. I want to do the retraction of anterior teeth to correct a class 2 situation, and doing this correction I can have more or less retraction of upper teeth. For example, one thing that I always say for my students, don't do extraction of lower teeth. This is a very important thing for you to keep in mind. Don't do extraction of lower teeth in a class 2 situation when the class 2 is related to a mandibular deficiency. What I mean here is when you do the retraction of lower teeth, when you do the retraction in that situation, for example, the first bicusps, you do the extraction and you do the retraction of lower. When you do that, the canine goes forward. Each millimeter that this lower canine goes forward, it's mandatory for you to go with the upper canine 1 millimeter forward also, because you have to correct the class 2. So why do you want to do the correction of the lower canine going forward? You really don't want that. So if you can avoid that, please do that, because this is very important for the face. You need to understand that we don't want to go forward with the lower canine, meaning in a class 2 that is related to deficiency of the mandible, I don't want to go forward with lower arch, with anterior segment of lower arch. So if I can do something for that, avoiding this, I will do. Sometimes we do need to do the extraction because we have a huge crowding in the anterior segment of the lower arch. But if we don't, we will always avoid that. And we have other options also. For example, if I want to do this correction of the to release that crowding, I may opt for doing the extraction of one incisor, for example. So in order to avoid doing the retraction of the lower canine, I can opt to doing the extraction of the lower incisor. This is important. Let me show it to you here in this example. So I'm doing the retraction and I'm using for that a solid, a very, very rigid anchorage in the lower arch, in the upper arch. I'm doing the upper arch, the anchorage with using TADs, and I'm doing the retraction of the whole upper arch, anterior segment of the upper arch. Look at the face. Look at after the other face, what happened to the lower, to the nasolabial angle. What happened here is an opening of the nasolabial angle, meaning I'm going backwards with my lip, upper lip, which is very bad, especially nowadays when people, especially women, they want to have those full lips, and I'm retracting, losing that protrusive lip, which is very, very common that people seek for today, nowadays, okay? So retraction is very, very close relation, has this very close, very intimate relation with the upper lip position, with the nasolabial angle. So sometimes we see in some articles that when we have the retraction of 1 millimeter of the upper incisors, we have opening the nasolabial angle in approximately 2 degrees. So meaning if I'm doing the retraction of the upper incisors 6 millimeters, I have to multiply that for 2. So I have 12 degrees of opening of the nasolabial angle, which is very bad sometimes. Most of the time, especially when the maxilla is well positioned on just mandible is retroclined, when we have this receded chin and a deficiency in the lower bone, mandible. So sometimes we have to do the retraction because we can't do the correction without doing the upper lip teeth retraction. But we can avoid doing that much. So meaning If you have a deficiency in the mandible, which is more common than protrusive maxilla, we know that approximately 60%, and in my office I think it's much more than that, but approximately 60% of the cases of class 2 are related with deficiency in the mandible, not a protrusive maxilla. Actually, protrusive maxilla is approximately 10 to 15% of the cases. Okay? It comprises almost nothing, 10%, 15% maximum. So when I have to do the correction of the class 2 using this kind of mechanics of retraction in upper lip, and we know that the mandible is the problem, so we are having some situation that's very difficult for us to choose, because we know that the best thing for that patient would be advancement of the mandible. But I know also that's not that common that patients choose for surgery. So we need to do the retraction. Yes, we do. But if we see that this retraction, if we foresee that this retraction is going to have a very bad side effect for the upper lip and for the face, I can just avoid doing the treatment and say to my patient, I'm sorry, this is something that I'm not doing for you because I know that doing that, I may do something very bad for your face. I may worsen your upper lip position, meaning you have something beautiful, which is the upper lip, and the lower arch is the problem. When I go in the upper lip, going forward with it, I may have a very bad outcome for the face. So I won't go this way. I won't go this path. So I can avoid it. I just say, no, I'm not going to do this treatment. And it's bad. It's very good for us. Bad is doing the opposite. Bad is doing this kind of choice, knowing that this choice is going to do a very, very bad outcome for the face. So when I do the retraction of the upper lip, when I do the retraction of the upper arch, I'm going to have different position of the lip and this side effect. I'm not saying that it's always bad, as I told you before. Sometimes it's good, but in most of the cases of class 2, I have to avoid this huge retraction of the upper incisors. So sometimes we see in social media, Instagram, Facebook, and everything, we see those beautiful cases treated with the retraction and having this very beautiful occlusion. But sometimes I ask myself, what about the face? And sometimes you don't see the face. Most of the time, actually, you don't see the face, we don't see the measurements, we don't see the pre and post regarding to the profile. We don't see the profile pre and post treatment, we just see the occlusion. Because what is the trend is the TED, not the face. Meaning, this is very bad. We need to understand everything. The complexity of the face and the occlusion and the TMJ all together. Not just the occlusion. The occlusion is just part of the problem. So let's see again. Let's go with this kind of design of treatment, going with TED in the upper arch. In the lower arch, we're doing the reciprocal distalization, meaning I'm going forward with the lower posterior, and I'm going backwards with the lower anterior. What's going to happen in this kind of design here? Yes, I'm going to correct the class 2 via the mesialization of posterior, but I'm also dealing with the retraction of anterior. So extraction, retraction of anterior, upper lip is going forward because I'm going to do the retraction in this design here with TEDs, meaning I'm not losing anchorage in this design. And this is what's going to happen when we compare this shaded image here with the retracted position of the upper incisors, and this is what is going to happen in this kind of situation. Correction of the occlusion, of course. This is part of the treatment, and this is what we plan for. But is it good for the face? I really doubt that. In most of the cases, this is not good. So this option here may be good for some situations when we have this protrusive maxilla. Remember, 10-15% of the cases, but most of the cases it's not good this kind of choice. Okay, so let's try another design, another option. Now I'm doing the retraction of upper teeth using both the retraction in the upper using this coil spring, this compressed coil spring, which is pulled to do the retraction. And in this case, we're going to have this anchorage loss, which sometimes is very good because we avoid doing the whole retraction of anterior teeth. So hope you're following me on this. Doing the retraction is very good because we're going to correct the class 2 canines, but I don't want to go the whole way. I don't want to go the whole path doing the retraction. I want to lose anchorage for that because I know that the mandible, in the majority of the cases, the mandible is the one to be blamed for the class 2. Okay, so in this case, I'm using the class 2 elastics for having the anchorage loss in the lower arch. But remember, I'm just dealing here with biomechanics. Remember that class 2 elastics sometimes is very bad for the face because it's going to extrude posterior and rotate the mandible down and backwards, meaning a clockwise rotation of the mandible. So sometimes you don't want that to happen. Remember that. We dealt with that before, especially in the previous sessions when we dealt with the basic biomechanics, so explaining everything for you, and you understand that this is the side effect of the elastic. The extrusion is the side effect, and in most of the cases, the best or the bad side effect, So just for you to understand. But when we can do this, when we are allowed to do this elastic in a class 2 case, meaning horizontal pattern, so yes, we can deal with this, break a hypodivergent pattern, yes, we can do this. So in this situation, we want to have this outcome, meaning, yes, I'm doing the retraction of lower anterior, but I'm doing less retraction of upper anterior because most part of the closure of the space was from posterior to anterior, or half. Yes, but I'm comparing to the previous design in which no movement of posterior happened and I have just the retraction of anterior teeth. So now I'm splitting the correction. Now I have the upper going forward, but the lower is going, the upper going backwards, the anterior upper here going backwards, but most of the correction happened in this situation of a class 2 with the posterior segment of the lower arch going forward. Good. Sometimes it's good. But why do I need to do the extraction of first bicusp if I have just some mild crowding on anterior segment, in anterior lower segment? Why do I need to do extraction of first bicusp? If I really need to do the extraction, why not choosing the second bicusp? Because in this design here, I'm going to have more anchorage loss than retraction of anterior segment in the lower arch. And now what I'm here using the same design, losing anchorage in upper arch during the retraction, yes, to correct the class 2, but part of the correction is the mesialization, okay, of the lower arch. In this case, I want to maximize the mesialization because I chose the extraction of the second bicusp. Why is that? Because I barely want to do the retraction of the canine, just to correct this mild crowding on anterior segment of the mandible. If I need to, because I told you, in this situation, I have other options. For example, I may do the IPR and extraction of lower incisors, one incisor or even two in some situations, because I know that you can do that. We know that many articles dealt with that many years ago, especially those articles from Rido and Little from the group of Seattle. They had these studies showing that the extraction of lower incisor is more stable for after the removal of the lower retainer. So dealing with this kind of movement, going with canine forward instead of going backwards, it's more stable for the occlusion. So we can do this. Or even we can also do the IPR to avoid doing this extraction of posterior and retraction of the canine. You understand that when I do the retraction of the canine in a situation like this of lower canine, I do the retraction of the lower, I have to do the retraction of the upper, because I need to correct the class, the class 2 by means of the distalization of the upper. So if I distalize the lower, I need to distalize the upper more. Is that what we want for the face? Okay, it's very, very uncommon. The most common situation is avoiding to do so much of retraction because the lower arch is the problem. The mandible is the problem, not the maxilla. So here, I'm calling your attention for the face, always the face, okay? So let's move on. And now I have more retraction of the upper and barely a little retraction of the lower incisors, or no retraction at all, because most of the case was the canine distalizing a little bit for releasing that crowding, and now I have just a little bit of the retraction of the lower canines, and then I could do the leveling and aligning without the need of doing retraction of the lower. Sometimes even protruding lower, okay? This is good sometimes. Sometimes not, of course, because sometimes we have the lower incisor and the limit of inclination, in its limit, they reach the limit of inclination because they are almost outside of the bone. We know that in some situations in class 2 cases, especially if we have a hyperdivergent pattern, sometimes we have almost no bone ahead and behind lower incisors, roots. So in this situation, we can go forward, okay? So you see how many considerations we have to keep in mind to understand our choices, to understand what we can choose in this kind of situation. So not just about biomechanics. Biomechanics is a detail which is very, very important. And if you don't understand how to deal with it, how to do the retraction, how to deal with the losing of inclination during retraction, we can block our mechanics, we can extend our treatment time, and we can have a very bad outcome for the face. So yes, we need to understand biomechanics very much, but biomechanics is part of the treatment, not the treatment itself. It's just part of the treatment, as I'm calling your attention here for that. So as you can see here, we have this situation, and when we compare those three choices, we have more retraction here, the first situation with TADS, a little bit less retraction, second situation, and almost no retraction in the lower arch in the third situation, meaning I have less retraction in the upper arch. So sometimes this is the best choice for us, okay? So we have to deal with this. Sometimes we need to do the retraction. For example, when the patient's chief complaint is the face itself, that protrusion profile is a very good example of that. Sometimes we have this patient coming for us and saying, oh, doc, I don't want my protrusive profile. Of course, they're not saying these words. It's not common. Sometimes yes, but it's not common that they say this. They just say, I don't like my profile. My lips are very protruded and I want to change that. Yes, in this case, we can choose this kind of approach of retraction, a higher retraction, especially when we have a horizontal pattern, meaning an hypodivergent pattern, facial pattern, which has this more space in the symphysis for doing the retraction. In this case, here's a good example of that. I did the extraction of the molars, the first molars, in this case because this patient had this first molar loss in the lower arch, and I looked at those other molars. They said, well, I don't like the molars. They have this huge restoration, and I don't trust this molars to be in mouth, and I don't want to do the extraction of very healthy premolar. So in this case, my option was to extract other molars to have the retraction of upper and lower teeth, to correct the protrusion of the upper and lower teeth, and along with that, the correction of the upper and lower lip. So you see here, a lower molar has approximately 10 to 12 millimeters width. So in this case, first molars, upper and lower molars without anchorage for that. So what happened in this situation? I tend to have half of the space being closed from upper and lower incisor going forward, and lower posterior going upper and lower going backwards, and lower posterior going forward. Half approximately. And you can just adjust. If you see that you're having just a very fast anchorage loss, you can stop it and change your approach. For example, going with DADs. But especially in those cases, when you do the extraction of molars, those going with DADs is not common, because we want to lose anchorage. We won't do the retraction of the whole 10, 12 millimeters of this lower molar with retraction of anterior. I want to go forward with posterior, because I want to split the space closure, posterior and anterior, okay? So this is what I do in this kind of situation. And let's see how it goes in this specific case here. Retraction of anterior, and you see the correction of the position of the lips. Of course, we have to respect patient's profile, not going that forward that much. And in this case, she was very, very pleased with the result. And when we compare before and after and this view here, we see that the correction of the lips was according to our planning, treatment planning. And here we see this protrusive upper and lower, and doing the retraction, we see the correction. See here, no anchorage at all, meaning I have the split of the correction being going with anterior backwards and posterior going forward. And now we have the correction. All times, the whole time we do the treatment, we have to understand that we need to see the situation. Are they going together? Do I need to stop here and at some place go with a less cut because we have more correction, more retraction of lower than the upper, or I need to stop with retraction in one of the arches and go just with the other arch, and then we go again together. So everything is in orthodontics is like that, guys. We don't have this perfect plan that we come from the beginning to the end like a movie. I know you like the movies that I do, probably because of that you are here with me, because you see those cases that I treat, and you understand better those cases because of those movies. But things are not like a movie. In the real life, we do things like this. We adjust. We go adjusting and adjusting and adjusting. And you see here, this patient was closed, and we are doing the final correction of the occlusion, those refinements that we like to do. And we have now a class 1. And we compare before and after. We see that we have the correction of the protrusive profile and the protrusive position of all those incisors. Okay? And for that, we use a specific torque that we are going to see and we're going to understand. And in this classes here that we are going to have. Okay? So we have here before and after and everything corrected. Okay? So we're back with this good biomechanics of retraction using torque. So dealing with torque in biomechanics is very, very important because we can control the retraction, we can control the movement, we can control the posterior segment and everything. So if we understand how to deal with it, our biomechanics is going to be very smooth. Our treatment is going to be very, very fast because we are not losing inclination, we're not blocking our movement. So now we start understanding how to deal with torque, okay? So we know that we have to understand both the relative and the real torques. The real torque, of course, is something that you need to apply. This is something that you are going to learn with our classes in this practical classes, and you're going to understand how to deal with that because this is important for your skills, for your hand skills to do and to practice a lot, so you can do that very fast. Sometimes you're in our office and you have to go with the torque, and if you don't do that fast, sometimes we just postpone. And when we postpone, we're going to have a very, very long treatment. So we need to understand that dealing with this, it has to be natural for you. So you are going to have to practice. You need to practice. And real torque, we understood before. We had this class before, and you know how to evaluate, how to assess anterior torque and posterior torque also, but now we are going to deal with anterior. We know that we have the neutral torque, meaning no twist of the wire, so we have this completely passive position, completely neutral position of the wire in relation to the glass slab and in relation to the position of the plier. And when we use, for example, these pliers here, this is a 142 pliers. And when we grab, we have a possibility of having it neutral, positive, and negative. I'm not going again with this explanation because you can go back and go to this specific explanation. Positive and negative are the tendency of moving positive and negative. So we have the real torque and the relative torque, which is the most important torque. So this is the torque expressed in the bracket slots and consequently in the teeth. In other words, what the twist of the wire will represent in terms of inclination tendency in these teeth. We know that, we understand that, we have that in mind because we knew that for our previous sessions in torque. And now we are going to another situation, not just the passive, active, negative, and positive torques when we insert the rectangular arch wire. We're going to another thinking here. We're going to understand what is the relative torque when we do the retraction, not just the insertion of the arch wire inside the slot. You remember that in that situation, just after going with the sequence of arches, of arch wires, we reach the round arch wire, the thick round arch wire in my mechanics, because I use 2230 slot, I use the O20 as the final round arch wire. Now we're dealing with this other concept, which is rectangular inserting in this rectangular slot, generating the couple or not, if we're going to the passive. But now I'm adding something. Now I don't have just the couple because now I'm retracting. And here we have to understand the relationship between the retraction, this moment of the retraction, which is going to generate a force and a moment, with the moment of the couple. So this balance between the moment of the retraction force and the moment of the couple will position the center of rotation of that movement in a specific position. So we are going to place the center of rotation in the place we want. Of course, it's not something, things are not that easy, things are not that fast as the videos may imply, because this is real life, but we are going to understand how to deal in real life with those torques, okay? So here we have it. Now we're going to understand the mechanics of retraction with sliding mechanics appliances, okay? So first of all, let's just go back here because I want to emphasize something here. Sliding mechanics, especially when we go with extractions. Then we go again with the mechanics of the retraction in other designs. Now extraction of upper bicusp, for example, we understood in the previous sessions that we need to avoid doing extractions in the lower arch when the mandible is, we have this receded chin and we have this mandibular deficiency, okay? So now we're dealing with the retraction just with extraction of upper bicusps, upper premolars. Sliding mechanics and extractions. A question that I pose to my students is always this. So, what are the main problems in this phase of retraction? We have loss of inclination of anterior teeth, and we have the anchorage loss. When we do this, when we do the retraction, can we do the retraction using round wires for that? Because sometimes we don't think of retraction with round wires. We're just applying the round wire and we see the space and we think, no, I'm just using here power chains for closing the space. Closing the space in this situation is retraction. Closing the space using a power chains for protruded anterior teeth with diastemas is the retraction itself. So Can we control the position, the inclination of anterior teeth using round wires? Because I know that people say that we can. No, we can't. Actually, what's going to happen here, even when we use when we use all 20 arches, for example, for this, we can control inclination. Look at this. Using a round arch wire, around O20, for example, here, we are not dealing with the control of inclination because we don't have the couple. For having the control of the inclination of anterior teeth, placing the center of resistance in the position, and center of rotation, the position we want, we need to have another couple, another moment, which is the moment of the couple. Here we don't have it. Some people say that, oh, but I can apply a curve of speed, a reverse curve of speed, or an accentuated curve when we use it in the upper arch, accentuated curve in our arches. We can control the position of the incisor. We cannot. We really cannot. I'm going to show to you why we can't do this in this situation. So this is what happens when we don't have the control, meaning we are using just power chains. We're using here a soft arch wire. People do like that. Believe me, I've seen a lot of this kind of outcome here. I think you may have seen the same outcome in your country, in your place, where you work, because it's very common, because people think, well, I don't have to wait till I reach a rectangular arch wire. I'm going to start closing the space. And closing the space like this is very bad because you're going to delay your treatment, because you're going to have the block of the movement. You're going to block your movement. You have to stop because you're going to touch anterior teeth. It's going to happen. Anterior upper teeth is going to touch anterior lower teeth. And then you haven't corrected yet the position of the canine, so you have to stop the treatment, because you need now to deal with that inclination that you lost, okay? Because now you have to correct the inclination, then you go on with the retraction. And you using round arch wires for that, you're not going to have this control. Let me show it to you. What do we call this in orthodontic treatment? We call this the roller coaster effect, which is very bad for the occlusion, very bad for the bone itself, because sometimes you have the fenestration of this anterior plate here, because the root is going forward. We're not controlling the position of the root. We're just doing this loss of inclination, and we call it, as you remember, uncontrolled tipping. We're not controlling the tipping, and we're going backwards with the crown and forward with the root. And this is very bad for everything. So this is the roller coaster effect. Okay? Sometimes people say that the accentuated curve can help control the inclination of anterior teeth and the roller coaster effect. Yes, it can. We can control the roller coaster effect because we are going against it. Okay, but we are increasing also in this situation like this, in a situation like this, if we use thick arch wires for that, we are increasing the friction. And sometimes it's not good for the treatment. So let's move on. But does it control the inclination of anterior teeth when you go with this curve? No. The accentuated curve, it won't control this position. Let's see how it goes here. I'm dealing with this curve, and if I wait long enough, I'm going to have this intrusive position, intrusive tendency in anterior teeth. So when we do that, we can control, yes, we can control this roller coaster effect, because we are not going to have the extrusion of anterior, because you're having this force upward, and we're going to control the extrusion. But let's see how it goes with the resultant force. The resultant force is this, just a force, not a couple, just a force backwards, an oblique force. Yes, you can go this like this, but for the incisor, it may stay regarding to the horizontal position, may stay in the right position, but the inclination is not going to be controlled, because this is what's going to happen. Yes, you control the roller coaster, but you're not controlling the inclination of anterior. Sometimes, if you want to lose inclination, it's good for you. Okay, I'll deal with this because I have like a very huge inclination and I have enough bone and the root is not very close to the thick cortical plate. Yes, I'm going to do this. And I'm going to do this with round wires and accentuated curve. But I know what I want. I'm not going with the tide. I'm not going because people say that's very good for every case. It's not. Some cases, yes. But most of the cases, it's not the best position that you want, the situation that you want. Because most of the time, losing inclination of anterior crowns, you're going to lose this lip posture, this lip position. So with no torque control, sometimes you have that. But when we do the retraction with torque control, good inclination, we may have a better outcome for the lip, upper lip especially, okay? Let's see here. I'm going to show you this case and I'm gonna ask you something. Look at this case and answer me this question. In this situation, it was a situation treated with round arch wires and we have this loss of inclination of anterior teeth, and the chief complaint of this patient was the deviated midline, upper midline. And I have this class 2 in one side and class 1 in the other side. The side that was correct with extraction of the first premolar, and this side, the premolar wasn't extracted, so deviated midline. My question for you is, in this situation, would you go with extraction? Would you plan extraction for this patient? Because we see, and the literature says that extraction is bad for the lip. And my question for you is, in this case, would you go with extraction or would you avoid extraction in this case, this patient? And I'm going to ask you and wait like 3 seconds, because 3 seconds here may be 1, 2, 3 minutes for you if you just press the pause and think about it. Think about it. Well, the answer for that is extraction in this case won't do any harm for the face. Any problem with the face going to arise with extraction if we control the inclination, because as you can see here, we don't have overjet. We don't have space between upper and lower incisors, meaning I'm not going to do the correction of this case with retraction because I don't have space for that. Actually, we can increase the position of upper lip if we do a very good torque control here, meaning I'm going to do the torque control and then I'm going to rotate upper arch with the correction of the upper arch without doing this retraction because you don't have overjet. Understood that? So let's see how it goes. In this case, I did the extraction of upper first bicusp because it was the only bicusp that wasn't extracted that in the previous treatment, and I went with this kind of correction. And I used for that TED. I can see the TED here, but yes, I used TED for that, and then I removed the TED when I had the correction of the K9 position. So let's compare before and after. This is the correction of the midline. And as you can see here, we have the after doing the correction of the torque, both posterior and anterior torque. Now I have a wider arch. Here is the TED. Let me show it to you in detail here. Here is the TED, because it's not about the TED here, but just a detail. The TED was here, and I used this mini implant in between roots and do the retraction, and I did the retraction with the correction of the inclination. Understood? I don't have a retraction, really a retraction of upper lip. I did this, and then I rotated upper lip with control of the inclination, okay? So when we compare here, before and after, the inclination of both anterior and posterior now are completely corrected. Meaning now I have more pronounced position of the lip, upper lip, more protruded position of upper lip because I corrected the position inclination of anterior teeth. And this has a very good side effect in the lip, okay? So when we compare here, before retraction, before correction, and after correction, can you see here the difference between these two positions? So this is after and this is before. Wow, with extraction, Yes, because don't think inside the box. You don't need to think, oh, I never do extraction if I have a obtuse nasolabial angle. It's not true, because sometimes you don't have to do the retraction. We do extraction and we correct the position of, meaning inclination of anterior teeth, and now I have more protruded lip, not more retruded lip, because now I have a good inclination. So torque is the best lip filler ever invented. So when we do the torque, we keep the position of anterior teeth. We don't have to do the lip filling here and from 6 months from here, and again and again and again, because this position will be kept with time, okay? So torque is beautiful. Torque is everything that we need to have when we do the correction of those retroclined incisor, and here also posterior. As you can see, the buccal corridors now are more filled, and we have this position of upper and lower, more protrusive lips after compared to before, okay? This is the question that I posed to you. Not always doing extraction will ruin the face. Not always, because sometimes this may have a good outcome for the face, especially when we don't have to do the retraction. So now we are going to learn how to do the retraction. Okay? So can you understand the way we're going here? We're dealing first with retraction, meaning I'm telling about the retraction and I'm showing to you that the face is the most important thing here. Then I go with the face, then I go with the options that we have, and I explain to you that we have the option of doing the retraction, the whole amount of retraction without losing anchorage, and the bad outcome for the face when we do that, and we can control. And I showed you a case that we can do the extraction without losing inclination. It's exactly the opposite. Going with the incisor forward and then doing the rotation of this incisor. So now I'm going with the mechanics itself. And I'm going to show to you 3 possibilities now. I can do the retraction now using 3 concepts. First concept is doing the inclination lost, meaning I'm going to have the position of those anterior teeth more retroclined. So meaning I'm going to have one torque, specific torque for that. I can do a torque on anterior teeth and keep the position of those teeth being retruded, being retroclined, being retropositioned. And I can also do this with gaining inclination, increasing the inclination of the crown, and have the root movement. So we have 3 possibilities doing the retraction of anterior teeth. So this is what we're going to do with understanding the torque. Understanding the torque, how to do the torque, but mainly the relative torque and how we measure that. So now it's what we are going to understand, okay? So we have 3 possibilities, as I told you. I have the possibility of having the inclination being lost, like this situation, and for that I'm going to use a passive torque. What is a passive torque? Do you remember in our previous classes when we talked about the real torque? Real torque is neutral when it's in the height, when we grab this anterior part of the segment, anterior segment of the arch. I'm explaining here the anterior torque. So when I grab the anterior segment of the arch wire, this is going to pass in this posterior part in the same line of the middle of the pliers. And when I put it in the glass slab, it is completely flat in the glass slab, meaning if I have a magnifying glasses, I can look at this part. If I just cut that anterior part, this segment is going to be completely touching the glass slab, the anterior segment. It's not going to be torsion, not going to have a torsion, okay? So this is neutral, but here is passive, meaning you understood that before. We dealt with this before. It's not necessarily a neutral torque. Sometimes I have to apply a torsion to achieve the passive position. The same thing applies here. So I'm going with the torsion because I want to adjust that torsion, the anterior torsion of the rectangular arch wire, so the posterior part of the wire is passing in the same height as the tubes. So this is the passive position of this torque. Meaning, is this neutral? Not always. Sometimes it is when I have a perfect position of anterior teeth and I have the prescription reading this perfect position. So I can apply neutral torque and achieve the passive torque. But sometimes, as I showed you before, I have very proclined anterior teeth and I need to apply a torsion so that torsion matches the inclination of the slots of the anterior teeth. Remember that? If you're not remembering that, go back and you go see that again, because this is important for this concept here. Now I'm going to apply a passive torque for retraction, meaning this passive torque, no couple is generated, but I'm doing a force, but I'm doing a retraction, so now I'm having a force and the moment of the force. Let's see how it goes. Here we have it, and for understanding better, I'm adding something here, which is the anterior segment of the bone, okay? So the anterior, the premaxilla bone is going to be depicted here, okay? So as you can see here, we have no torsion, and in this design of retraction, I'm using what? 1725 in an 022, 030 slot. Is it a good outcome? Because sometimes we think, well, I need less friction, and I need a rectangular arch wire for that, for doing the retraction. But is this design good? Hardly. Let's see how it goes. Because when we do this, we have no control at all at one part of the retraction. In one part of the retraction, it's almost like we're using round wires because we don't have contact between those 2 points generating a couple. Because it's completely passive and we have this play inside the slot. Remember the play? We have the play inside the slot. So during the retraction, what we will have is this. I have the force. Let's say I'm applying here 200 grams. So I have 2,000 grams per millimeter approximately in a healthy environment. Remember that? So when I have approximately 10 millimeters height of the center of resistance of anterior segment. I'm just here using the concept in one tooth. It's the same thing, approximately the same height. So for us to understand, I'm going to apply, for the sake of simplicity, of understanding it better, I'm using just one tooth. And I have 10 millimeters height, okay? Which is approximately the same thing when I have 4 or 6 anterior teeth. 10 to 8 millimeters height of those anterior teeth together. Let's see. Force, moment of the force, and retraction. No couple. No couple. Until we have a couple. So we have the retraction, a free retraction, meaning we have uncontrolled tipping in part of this movement of retraction. And then I'm having the bone, the root going forward, okay? So is it good? Well, I really doubt that because you may just concentrate the force in the apex of anterior teeth and you may generate this root resorption. So beware of that, okay? I don't apply this kind of concept. What I want here is to have more control. And when we use 1725 arch wire, sometimes what you have is not enough rigidity, not enough stiffness. So you lose inclination, even having the torque, okay? Because it's not rigid enough. And what do? I apply this concept, 1925 in 022/30 slot. But Kleber, now we have more friction. Yes, but what do I use for that? I want to have this rigid arch wire on anterior segment, and in the position that this arch wire is going to slide inside the posterior slot, I just grind it. I just go like rounding those tips of the arch. And then I have less friction, and I have still in the anterior segment more rigid control, okay? So this is what I apply. Even if I don't have this, in this situation, this couple in the beginning, I'm going to lose less inclination before I reach the couple. As you can see here, because I have a less play, okay? But sometimes I just apply a little bit of a torque since the beginning because I want to have just since the beginning a very slight contact. No torque at all, no active torque, but contact in those points, okay? So this is what I do. Just for you to see, in this situation, I'm proposing here, I have more control, and I tend to have, in this situation, the center of rotation position close to the apex of those anterior teeth, which is a controlled tipping, okay? So for that, I use the concept of having a passive torque, but you need to have this situation here. More stiffness, more control, and you go controlling again and again each time patient come back to your office. Then sometimes you have to change the torque, okay? First torque, the passive torque. I want what? Controlled inclination during retraction, okay? Still about the retraction using torque, we are going to the next torque. The next torque is that situation in which we have a good inclination of anterior teeth, but not a good position of anterior teeth between upper and lower, meaning I have a overjet. I have an overjet that needs to be corrected, but the inclination of anterior teeth are very well positioned. Very good inclination we have there. So in this situation, I want to do the retraction keeping the inclination without losing it, because otherwise I can have the block of the movement. I can block the movement during the retraction. And I don't want that to happen because I have, in this situation, a smooth movement from the beginning to the end until you have the correction of the overjet. So I need to apply a torque in order to counteract the inclination, the loss of inclination that we tend to have. What can we do in this situation? I want to apply a torque that is resistant to the loss of inclination, the inclination lost. So what should we do in this situation? Apply this torque, and when we measure, when we put in the anterior segment this 1925 arch wire in the anterior segment, when I do the reading of the torque, in the position of posterior segment of the arch in relation to the tube, to the height of the tube. For having this amount of this magnitude of torque, I apply this 5 millimeters when I put in the anterior segment. The posterior segment is going to be 5 millimeters high, because I know for previous measurements and finite elements and all, that when we have this 1925 arch wire, when we apply this torque and it passes in this position approximately 5 millimeters high in relation to the entrance of the posterior tubes, we have the torque that we need to counteract the moment of the force of retraction when we apply approximately 300 grams in each side. Is not that too much, Kleber? 300 grams? No, it is not. Do you know why not? Because in this situation of sliding mechanics, we have high friction. So we have loss of efficiency when we have high friction. Part of that movement, part of that force that we are generating during the retraction is lost by the friction, because of the friction. So 300 grams is good. And I'm being very clinical here for you. So we apply 300 grams in each side of the mouth, in each side of the arch, doing the retraction. And we know that doing that with coil spring is better than we apply power chains, because power chains lose force very fast and coil springs not. We apply the coil springs with approximately 300 grams each side. Of course, it's very difficult to measure that when we just apply the power chains in all the brackets. We can't do that. So we use this with hooks, and we use that with the coil spring. In this situation, 5 millimeters high, what's going to happen? Let's see. Approximately this 5 millimeters high, comparing to the entrance of the tube. So when we go down here and we put inside the tube, the force generated in anterior segment on those anterior teeth is approximately the force that you need, the couple that you need to counteract the tendency of losing inclination, meaning the tendency of losing inclination is the moment generated by the force. So the moment of the force is going to match the moment of the couple inside the slot. Do you see the situation here? I'm applying in this example and this design of retraction one bad thing here, which is the ceramic braces. Ceramic braces, they usually break when we do this kind of torque. So if we need this torque here, I really advise you not to use ceramic braces anterior teeth because they will break unless you're using a very good ceramic brace for that. And we have many good ceramic braces, especially when we have the metal, the slot in the metal and not just the ceramic. In this situation, if you lose inclination with the ceramic braces, is because it's not enough force. Because if we have enough force, ceramic braces won't open the slot. They will break. They will break. So if you have the right force and the right ceramic braces, yes, you can apply this. And you have another bad side effect here, which is this combination of ceramic posterior brackets in this area of sliding mechanics and metal and stainless steel, we have more friction. If you apply TMA for that, you won't have the movement at all. It will like bond the arch wire to the bracket. So don't use TMA for sliding mechanics. It won't work, especially if you use ceramic braces. So I don't use TMA in this kind of retraction, just stainless steel. Stainless steel because we have less friction in posterior segment and more rigidity on the anterior segment. 1925 in this composition, and ceramic braces is not good for that, okay? Just an advice. Yes, you can use if you have a good ceramic brace, but good ceramic braces, but if not, don't use it. You are going to be very unsatisfied with this combination. So let's move on. In this situation, the resistant buckle torque. So you know that we just put inside the slot first, and then we have to bend the anterior segment, which is torsion, which is twisted, to get inside those braces. So we do like this, we put here, and for getting inside this anterior segment, we get this twisting. We have this twisting of the arch, this stainless steel, and because it's a very plastic material, we have it very resistant in this keeping the torque. So it keeps the torque. It keeps the torque. If it is stainless steel, it will keep the torque. So we can trust on that. Having this situation, we have to go untwisting and getting inside the slot. So it's going to keep the torque. And so now we have this couple generated inside the slot. Let's see more close. We have the couple, and having the couple, we have the moment of the couple. Do you remember that? We have here two forces in equal magnitude, so we have two different senses, same direction, and non-collinear forces acting here in this position. And as we know, because we have this very short distance, we need to have high force, because the moment of the couple is calculated by one of those forces multiplied for the distance between those two forces, which is very short. So we have to have this very high force applied here. So we have the enough couple, enough moment that we need. In this situation, of course, guys, this is not magic. This is not like this. And when we apply this concept, we need to keep in mind that most of the time what is going to happen is loss of inclination in the beginning of the movement, and then we wait. So we have the correction of the inclination, because when we lose inclination, we increase the torque because we have now more inclined anterior teeth contacting more with more force, because now we have this loss of inclination and we increase the torque. we increase the couple. And now we need to wait till the couple does its job, which is correcting the inclination. So we can't go on and on and on, going with the retraction and activating the force and reactivating the force all the time. No, it won't work like that. You need to wait for the torque to act. So torque takes time. It has to act for a long period for having a good torque, a good control of inclination during retraction. Sometimes what we see is that orthodontists want to go fast. But going fast here, it doesn't mean that you go again and again and again with the activation of the force, because each time you reactivate the force of retraction, you're increasing the moment, and you're not letting the couple, the moment of the couple, act. You're not waiting for that. So please wait. Don't reactivate all the time. What happens when patients come back to your office? You remove the arch wire and you again read. You see the torque. Is it the torque that I need? Am I losing inclination? So if I lost inclination, probably the torque is higher now because it will pass higher than that 5 millimeters, and then we wait. We keep the force. We don't increase the force because the force is a little bit, it loses a little bit of a force. We don't increase it again, and we let the torque act. And we let the couple and the moment of the couple be effective. So we need to wait. Keep that in mind. Always keep that in mind. So for this thing to happen as it's drawn here, we need to wait. Let's see how it goes. So we tend to cancel the moment of the retraction. Here it is the moment of the retraction, and the moment of the couple, they are going to be canceled. In a perfect world, it happens, but in a real world, it won't happen like this. So sometimes we have loss of inclination, and then we have the correction of the inclination. And it go like this, in this this movement like a pendulum, like this, going like twisting and twisting, so we have the final moment as a translatory movement, okay? So this is in a beautiful, beautiful drawing. Is this what's going to happen? We spread the force in this whole area of the root, and we have this tension here in the other side. So we have compression in a wider area and have the tension, and we go like this. Again, this is not magic, but this is what's going to happen if we apply the right torque, the right time, and we don't go apply again and again and again the force of retraction. We let the torque do its job, meaning we let the couple correct the inclination of the crowns, okay? So we do the activation of the force and let the force act. Again, if you need to do something, it's just to check, because sometimes because of the mastication, because of some things that patient put in mouth, we have this twisting, we have this deformation of the arch, and we have more friction. Or sometimes we don't even let the wire go like sliding. So test the sliding, test everything, and again, don't put more force. Let the torque act, okay? Don't need to do every time patient come back the reactivation of the force. Believe me, it's better for you. You're going to see that the movement is going to be very, very beautiful. Not doing again and again and again the retraction, okay? The force of retraction. So we go on, and we go to the third possibility during the retraction. Let's think about it. And then we go with the examples. Now we're going to understand what's going to happen, or what tends to happen when I lose inclination during retraction. Meaning, I'm doing the retraction, and at some point, there is a contact between upper and lower incisors, but the canine is still in class 2. We have the canines in both sides still in class 2 position, but we don't have more retraction to be made because there's a contact here. So the simple thinking is, okay, now I understand what I have to do. And what most people do is doing the IPR in the lower arch and go power change the lower arch, so we have a retroinclination and we have more space. But now we have both upper and lower with the crowns retroclined. You understand that? Because we are not doing the right thing here. We're not doing the correction of the anterior position of the anterior teeth. We are doing this, going far, going more distal with lower anterior because of the IPR and the power change, losing inclination, and now I have enough space to go again with the correction, losing inclination because you're not dealing with torque. We don't want to deal with the torque, we just want to retract, and this is bad. Because this is the design that we don't want to apply. Because this design is going to have as an outcome disinclination, negative inclination of the crowns. And this is very bad for the lips. Okay? So no, we don't want it to happen. Sometimes we have this. We lose inclination and I want to go on with the retraction, with the go on with the retraction, having the inclination being corrected and the retraction being made. Is that possible? Theoretically, yes, but not in the real world. For that, you need to apply a huge torque, a huge moment, a huge couple, and it's very bad for the crown and for the root, especially for the root, okay? So very bad for the bracket, it's going to break, and we're going to have much force, a high force for that, high magnitude of force for that, and it tends to concentrate the force in the apex. Let's see how it goes. 10 millimeters high. So now we have the force of retraction, which is the same, 300 grams, but now we have this huge torque here, 10 millimeters high. So when we apply this force to go inside the tube, the force that is being applied in the anterior segment is much more than 5,000 grams per millimeter, which is too high, 1925 in this concept here, in this design here, will have a huge torque. Sometimes what we have in this situation is more root resorption than everything. Okay, so I really advise you not to try to do this kind of thing. Don't do that. Don't do that in home. Okay, in your house, it's very dangerous. Avoid that. But it's possible in theory. Theoretically, it is possible. We can have this, and this is the situation that I propose for you. We have this contact here in this position, and we don't have the correction of the class 2 situation of the canine. So now we need to go with the torque. And I don't want to stop the retraction. What do? High torque, a higher magnitude of torque, a higher couple, a higher moment, and now we have the tendency of having the correction of the inclination along with the retraction of anterior teeth. In this situation, we tend to have this kind of outcome, meaning I have the couple, let's see, closer look to the couple. Think of a high couple. Is that what you're having here? And now I have the comparison between the couple, the moment of the couple, and the moment of the force of retraction with the moment of the couple higher than the moment of the force. So it's predominant the moment of the couple. And now we have this tendency going with the center of resistance distal and having this inclination being corrected at the same time. So this is what's going to happen. I don't do this, never. So Kleber, you mean when you have this situation that you propose, what do you propose for us to do? You say that it's not good for us to do this kind of high moment of the couple. So what can we do? Just stop the retraction and get the inclination corrected. You don't need this couple now for that. Just a low couple, meaning I don't need to go 10 millimeters. I stop retraction and I just apply what? The 5 millimeters concept. But we have some problems with that when we stop and we do this. I'm gonna deal with that in another class ahead. So we have this. Yes, theoretically it is possible. I have never seen this thing happening, but it is possible, okay? So regarding the torque and the control of the torque during retraction, many people that I see and I talk with, they say, well, I'll use prescription, specific prescription, and then I go with the retraction because I know everything's going to work. They think like that. My question for you here is this. Does the retraction being made with rectangular arch wire it will guarantee that torque control will take place in this situation, meaning I'm using rectangular arch wire and the right prescription, everything is going right, always. Is that true? Well, first of all, we need to understand that prescriptions, they are made for two reasons. Or you can do either for finishing or for movement. Meaning, when I do the retraction and I want to do this prescription, use the prescription for the movement, for the translation, I need a high prescription, a high torque for that. Because using that high torque, I will have more control during retraction because I'm applying the concept here of a resistant torque, something like a resistant torque, okay? And I apply the other concept, for example, when I want the prescription for finishing. It's quite the opposite in this situation. I'm using a prescription with a low torque in the upper for class 2 because I want to finish with lower anterior more proclined and lower upper more retroclined, because this is the camouflage. This is the compensatory movement that we want. So first of all, we need to understand what the prescription that we are using is. What is the prescription that you are using? Is it a prescription for translation or a prescription for finalization? So those are different, first of all. So my question for you is, why to apply those prescriptions all the time if you can do this by means of torque? You can control everything with the torque. So you can use all prescription that you want, any prescription that you want. Meaning you can use high torque, low torque, you can use standard prescription, and you'll have the control, because in each situation you need to individualize, meaning you need to individualize every time. I want to individualize all my cases because I see my patients as different human beings. One patient has, that patient needs to have more inclination of anterior teeth to secure good positioning of upper lip. In the other, I want to lose more inclination, and I work with that. I don't work with the thinking of I will apply every time the same inclination, the same prescription for class 2. I won't apply the same prescription for class 3 also. Why is that? Because I see my patients as individuals, not as medium. Okay? Because yes, medium cases, they will work. The prescriptions will work beautifully. But you don't treat those always those medium cases, do you? I don't. In my cases, in my treatments, I need to individualize, and I want that. And I want that for my patient. They deserve this. So this is a very wrong concept. I'm not having always the same outcome using the same composition. Meaning, if I apply the good prescription for medium cases and I'm not treating medium cases, I need to adjust. Because most of the time, especially using what most orthodontists want to use, which is low stiffness arch wires in this kind of translatory movement, because we want to assure that we're going to have low friction. But low friction is just part of the problem. We need to have stiffness in the anterior segment, otherwise we're going to have this inclination being lost. Yes, and then we have to deal with that. And then we have to stop movement and go against our mistake, okay? We need to fix our mistake. So this is what's going to happen most of the time, especially when we have this huge overjet to control during the retraction. I have this, and I need this to happen with the correction of the class 2 in canines to a class 1. And if we don't do this, we have this outcome. We have the retroinclination of anterior teeth because we didn't pay enough attention to the retraction and the control. And now we have the contact between upper and lower anterior teeth. And now we don't have enough space to do the retraction. So we have to stop and then rethink. And again, most of the orthodontists, they will think like this. I want to do the IPR and use power chains in the lower arch so I can secure space, enough space, clearance to have the retraction being made. But now we have two negative inclination of anterior teeth, which is very bad for the smile and for the lip position. okay? No, this is not the case. Most of the cases, what we want to do here is to correct the inclination, and then we go on with the retraction. So what's going to happen here? If the retraction is prevented by incisal contact, what are our options? Now we know that we have the option of stopping the treatment here, stopping retraction, and now I can just adjust the torque, because a low torque here may be enough to have the correction of the inclination. But for that, I need to stop the retraction, because if I continue the retraction, it won't happen like this, especially because you're going to lose anchorage. If you're using direct anchorage, we tend to lose anchorage. Oh, no, I use TEDs for that. Well, you're using TEDs, but you're not going to do the retraction because you have now the contact. So you need to stop and fix it. I prefer to use power chains. Okay, this is with you. I don't power chains and IPR. For me, is for specific situations, and I'm going to show you in which situation I use this kind of concept. IPR in the lower arch, retraction with power chains, and then go on with the retraction in upper arch. But for that, I still use torque, okay? I use torque for that also. So in this case, I need to do the correction. For that, I don't need a high torque. Don't even need to use 8, 7, or 9 millimeters, just 5 millimeters. It's good, it's enough. In this case, it's an active torque. Why is that? Because I don't have force of retraction to be resistant anymore. Because you know that 5 millimeters high is what we call resistant, okay? In this clinical field that we are applying here. This clinical field is going to work in most of the cases. So we go, we feel the torque, we read the torque, 5 millimeters high is enough, and we wait for the correction of the inclination of anterior teeth. But here we have a problem. Here we have a problem. What problem is this? When I do the torque, I'm applying just a couple, and the moment of the couple tend to go with the root backwards and the crown forward. Meaning I have to do this, all this bone resorption in this area, anterior area, and then we go to have the movement of the root. But imagine that. I'm applying the force and I'm contacting the root against the bone, and the crown is going forward. Going forward, if we have all those teeth connected, I tend to have the loss of inclination of posterior teeth, which we call the roll bow effect. I'm just doing the roll and I'm going forward. I want to eliminate that. So when we do this, we stop retraction and we do the correction of the inclination using just the torque. Think of this bad side effect, which is the losing of the posterior segment contact between upper and lower. This is what's going to happen. Because the root of anterior teeth is contacting this huge area of bone, and the anterior crowns are going forward. So imagine this, they're contacting here and going forward. So we have the contact of all those teeth, posterior teeth, with this wire here inside the slots, and we have the friction and we have the tendency of those anterior teeth going forward along with posterior. So we're having this inclination, or this loss of anchorage. So this roll effect, it has to be counteracted with elastics or TEDs or wherever you want. I just want you to pay attention to this side effect, okay? So do whatever you want to do to maintain posterior teeth in this solid class 1 relationship. If it is class 1, of course. If it is not, you have to achieve the class 1. And then here we have one possibility and one easy possibility if you have this approach with your patient, is to say to your patient that you need her. Now I want you to use elastic. It's the easiest way, especially in hypodivergent patients with a good occlusion, with a good intercruspation. Elastics are going to be enough. So use triangular elastics for that, and for that I use 1/8 heavy elastics, triangular, like premolars in the lower and one premolar in the upper, and premolar and molar in the lower, and upper molar also you can use triangular elastics. So this is enough in most of the cases if patient is compliant. If you have a cooperative patient, this is going to happen. You're going to keep the occlusion very tight in the posterior segment, and you are going to avoid this side effect. You just have to tell your patient. Of course, if you have this approach, you have this kind of good relationship to your patients, and you say, I need you, because if you don't do this, we're going to increase the treatment time, because what's going to happen is the posterior segment is going to be losing this good positioning, and then I have to recover. And then I have to go back to a very long treatment to regain what I lost. So for that, I need you. I need you to use these elastics, and most of the time they will. And if you feel they are not going to do that, you can go with pads. You can put, for example, here a mini implant in between the roots of upper first molar and second premolar, and secure the space with a heavy wire between this mini implant head and the premolar or molar, and you can just ligate those two with this heavy wire and have this indirect anchorage being used for that. You have many options. You choose, okay? Just calling your attention for this bad side effect. So now we wait. So we use this concept of the active torque, which is not necessarily 10 millimeters because it's too high, as I told you before. 5 millimeters or even less than that, you will have a good torque and a good couple for having the correction of anterior teeth. Again, here it is, going inside, untwist the wire, get inside the slot, and then now we have the couple. The couple is going to generate this moment, and the moment is going to correct the inclination of anterior teeth. And when you have it corrected, then you can go on with the retraction. So remember, secure it and have it like this and wait for that to happen. You don't need the anterior teeth to go forward. You just need the root to go backwards. So now we have something like we mentioned before, with the center of rotation closer to the brackets of the incisors. So you need time for that to happen. And this whole period here, this moment that you are correcting anterior teeth, you need to secure the occlusion, the good occlusion in posterior segment. Remember that. Remember the roll-ball effect, okay? For that, we have this, okay? And then we just secure the space. After having it corrected, yes, now we have clearance between upper and lower incisors, and we can go on with the correction. And now I ask you, now I have this overjet recovered, and we have now secured the space to do the retraction. What is the torque that you are going to apply to go on with the retraction of upper anterior teeth? 1, 2, 3, it's resistant torque, of course, because now you have the right inclination, and you want to keep this inclination. For that, resistant torque, meaning same 5 millimeters, okay? And then you go on with the retraction. Again, controlling and adjusting, step by step. The patient come back to your office, you see again, everything's going right, I'll keep it. Oh, I lost a little bit of inclination, I wait. So this is case to case, and you go on again and again, controlling it. Now, if you have to lose inclination, of course, you're applying a passive, but it's not common because you recover the inclination, okay? And now you go to keep it. So, let's see how it goes in this case. Can you see it here that we have a good inclination of anterior teeth, but we have an overjet to be correct, and I have a full step class 2 in this case. Of course, we know that if I want to correct that in maxilla doing the retraction, I need this perfect anchorage for that, meaning I need TED for that. I need absolute anchorage for that. So we need to first secure anchorage and then do the right inclination, do the right torque to keep the inclination. meaning I need 1925 in this environment here, and I need a resistant crown torque, okay? Resistant torque. In this relative torque is resistant, meaning I have a good torque to keep the inclination during the retraction. Let's see how it went. So here it is. And another thing here that I want to call your attention for. When we have this inclination, good inclination, and we have contact between upper and lower incisors, we don't do the extraction. We just do the extraction when we correct the vertical. I want this to be very clear for you, because sometimes you think, no, but I can use posterior bite ramps. Yes, we can. But if we don't want to increase lower anterior face height, you are going to remove those bite ramps. So if you lost inclination, even using bite ramps, when we remove bite ramps, we'll open the bite posterior, in the posterior segment, because it's going to contact incisor upper and lower incisors, because they are going to be retroclined. So it is going to be necessary to have the inclination being secured, the inclination being corrected. So before doing the extraction, we need to have enough clearance, both vertical and horizontal. So then we go with the extraction, because what I see most is people doing the extraction even before having the vertical being corrected. And they use for that the just bite ramps and go with the retraction and lose inclination, and they think it's okay. When they do the trimming of the grinding of the posterior bite ramps, they will see that we will contact anterior teeth. So we are going to generate a posterior open bite in that situation. We don't want that. So my advice for you is do the right leveling and aligned face, and secure enough space, both vertical and horizontal, and then do the extraction and initiate the retraction. Why is that? Because when we do the extraction, 6 months after extraction being made, we have this volume of the bone being very, very rapidly decreased, very fast decreased. We can have like 50% of bone volume lost in those 6 months. So if we are doing the extraction and you are not having enough space to do the retraction, and we'll have to wait, so we are going to have this volume being very, very fast decreased. Okay? So before doing the extraction, remember, make everything perfect to the retraction to begin. And then we have a faster retraction, because we have this window of opportunity of having a faster movement, because now we have this regional acceleratory phenomenon, like orthodontic surgery. We have more movement being made, more faster movement being taking place here, okay? So now we do the retraction. Let's see if it went well. No, it didn't. It didn't go well. Why is that? Why is that? What do you think happened here, and that we have this situation? We have now the retroclining incisors contacting a lower incisors. What are the options here? Yes, those power chains are being used to close the space, but not with IPR. I didn't use IPR in this situation. I wanted to have the correction of anterior teeth. So I applied the torque. This is a case treated in one of our courses. And what happened here, guys, is this. Low stiffness arch wire being used in anterior segment. 1725. 1725 is no good for that. It's not a good option in this situation, especially when we have this huge overjet and good inclination of anterior teeth. This wire, it doesn't have enough stiffness for keeping the inclination or correcting the inclination. So as you can see here, we have the contact, and now we have to stop the retraction to correct the inclination, okay? So guys, nothing is going to happen in this situation because we have the contact. So it won't matter if I keep on with the force, it won't go, because two bodies, they don't occupy the same space in the same place in the space, okay? At the same time. It won't happen. It will contact, it will keep the same position. So what we want to do here is correcting the inclination and then go on with the retraction. And then we can move on with the retraction. For that, we changed the wire size. We went to the 1925 and with active crown torque, active buckle crown torque, and then after correcting that, we move on with resistant torque to continue the retraction. This is the right way to do it, right way. But what happened here is a crooked path. We went from here to here and then to this photo here for like 10 months after this photo to reach this position. Too long. I don't want that to happen. What was the wrong choice here? The arch wire and the wrong torque, okay? So if we went in this path with the right torque and the right arch wire, we wouldn't need to go this way. We go like this direct path, okay? Not going here and going backwards and then having to correct and spending a long time for that, for going to the right place. So important, very important. Keep in mind that if you apply the right concept and the right torque and the right movement that you want, you don't need to go like this long treatment because of something wrong you generated during the movement, okay? During the treatment. So keep that always in mind, okay? And we are back. So there are some situations that we feel that I don't need to extract to correct that class 2. And what if I use another approach for that? For example, using elastics. By a patient wearing elastics for correcting a class 2, it is possible, yes it is, if we choose the right patient, and we have talked about that before. We know that we have some situations that are completely contraindicated for wearing elastics, and those situations that are okay, I can use elastics for that. So what can we do? What are the options that we have when we use elastics? Will it change something for us? So the question here is using not anymore the sliding mechanics because I didn't opt to do the extraction in that case. What can I do? Class 2 is one option. Of course it is. But will it change something? Here we have a situation correct just using class 2 elastics. So what happened from this photo here up to this one here down? Is it a very, very easy way to do the correction? Or if you don't extract and use elastics for class 2 correction, would there be any difference when you have this approach, when you use this approach here? Well, I think things tend to be worse, actually, because we have now another thing happening during the retraction of anterior teeth, because now we are splitting the correction between upper and lower. So if I don't want to do the extraction and I don't want to do the correction just in the upper arch, I want to split the correction between upper and lower. One elastic, class 2 elastics is a good outcome. It's a good strategy for that. But what is going to happen in this situation? As you can see here, we have retroclined anterior teeth. We don't have enough space between upper and lower to do that. So first of all, we need to secure space. We need to achieve this clearance before doing the retraction or using elastics for that. So the treatment step by step here will be a little bit different. First of all, we do the proclination of anterior teeth. We run the sequence of arch wires, then we reach the rectangular arch wire. And after reaching it, we're going to do the inclination, the right inclination of anterior teeth. Torques are going to be used to accelerate it, okay? We're not just relying on the prescription, we're not just relying on the sequence of arch wire that we are using. Yes, we do the torque, because we want that thing to happen fast, so we can go on to the next step, which is the sagittal correction, which is the correction of the class 2 by means of posterior displacement of maxilla and anterior displacement of mandibular teeth. We can use elastics. Patient, we wear elastics for having this outcome. Again, I'm just here talking about the biomechanics because previously we have talked about the right concept of using this, okay? I'm not going to use this kind of approach in vertical patients, okay? In hyperdivergent patients, because if I do that, I'm going to have more extrusion of posterior, more rotation of the mandible, more posterior displacement of the pogonium, and an increase of the lower anterior face height, which is not good for this patient. So I'm assuming here that you have understood that, and you are going to apply this concept to the right patient, okay? I rely on this. I trust on you, okay? I trust in you to be like this. So we are going to do the retraction, but in this case, we have both occurring at the same time. And in most of the cases, anterior lower teeth will very fast go forward. And in this case, we have both anterior losing inclination in the upper and posterior, and lower going forward and contacting faster. So we have this outcome. We have this situation being very fast, happening very fast. So we remember that I told you before that in one situation, I usually use the IPR. This is the situation. This is the situation because in this case, we're going to have the inclination of anterior teeth. And you may be thinking now, but I can do, like, for example, indirect anchorage for having the stabilization of the lower arch, so I use elastic. But if you have this feeling, if you have if you want that to happen, not going with the lower arch forward, and you're going to use for that TEDs. Why are you using TED in the lower arch if you can use TED in the upper arch and you use elastics? So I'm assuming here that you want to split the correction between upper and lower. So this is not that simple thinking now, but I can use, for example, here, TED in the lower arch and indirect anchorage and use elastics. Makes no sense, because if you want to use TED, you go to the upper and don't go with the elastics. Here, you and I, what we want is to split the correction, because you know that patient that you chose this kind of approach, he or she, what they have the mandibular deficiency. So we want to do a little bit of retraction of upper, but a little bit of protraction of lower teeth, because we don't want just to go up to do the correction. Otherwise, we can ruin patient's face. You understand? This is what I'm thinking here. I want to split this kind of correction, but sometimes, I would say most of the time, we have more inclination and very fast inclination of anterior teeth, and this inclination will block the movement of retraction and the correction of the class 2. So in this situation, going very fast forward with lower anterior, sometimes we have to deal with the IPR because it was too much, and I want to correct. So in this case, I can use the IPR approach to have the correction being made both up and lower, in upper and lower arches. So I have the inclination being regained in the upper arch by torque, and the lower arch, it was too much of inclination, and then I can use the IPR approach for that. So we can correct. Again, same strategy. We stop with elastics, and then we go with the correction like this. Torque, okay? Oh, Kleber, but can we stop the elastic? We stop with the elastics full time, 24/7. No, now we say to our patient, to keep elastics, to keep the position that we achieved now, we so hardly achieved. So we keep the elastics just for night use, night wear, only night wear. So then we stop with the movement, with the active movement, and we keep the movement, the position, with this kind of approach, just night wear. And then we have the correction of anterior. You remember that we have in this situation the possibility of having the roll-bow effect, because we are dealing with this contact of the root against the bone in a large area and the anterior teeth going forward. We want to avoid that, and we want to avoid posterior teeth to go forward along with the anterior teeth, together with anterior teeth, okay? And then we use the elastics for that, 10 to 12 hours day, not just night, yes, because it's 10 to 12 hours. Remember Andrew's 10-hour theory is that what it's about. We keep the position using some kind of force for 10 hours, not much more than 10, like more than 12 hours. So between 10 and 12 hours, you tend to keep the position. So for that, we asked our patient to wear elastics just for 10 to 12 hours. So we have the correction being made, taking place in this condition here, but we still wear the elastics, and then we have again and again the split of the movement between upper and lower. Sometimes you have to do very good IPR in the lower for that, because I don't want just upper to go forward, to go back, okay? I want the anterior, I want the lower to go forward because I want to split, again, because this patient, specific patient, he or she has this mandibular deficiency, okay? So I don't want to ruin her or his face with just the retraction of the upper arch. And here we have the case, again, class 2, correction of the torque. I did the torque, as you can see here, good torque, correct anterior position, anterior inclination, and then we are with the elastics being worn, and now we have this contact, but not the correct position of the canine in one side. In the other side, yes, we have corrected the position, but not in the right side. So stop the movement. Again, we have this strategy of using just 10 to 12 hours in this side again, because I don't want to go forward. I just want to keep it. And if I just remove the elastic now, we'll have a fast relapse. Why is that? First of all, because we have this this bone being created in the distal part of the upper arch, because the distal part of the lower arch, I'm sorry, because those lower teeth went forward. So we have this tension in the distal segment of the roots. So there's formation, bone formation, that area, which takes time, like 3 months to have this bone being stabilized in the movement. So we need this night wear elastics, okay, for at least 3 months. So now we have the correction in this side. Let me just be more clear here. So upper teeth went forward, lower teeth, upper teeth went backwards, lower teeth went forward, okay? So think about the movement. I think we have many images of that during our course. Yes, I remember that we spoke about it before, or if not, we're going to speak about it. Yes, I'm sorry here. Just reaching the right time for this class. I'm sorry. And just a little bit more and we'll stop this class, okay? So we have correct this side. So we have the movement of this side in the upper segment here. We have canine, premolars, and molars going forward. So we have the bone being formed, being remodeled here with growth, bone being formed in this position, medial, the mesial position of the root. And in the lower arch, because those teeth are going forward, we have the bone being formed in the distal of those teeth, okay? The distal portion, the distal side of the root of those teeth. So we need to wait for this thing here, this bone to be formed, and then we have the stabilization of the movement. So for that, we need to wait at least 3 months, okay? 3 months. And we have in this side here, not the class 2 being corrected, to use more elastics, but we don't have space for that. What we need to do, IPR in the lower, upper arch is going to be correct, the inclination is going to be increased, and we use in the lower arch the power chain after the IPR, so we have lower arch going backwards, the anterior segment, because we have too much of inclination, and I'm correcting the inclination, and lower arch is going forward with the inclination of upper anterior teeth. And then staying with keeping this kind of elastics just 10 to 12 hours maximum, okay? And then after having secured enough space, we go on with this side 24 hours a day, and the other side just nightwear, 10 hours a day, okay? Then we go on. If we want to use just elastics for correcting this class 2, this is the strategy that I used for this case, okay? Let's go on, let's move on. So now we have everything beautifully corrected with a good inclination of anterior teeth and lower teeth, good inclination also because of the IPR and the retro inclination of those teeth, okay? So this is what happened. And now we have the outcome for the face. As you can see, good outcome. Sometimes you tend to think that we are creating bone, we are growing mandibles when we see this kind of facial outcome. But when we go to our cephalometric X-rays and we do the superimposition of the cephalometric X-ray, what we see is that most of the correction was just teeth, not bone. So just normal bone growth, which was expected to happen in this patient because he was still growing, okay? And we have the correction of the face, yes, and the increasing of the position of upper and lower lip, one in relation to the other, and we have here the correction. Another situation, class 2 elastics, and here we have a different approach, and because I wanted to have just in one side of the correction of the class 2, I used class 2 elastics in one side, and the other side, just to secure the position, I used the class 1 elastic, meaning triangular elastic. You may be thinking now, but why don't we use the same approach as before? But the previous case, it was necessary to correct both sides. In one side, after the correction, I'm wearing the class 2 elastics, I'm using the class 2 elastics for this patient because I need to keep the position. Now, I don't use a class 2 elastic in the left side because I already have a class 1. So I want to keep the class 1. In this case, I use vertical elastic, okay? So in the other side, I use the class 2, and the approach I did here was a more horizontal class 2 elastic because when we use just in one side and we use one class 2 elastic with a very high vertical component, I may have a cant generated by the use of class 2 elastics in one side. So in order to decrease the vertical component, what I did here was to put a more horizontal positioned elastic using a hook position upside down, like this, not in this position, because we've seen that before, that when we use this, we have high effect, vertical effect. So I increase the span between the 2 points of application of the elastic, decreasing the vertical component and increasing the horizontal component. But when we use this, we need to pay attention to the torque because now I have a lower position of the line of action of the force, a more distant line of action of the force in relation to the center of resistance of those anterior teeth. As you can see, this line of action now is more distant from the center of resistance. So we need to pay attention and we need to apply the right torque for that, okay? Just one thing here. In this situation here, yes, we can apply the concept of using the concept, just in the time here, if we're still in time, the concept of, yes, we are still in time, we can have more time in this class. So in this case here, we're not doing the sliding mechanics, as you can see, because we don't have space to be sliding the arch wire in those slots. So if we want to apply, in this case, specific case, TMA, because we are using ceramic braces for that, and to do the torque in ceramic brace, TMA is better than stainless steel. Yes, you can use it. Why is that? Because we are not sliding the arch wire in those slots, inside and through those slots. We are not sliding because we didn't do extraction here. So in this case, yes, you can use TMA. Do you understand the difference here? So extraction, the wire is going to be sliding through those slots, but here we don't have extraction. So we can use the TMA because in this case, I was using ceramic braces. So to control the torque with ceramic braces, if you're not sliding the arch wire, you can use the TMA, okay? Maybe better. So in one side, class 2 elastics, and the other side, intercuspation elastics, meaning keeping the class 1. There was an interesting thing happening. There is always interesting things happening when we show cases in the internet, in our social media. I showed this case once, and one colleague of ours, he sent me some pictures of one case that he was treating with this strategy. But he thought, oh yes, I need to use for this bite ramps in the molars because I want to speed up the mechanics. Very bad, very bad. So what happened here is he thought I was teaching this kind of approach, using in the posterior segment bite ramps, but each case is individual case. In this case, I can't use that because if I do this, I'm going to have a very fast extrusion in one side, this side here, because we have the vertical component very, very high, okay, because this is the resultant, is very, very, very vertical, and in the other side, less vertical component. So I may be generating a cant if I use in the posterior segment, in this situation here, bite ramps. So don't use bite ramps in this situation when we have differential vertical components. You may have this bad side effect, okay? So pay attention. So I'm mentioning this case, specific case, because this colleague of ours, he thought that he was using that for helping the patient, and he thought that I taught him like this. It was not true. So pay attention. And the details are very important. In this case, I want to eliminate the vertical components. If you do the bite ramps in the molars, you are going to increase the vertical component, especially in one side, which is, in this case, using vertical elastics. So vertical components are very high here. So avoid that, okay? Just quick thought. And here we have what's going to happen most of the cases, because we are very, very far from the center of resistance of those anterior teeth, we tend to lose inclination, especially because in this case I was using a TMA. So TMA doesn't have the right, the good stiffness that we want. So lost inclination. Then I had to struggle to recover that inclination of anterior teeth. Okay, again, torque, and here is how we apply the torque. So we are going to have the opportunity to see this video on and on and on, and go back and go forward and go again, trying to do it again and again. So what do I do in this kind of situation? I do distortion. We will have the opportunity to do it together. I'm planning on doing this in live class with you, so you can see how things are going. So we have the opportunity of having those weekly meeting for 2 months. So we have in one of those meetings this torque being applied, because I know this is difficult. And I'm going to teach you step by step how I do this, how I remove those. When we do the torque, we tend to create this unevenness of the arch wire, and I'm going to teach you how to eliminate this. I'm going to teach you how to eliminate the posterior torque, with 2 pliers, and this is very, very interesting because when we do that, we keep more space, less friction in the posterior segment, and this is good, and we don't apply buccal torque, because when we apply buccal crown torque on the anterior segment and we don't remove on the posterior segment, we still have this buccal crown torque being applied to posterior. So we have to eliminate that. And for that, we use this strategy that I'm going to show to you with more details in our live class, okay? And here is the torque being applied. Here we have it. Okay, good. And now we have it. Yes, again, same thing over and over again. And here, same strategy. This is the couple, moment of the couple. Again, we have the tendency of having the roll ball effect, and we're canceling the roll ball effect using this strategy of keeping the wire not used. And after that, we can use the 24 hour wear the elastics for having the correction. So first we correct, then we go on with the elastic. And here is the case again. So we correct first the inclination, and as you can see, we have here the torque being made. So I first use the TMA to having this torque, and after that I use the stainless steel. And as you can see here, the correction. Let me move back just a little bit just to show to you again. So as you can see here, we are just waiting the torque to be, okay, we're just waiting the torque to be active and to be effective. As you can see, there is a position here. There is the space between lateral and canine being created because of the torque. And patient is wearing the elastics just 10 hours a day for just this time, because I didn't want to do the retraction yet. Before doing the retraction, I needed to have the correction of the inclination. And after that, after having the correction of the inclination, yes, now I go with 24 hours of elastic being worn, okay? And then the correction, okay? So good strategy, finishing the lower arch. And here we have the correction of the class 2 position. Very fast and very precise, okay? So for now, we stop here, and then we go on again with more and more details of this phase, beautiful phase of orthodontic mechanics, which is the class 2 correction by retraction of anterior teeth and sometimes visualization of lower teeth altogether, okay? So this is very important for you to keep in mind. Each case has to be treated individually, okay? Because each case shows its specific situation and specific conditions. Hello guys, so we're back with this information on retraction in orthodontics. Again, retraction in orthodontics. Why is that so important? Because we have many of our patients that are class 2, and we have to retract to correct that class 2, because most of those patients, in most of those cases, we do the correction in maxilla, not in the mandible. So we need to do the retraction. So now I'm talking about one situation that's very common, that people think when we do the retraction using high hooks. So I use high hooks for the retraction, and I don't really pay attention in anything else, because high hooks will put the center of resistance, the line of action of the force, and the height of the center of resistance, matching the center of resistance of those teeth that I'm doing the retraction. So is that true? Does the use of high hooks guarantee torque control during retraction? So meaning I'm doing the distalization of anterior segment of upper arch, for example, to correct a class 2 relationship. And then for doing that, I'm doing the control. I think I'm controlling the movement by this high hook and the control of the inclination. Is that true? Well, I guarantee that it's not true in all those cases that you are using high hooks. But there is a specific situation that you can control better when you do the high hook for doing the retraction, but you need to have some topics associated there in that situation that I'm gonna tell you in a few slides that can assure a better control. But in all situations, high hook guarantee control, torque control during retraction. No, it doesn't, because sometimes we have the combination of a very not that stiff arch wire and not that large arch wire, meaning I have space and have play inside the slot that will do the retraction, losing inclination for a long time. So I do the retraction as I am doing, for example, for using a round wire. If you're using high hooks in round wires, it won't do the retraction with control at all. Even though you use the highest, the thicker round arch wire that there is, for example, 020 stainless steel arch wire, if you use attached to that round arch wire a high hook, it won't control at all because you don't generate the couple during the retraction. But when we are doing this using a undersized arch wire, at some point we will establish that torque, that couple. But in the beginning of the retraction, we are dealing as if we were using a round arch wire, because it won't generate the couple, because it is there is this space display and the arch is going to act at some point, but not in the beginning. So you can lose inclination even using the high hook and the high line of action of the force. Let's see how it goes. So sometimes we do that and we don't even pay attention to what we are doing, because we are told that with this kind of combination, using a high line of action of the force, trying to go in the height of the center of resistance of those anterior teeth, I may have a very good control of inclination of those anterior teeth. It's not true, as I told you before, because we have some combinations that are not that effective during this retraction. But if you're using another combination, you may have a better control in this situation, okay? So sometimes we use that and we take for granted that we are doing a very good retraction and everything is going to be right. It's wrong because of this, because we don't have, first of all, enough stiffness of that 1725, for example, it doesn't provide enough stiffness to control. And I have this play inside the slot, if I'm using this combination of undersized arch wire in a very large slot, which is the 022, 030. So we have to take care when we do the retraction using this combination. So let's see how it goes. Now we have the play, even though we are using a very stiff arch wire, sometimes we are losing inclination because of the play itself. So if I don't want to lose inclination at all, I need to provide the couple since the beginning of the retraction. So even in this situation, I may need to use a couple, a torque in the anterior segment, so I have a better control during the retraction. In this case, I'm using, for example, a 019, 022, 025 in this 022, 030 slot. In this case, I still have play of between 10 and 12 degrees. So I may lose inclination 10 to 12 degrees in this kind of situation during the retraction, even when I use high hooks. Because what's more important here is that you may remember this. I told you before, I told in previous classes that we need to have more stiffness and the ligation between those anterior teeth. It needs to be very, very precise, so we can consider those anterior teeth as one whole body. So for that, I need stiffness, I need the wire to be filling the whole slot, and I need to be very, very rigid. The ligation needs to be very rigid, so we can consider those anterior teeth as one body. In this case here, we have the play. So if we don't pay attention during the retraction that we are having since the beginning, at least contact in those 2 points, creating or generating the couple, I'm having the inclination being lost, because it will consume a little bit of loss of inclination until it establishes the couple. So this is important. I need to pay attention for in this kind of situation because I'm not having a good control if I have this combination. For that, I really need something else. What do I need? I have this loss of inclination, and now I need to go again and to regain and to reestablish a good position of anterior teeth so I can go on with the movement. I'm always saying the same thing for you. This is not the case for IPRs. Why is that? Because this is not a problem of the size of the upper and lower teeth, the combination of lower and upper teeth. So it's not a discrepancy, a tooth arch discrepancy here, and a tooth size discrepancy here either. So we need here to go again with a good inclination of anterior teeth so we can go on, we can recover this inclination and go on with the retraction. So then we can start the retraction again. So after doing the correction of anterior inclination of those anterior upper teeth, no IPR in this situation, no indication for IPR in such a situation like this. So I need to go again to the inclination, the correct inclination that I'm losing during retraction, and for that I stop doing the retraction of anterior teeth, and then I go with the torque, and after the torque, yes, we can go again with the retraction. So to recover the correct inclination and the clearance, and then again going with the retraction. Do you remember what kind of torque we need to do here in this situation? You don't need, for example, to do this height of torque. I just put it here to give the example. This is not a good torque for this situation. Here, you may use this torque to continue doing the retraction because this is kind of an active torque. Even when you're doing the retraction, you may overcome the moment of the force of retraction with a very high couple, with a very high moment generated by this magnitude of torque. We don't need it because we are not retracting in this phase here. We stop the retraction, so we stop doing this force in the posterior direction, the direction of distalization of anterior segment, and then we do the torque. So we have just a couple now. We don't have the moment of the force. We just have the moment of the couple. So if I have the moment of the couple in such situation, I have the inclination of anterior teeth being established again, okay? So it's important for us to re-establish the right inclination and then go on with the retraction. As you can see here, after that, we can have the correction of the class 2 in canines, in premolars and everything, not losing anchorage for that. So here we use the TET since the beginning for having this retraction, okay? So in this situation, we lost inclination, as you can see. But you may ask, in what kind of situation, Kleber, don't I have this kind of outcome, bad outcome? What can I use for avoiding this kind of losing of the inclination, loss of inclination? Well, we can use these high hooks, but with thicker rectangular arch wires. So we can use this combination here. You don't even need, if you are using a very stiff arch wire, you don't even need to ligate anterior and posterior segment. So in this case, we can just remove the posterior segment of the arch wire because I don't need the friction. And now I'm considering this anterior segment to be just one body. In this case here, I have a 021-25 arch wire, and I have a better control during retraction. I have more stiffness, meaning I have more control for doing the retraction without losing inclination because I'm ligating as a very stiff ligating ligature here, the anterior segment. So I'm using that anterior segment as just one whole body that's going to be moved as just one. better torque control, and then we have the expression of this torque, because we have the torque here embedded in this bracket, and we have less play, and we have control during retraction. So this is a good combination here. We have a stiffer arch wire in this slot, and we have the arch wire filling completely, almost completely the slot. And if I want to apply a torque, I can go controlling also the inclination of anterior teeth, because now we don't have the moment of the couple, or we have a very, very low moment of the couple. Why is that? Because the line of action of the force is passing at the same height of anterior segment center of resistance, the center of resistance of anterior segment, meaning when the force is passing close, meaning let's say it's exactly in the center of resistance, what's the moment that's generated during the retraction? Well, if I consider this to be a whole body, so understand why I'm spending that time explaining to you this, because for this kind of mechanics work well, we need to have those anterior teeth being all together ligated very, very rigidly. In this situation, we have one body, okay? So the line of action of the force passing through the center of resistance of this whole body will generate zero of moment of the force. So if I apply a little bit of a couple during the retraction of anterior teeth, I may also have a little bit of correction of anterior teeth, even doing this kind of retraction. You understand that? The combination here to assure that we are having the right center of rotation, meaning I'm trying to transfer the center of rotation to a position closer to the tip of those anterior teeth, I'm using here torque for having this inclination being correct. What is the difference between this condition here and the previous condition that I told you before, that I don't want to do the very, very high torque to do the retraction? Because in that situation, I need a real high torque for having this kind of inclination being corrected during the retraction. Why is that? Because the moment of the force is too high. Because the line of action of the force is not that up. It's not up. It's in the height of anterior teeth center of the crown. Okay? So in this case, I have the moment of the force being put this height far from the center of resistance. So I have the moment. And now I have to have a great moment of the couple, a very big moment of the couple, to do the correction of inclination at the same time and doing the retraction. So for that, I really need a tremendous torque for that. And I don't want that to happen. But do you see that in this case here, we don't have a moment of the force of retraction? So not having this moment, I have just a moment of the couple, meaning I don't need to apply that high torque, because just a little torque may do this kind of inclination, may achieve that kind of inclination that we want. So we have different situations. Always remember this. You need to understand the system of forces that's being applied in each situation. In this case here, we have zero moment of the force of the retraction, and if I don't want to have a moment of the couple, it will be equal. We have no moment of the couple and no moment of the force of retraction, meaning I'm going to have a translation. So if I want to have a moment of the couple and no moment of the force of retraction, I may have this situation. But in this case, the moment of the couple, meaning the torque that you are applying in the anterior segment, it doesn't need to be that high, because it will not counteract a moment of the force that doesn't exist, because of the line of action of the force being applied in the height of the center of resistance of those anterior teeth. And in addition to that, I told you before, I have a whole body, because I'm applying a good combination of a stiff arch wire, no play, because maybe a little bit of an inclination of anterior teeth, and I'm ligating that very rigidly. So this situation is very good when we don't want to apply the torque of retraction, okay? So now we have the very good combination of this movement. So as you can see here, I have the sequence of arch wire being used, and when I reach a 21, 25, look at this size of this arch wire here. It's very, very rigid. It's very, very thick. So in this case, specifically in this case, I can use this kind of bracket, ceramic bracket. Why is that? Because I'm not applying a torque. I'm not applying a real torque here. So I'm not twisting the wire so it can, when it goes inside the slot, it may break the bracket, because we don't need, in most of the cases, if the teeth are well positioned and we reached the 021, 025 arch wire, it will read, the bracket will read its prescription. So it will be well positioned. So I don't even, in this case, need to use torque in most of the cases. So I may use here this kind of concept in rectangular arch wire, very thick in a rectangular arch wire in ceramic slots. So as you can see, the line of action of the force is high, okay? Was not that high that I expected, so I lost a little bit of inclination, but it could be managed during the retraction. Then I have this beautiful loop to do the mesialization of the molar, so controlling it tridimensionally, okay? Here it is. And here we have the after and pre and post treatment, okay? So you can compare. We managed to do the retraction keeping the inclination. What we see most in this situation of this kind of overjet is that during the retraction, it's very common to lose inclination. So using this concept here, you may do the retraction with less tendency of losing inclination, okay? Let's see what's going on in this situation here. Another case, this is one situation of a very, very big overjet, and I use the concept of a high hook. But let's see how it goes in this situation, how it went in this situation, okay? So we'll go the sequence of arch wire, using here elastics, and we know that elastics have this bad side effect sometimes, because we understand that we have vertical and horizontal effects of the elastic, so I need to understand all those components, okay? So in this case, one bad component of the force is in the lower arch, because those anterior teeth, they were already protruded and very inclined, and very, very highly inclined, okay? So I needed to control that, and I didn't control enough using elastic. So there's a very old case of mine in which I used elastic in that situation. It's not common to use that. In my case, that I use elastics having this kind of inclination of anterior lower teeth, because of the action of the elastic in those anterior lower teeth that will protrude them a little bit more. So I avoid doing this kind of class 2 elastics in this situation, okay? But I did it, and as you can see, I didn't manage to control very well the inclination of lower anterior teeth, and I have this proclination of those anterior teeth because it was my fault, because I used for a long time the class 2 elastics. So I avoid doing that today, okay? So let's see before and after use of elastics in the end of retraction. And here we go with the inclination of anterior teeth, increasing the inclination of anterior lower teeth by means of the elastics, and because I need to solve the crowding. And now let's see how it goes in this situation. I used a very high hook for controlling the retraction, and in this case I learned another lesson about this kind of retraction with high hooks. If we are using, and here I am using, a very, very thick arch wire in the anterior segment, and as I told you before, I do the grinding of the posterior segment, so I decrease the friction in that segment. I just rely on this kind of combination and I go with my retraction. But what happens in this situation? Look at this. Now it's touching, anterior and lower and upper incisors. So they are contacting here, avoiding further retraction for having the control, for having the correction of the class 2. So now I have the contact and I have to deal with it. So as you can see here, we have a very, very difficult situation. What happened during the retraction? And this is my lesson. This is the lesson I learned with this case. I can't do that using this kind of combination here. This arch wire, even though it's steep, a very, very thick arch wire, it has a problem when it's inserted in this kind of slot. I told you before about it, but it's important for you to see in this case. So what happens using this kind of slot? We have this situation here. So we have sometimes it depends on the shape of the bracket. You have a shorter wall up or down in the up or the lower, the upper or lower walls of the slot. And so when we have that, we may don't have a good control of the torque during retraction. So what happens in this situation is something like this. If I need to do the control of the torque in this situation, I may have this very bad outcome. What happens here? So I place a torque, but in this case, first of all, I have more play because of the shape of this bracket. We have a shorter wall in the upper and a normal, regular or something close to it, a wall in the lower wall of this bracket. So now we have, when we establish a couple here, now we have a decreased distance comparing to a conventional bracket between those two forces. So the couple here is a different couple. We have two problems. The first is the play, which is bigger. And the second one is the couple that is going to be generated, because we know that the moment of the couple is measured when we multiply the force that we are applying by the distance between the two forces. So in this case, we have a higher distance, and in the second situation here with a interactive self-ligating bracket, we have more play and we have less moment of the couple because we have less distance. And so this is very bad. This is the lesson that I learned in this kind of composition here. We have more play in this kind of bracket, and we have less torque control. So I don't use it anymore. So we are using a high hook for that, but the play is huge. And when it establishes the two forces, the couple, this is a low couple. So it won't control the retraction in such a way as the conventional bracket would control. So I really have problems. I have real problems when I use this combination. So in this case, the wire needs to have a higher real torque, a bigger real torque, and I have a decreased couple comparing to the conventional bracket. So sometimes the relative torque is really not enough. So I need to do more for this kind of combination. So take care. As you can see, yes, we managed to finish everything, but with much more work to do, okay? So this is the lesson in this segment. We really need to pay attention to everything about this kind of combination. Not just using high hooks. We need to understand that the high hooks, in this case, the high hooks may provide, if you're using the right combination, the right torque, but sometimes it won't, okay? So very important for us to understand that. Take care. Don't do that and take for granted that you are going to control the inclination. Sometimes you are not. So you have to have this good combination of a thick arch wire, very rigid ligation, and we have this possibility of doing the correction of the overjet with a good control of the inclination. Okay? Hello guys, so we're back with the same topic here, torque and retraction. torque and retraction, as I told you before, is very important for us because we do this daily, we do this a lot in our practice, and we can do that by sliding mechanics, class 2 elastics, retraction, distalization, then retraction. We can use loops for that and other kind of devices that we can use for correcting the class 2, but for doing the retraction, those things are the most important for us. Let's go now with the retraction of the entire arch at the same time. I'm giving you the example of this situation here, in which I was doing the decompensation of this class 3. This patient, she was treated before in a previous treatment, orthodontic treatment, for compensation of the class 3 and the asymmetry. So in this case, the asymmetry of this patient was her chief complaint, and she wasn't satisfied with the outcome of the previous treatment, not because of the treatment itself, because as you can see here, we have a good relationship between upper and lower arches with a good intercuspation. But the problem is, this is something that I always say to my students, we need to understand the chief complaint of our patient. So we have to address the problem in the patient's view, not our view. So now our point of view is important for us, but for the patient, they want to have that problem corrected. In this case, the asymmetry was the main problem that this patient saw in her face. And she wasn't satisfied, not because of the occlusion, as I told you, but because she's still asymmetric. So I wanted to do the opposite now. I told her that for doing the treatment, I would need to do the preparation for orthodontic surgery. Otherwise, the treatment wouldn't be good for her because it wouldn't address the main problem, the asymmetry. So I needed to go now against the camouflage. I needed to remove the camouflage in order to prepare the case for orthodontic surgery, meaning in the upper arch, because this patient was class 3, I needed to go backwards because I wanted to go distal with anterior segment of the upper arch, so I could do the decompensation. And the lower arch, I wanted to go forward in the lower arch. So there's another thing that I want to do. It's the correction, the uprighting of anterior segment, both upper and lower arches. In this case, I used TAD for that. In the beginning, I used the TAD for doing the retraction of the whole arch at the same time. And as you can see here, we have the first appointment doing the boning of upper arch. I started doing the retraction with class 2 elastics and retraction of the canine using the TAD as anchorage. Why did I do that? Because I wasn't concerned about losing the lower anterior face height being increased because of the vertical component of this class 2 elastic. So in this case here, for me it wasn't a problem for doing the retraction with the extrusion of lower molars. Why is that? Because in this situation it was a surgical case, so it would be treated surgically with this decompensation. Okay. So let's move on. In the first appointment, bonding the upper arch, I started with the class 2 elastics plus the retraction of the canine using for that coil spring. And I stretched the coil spring for doing the retraction. And then I needed to go like this. Look how we can deal with this kind of situation. With this, we can be very, very precise in our retraction, yes, but we can also be very creative when we start with the kind of treatment like this. So I wanted since the beginning to do the compensation. So the lower arch going forward is what I wanted to happen. And then I used for that the class 2 elastic. So I wanted to have this kind of the compensation. And since I wasn't concerned about increasing lower anterior face height, in this case, the class 2 elastics was a very good choice for this kind of treatment. As you can see here, I'm using this hook, that sliding hook, for doing the retraction of the canine. Now I'm already using a rectangular arch wire in this upper arch, and then I did the retraction of the upper arch itself, using for that the coil spring attached to this hook welded to the arch wire. So as you can see, we have two retractions being made at the same time here, because I wasn't afraid, I wasn't concerned about the increasing of lower anterior face height. I used the elastic, and I tried to use the elastic during the retraction of the canine, and at the same time, when I had this space between canine and lateral incisor being created, then I used the retraction of the whole anterior segment at the same time. So I used for that what? The hook and the torque. I use torque here. Why is that? Because the line of action of the force is below the center of resistance of those four anterior teeth. So for that, I needed to use the torque for controlling it. Otherwise, I would have a very high, very fast inclination lost. And so I would do this very fast, and I didn't want that to happen. So I would try to do this in a more controllable manner, using for that a little bit of a torque. In this case, a positive crown torque, positive relative crown torque, meaning I wanted to go forward because I knew that I was losing very fast the inclination of anterior teeth. So remember, if we understand the side effect, we can go accept the side effect, or we can go against the side effect, using for that the torque, the couple of the moment in this case. In this case, after doing the retraction, as you can see, and correcting the inclination of anterior teeth and lower anterior teeth, lower and upper arch both, we needed to do now the, let's say, those arches may be very precisely put together. So I need to do this coordination of the arch wire. So because I needed to do the surgery in a very precise position of both upper and lower. So in this case, I did this with a torque to control the posterior torque to control inclination, posterior lower torque to control inclination also, because the previous treatment removed this inclination doing the compensation. Now I wanted to remove the compensation for preparing to orthodontic surgery. So retraction being made, and this arch in the same moment, meaning I'm not doing extraction to do the retraction, I'm doing the retraction in one whole body at the same time. So because I did this kind of retraction using one line of action of the force, only one line of action of the force, I also needed to use for that this concept of torque. Why I'm telling you this now? Because there is a difference. We are going to see that there is a difference when we apply other kind of retraction, meaning, for example, using a segmented arch wire. For that, we don't even need to apply torque. We can apply the concept in the loop, inside the loop. Of course, this is not part of the loop class here, but I think I need to clarify some things about this option in the next cases, okay? In this case specifically, sliding mechanics, using sliding mechanics for that, I'm also using here a torque because there is a moment created here. Do you agree with me? Look at this image here. You see that we have a stretched coil spring, and this coil spring is representing the line of action of the force itself. So when I use this coil spring in this height, at this height, we are creating here a moment in the anterior segment and in the posterior segment also, because I'm retracting the whole upper arch in one piece. In this case, I need to consider, if I'm using a very, very thick arch wire, I need to consider the center of resistance of the maxilla, which is located probably in between premolars at a height of 6 millimeters approximately in this healthy periodontal environment, okay? So in this case, the retraction being made doesn't relieve us from doing the retraction with torque. It doesn't, in our case, in this case specifically, I'm doing the retraction trying to compensate the losing of inclination with the torque. So this is very important. One line of action of the force below the center of resistance. In this case, we need to do the torque because we are going to lose inclination. We are going to lose inclination of anterior teeth because the whole arch is going to do like this, okay? Rotating, meaning we go downwards and we go losing inclination on anterior teeth, and we go upwards when we do this kind of line of action of the force below the center of resistance. So we're doing this, and for that I need to apply the torque for controlling it, okay? And here we go again, retracting again, and as you can see now we have a good inclination of both anterior, upper and lower incisors, and now we have removed the inclination of posterior teeth also, and now we're doing the retraction, finishing the control of inclination and rotation of the canine here. So as you can see, sometimes we have this freedom to go back and use loops and use anything we need to use, any device we need to use to control some things that we left behind. So in this case, there was still a rotation of this canine, and then I went back and used for that 2 vertical loops for having the derotation of this canine here. So now we are prepared for surgery, and then I was able to put inside the slot the rectangular arch wire, and I used now the hooks for the surgery, and then the patient's prepared for surgery. So we did the decompensation by using the retraction of the upper arch wire, upper arch in one piece all together, doing the retraction using TED. So one line of action, remember, one line of action of the force, even when I don't do extractions to do the retraction, I need to understand what is going to happen to that whole arch. Meaning, in this case, this is what's going to happen, anterior and posterior this way. So because the line of action of the force is single line of action below the center of resistance of those teeth together. So torque was necessary, okay? And here we have, after surgery, again, we need torque now to finish the control of anterior segment, to finish the control of posterior segment, so everything's together here. Arch with torque, with bands, elastics, everything together to do the finishing. We're going to deal with some strategies to finish better your cases, and you're going to understand that in this phase, everything is possible. Loops, torques, elastics, bands, everything, okay? So here we have it, finishing the case. 1 month later, I have now, and then the deboning phase, okay? So now we have it, the phases. As you can see, the entire arch was retracted as one piece, and we went all together backwards, okay, because we used this retraction using TEDs for that. Of course, we can't do the same thing when we use interradicular, interroot mini implant, okay? So if I put mini implant between 2 roots, we can't do that because we're going to throw the root against the mini implant. In this case, this patient, we started with IZCs, then we moved to use the mini plates. Why? Because the IZCs were touching the molar when it went forward. So we understood that, we stuck a little bit, and then it wasn't going forward. And when we took this CBCT, we understood that there was a contact between the upper molar and the mini implant, the IZC. So we changed strategy using mini plates for that. So now we could, then we could do the retraction without anything avoiding it, okay? So here we go, and as you can see, another case. So again, I call your attention for this specific situation here. What's happening here? I'm using a mini plate for this, but I'm not using just a high hook. If I use just this high hook for that, I could consider not using a torque for doing the retraction, but I was using just to increase the force of retraction of the whole arch itself. In one piece, I'm using two loops, two coil springs for that, stretched coil springs for doing the retraction. So I need to understand the resultant force. As you can see here, we managed to control this, to do this expansion of the upper arch and everything. But the most important thing for us now is to understand that even when we use a high hook, if we are applying, for example, this concept here of two line of action of the force, I need to see the resultant force. We saw that before. So now we see that the resultant force is below the center of resistance of those upper teeth. And for that, because of that, we needed to use the torque. So we did the torque since the beginning, and for doing the retraction and controlling it, because I have this two line of action of the force, I needed to do the torque for having the control. So after that, just finishing, we needed to increase the size of the lateral incisor because she had this tooth size discrepancy, okay? And here we have before and after. You can see a beautiful smile now with this curve, very beautiful curve, and good torque of anterior teeth. So doing the retraction, if you're using high hook, it won't guarantee for you that you don't need to do the torque, because the torque is always necessary when we lose inclination. So remember, I'm now having the line of action of the force below the center of resistance. In this case, I'm considering the center of resistance of the whole upper arch, because in this case, I'm using for doing the retraction a thick arch wire, and we talked about that before. So in this case, I need to understand that I'm having inclination loss, okay? So I need to do the torque. Let's move on. There is another situation in which I can apply the retraction during, for example, extraction in the upper arch, and using for that not torque. How can I deal with this? Now, I don't want to use torque, and I want to use another concept. And I don't want neither to have friction. So what can I do to avoid friction and not doing the torque? What can I do? Yes, I can apply a high hook for that, or I can use another kind of concept, which is using loops, because the loop can apply the torque, can apply the couple, and applying this couple against the moment of the force, this couple will generate a good moment to counteract the moment of the force. And we don't have, in this case, you see this case of Maria, we don't have a friction because we don't have sliding mechanics. Here we have Maria's case. And just for you to understand, it's very interesting this case, because she was treated before. A previous orthodontic treatment managed to do the good intercuspation, yes, but she was still complaining about the inclination of anterior teeth. She's an orthodontist, and about the exposure, the gummy smile. So again, same thing that we talked before. Sometimes we do a very good treatment, but we don't address patient's teeth complaints. So in this case, we are not satisfying patient's complaint, and so this is for the patient point of view. At the patient point of view, it's something that's not successful. So, but remember, always try to understand your patient's chief complaint, because it needs to be addressed. Otherwise, you're going to fail in your treatment, even though sometimes you do very good treatment with very good intercuspation, but for patient, it's not successful because his or her chief complaint wasn't addressed. Well, okay. So in this case, Maria had this biprotrusion, and we plan to do this orthodontic preparation for orthodontic surgery. Let me call your attention for something here that's very important. We are talking all the time here about anticipation. Anticipation meaning I'm thinking forward. What's going to happen during orthodontic treatment in this case? What is good for the case in the finishing of this case, and what's bad? So if I do, for example, in this case, keeping the protrusion, and I do the impaction of the maxilla, and she was planning to do the impaction of the anterior segment more than posterior, because of the occlusal plane. So my surgeon told me, Kleber, I'm going to do here the impaction of the maxilla, but it is a differential impaction. I'm not doing the impaction in a whole body, look like a translation. I'm doing the impaction of anterior segment more than posterior. So what's going to happen when you do the anterior segment, more in the anterior segment, more intrusion, more impaction than in the posterior? So this is what was planned, and she was already presenting this kind of protrusion by protrusion. And what was going to happen because of the treatment plan of the surgeon was an impaction with this inclination being increased. Look at that. Anterior segment would be impacted more than posterior, and the inclination of those anterior teeth would be increased, meaning it was already high inclination, a big inclination of anterior teeth. So if I let that happen without doing the retraction prior to the surgery, that anterior segment would trap the lip in between the upper incisor and the nasal spine. And you would have a very, very bad outcome for the smile. So in this situation, it was mandatory to do the extraction and the retraction. Yes, you can do that during surgery, but you are going to have more instability and everything. So it's better to do that by means of orthodontic treatment, not the surgery itself. Yes, sometimes the surgeon can do the extraction of the premolar and this three-piece segmentation of the maxilla and do the inclination, the correction of the inclination during surgery. Yes, it's possible, but it will apply more instability for the treatment. So we prefer to do that by means of orthodontic treatment. And in this case, as you can see, we can see by the numbers here, we can see by the pre-visualization of the surgery using the Dolphin appliance, the Dolphin software. I'm sorry for the delay here. For the Dolphin software, and we saw that this could happen, and this could be very bad for the inclination of anterior segment. So we did the extraction. We ran the sequence of arch wire as we do always, and when we reached the rectangular stainless steel arch wire, we did the extraction. And now you can see that we are doing the retraction using another device. We are not using sliding mechanics for that. We are using the TADs and direct anchorage to do the retraction. Now we have here a compressing loop, a delta loop, and in the tip of this delta loop, which is attached to a cross tube, we can apply a counter moment regarding the moment of the force. It is counteracting the moment of the couple here, is counteracting the moment of the force. Yes, this is something that we are not still studying here, but we are going to study it a little bit further. But I need for you to understand that we can just use this kind of device to avoid, first, the friction, because the friction is too high, and this composition between stainless steel and ceramic braces. And we are avoiding also the need for doing torque. So here we have a very good retraction being very fast, okay? Because we don't have the restriction of the friction acting here. And we also have here the torque being applied. So let me call your attention for another thing here about this thing here. What is this? This is the TAD that was in this position being removed in this session, and now we are using a different approach for that. Yeah, here again without friction, because this is a loop being compressed, and now we're losing anchorage. We're going to explain everything when we deal with the loops in orthodontics in our live class. But in this case here, in our classes, may be recorded or live, but we're going to apply this concept and discuss everything about loops in another part of our course. But I need you to understand this. This is important. What I'm saying to you here is this. Look at this. I'm removing the TAD here because we don't need to go with the TAD from the beginning to the end. Why not? Because we don't have enough room, enough space to do the retraction, especially in the lower arch, in the lower segment of the lower arch. Why is that? Because our symphyses here are very, very, very narrow. We don't have enough space to do the retraction, for example, of 8 millimeters. So if you are applying this concept of doing extraction, using very rigid arch wire for doing the retraction, and using high hooks, you're going to have this kind of movement, throwing your anterior root outside the bone. Very, very bad. Very, very bad. So take care. We need to understand that this concept here is going to be very dangerous for your roots. So we can just remove the TED and we can lose anchorage without the need of going from the beginning to the end with the TED and the retraction. Just that. Pay attention. You see that a lot in the internet. You see that a lot in social media. So I'm having here the retraction being made, and just for a very, very fast explanation, I'm using this drawing for you. So we did that using the TED, using the cross tube, and then I put here a resin to the flowable resin to secure the cross tube, and I'm using this beautiful loop that you're going to learn about, everything about it in other classes, not now, but just for you to understand. We use the concept of the 6 geometry to have just moment without vertical component, and then I'm doing the compressing of this loop, and now I have the control of the moment of retraction, of the force of retraction, because I applied the couple to this segment here, to this little segment here, the cross tube itself. Okay, so retracting with control, and I'm gonna show you that's not that beautiful, that's not that plain and simple, but for now, stay with it. This is another option to avoid having the retraction with inclination being lost. Okay, so remember, now I'm not having just one line of action of the force. Now I'm applying the wise way to do this. I'm applying a counter moment, okay? So this counter moment is controlling the inclination of anterior teeth. As you can see, Maria is ready for surgery, and like 1 month after surgery, you can see that we have now a good inclination of anterior teeth, both upper and lower anterior teeth, and we are now losing inclination, losing anchorage. And this is something that's interesting. Sometimes we don't need to apply just the fancy concepts for that. This is a good student of mine, ex-student of mine of our classes, and she didn't want to go again with the TEDs in anterior segment to lose anchorage. And she asked me, Prof, can I use another kind of device for losing anchorage because I don't want TED anymore? Yes, you can. You can use face mask for that with orthodontic force. And she said, yes, I go for it. Come here. Give me the mask and I'll use it. And she did really use this mask, and we are now losing anchorage, not doing just a retraction, but losing anchorage. And here we have this anchorage being lost, as you can see. And after that, we have Maria's occlusion. And here it is, before and after the debonding. And here we have her smile, and here we have her profile. Okay, so retraction can be made in by different kind of approaches. We can apply the torque, we can apply the high hooks, but using that kind of concept, or we can apply this kind of concept using the retraction, the force of retraction, and the moment of the couple against the moment of the retraction. We're going to learn about it in another part of our course, okay?